We have one, but he's just here to watch. He's not going to speak.
June
Yes.
coming up.
Derek, did that work?
call the meeting to order. It's about 8:11. Thank you for your patience waiting for us. We just have some situation back up over the parking garage. I want to wait for everybody to come in before we get started. We do have, I'd like to invite Angela for the opening. Prayer and pledge, please. Good morning.
Good morning. Let us pray. Gracious God, thank you for entrusting us with the stewardship of the great mission at JPS. Guide our discussions to be full of wisdom and integrity. May we listen, engage, and focus on what best serves our patients, our team members, and our community. Let this work demonstrate that we use our resources wisely and remain dedicated to improving the lives of those we serve. Amen. Please stand with me for the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, Angela. Welcome, Glenn.
Mr. Chairman, before we get started, can we sing happy birthday to Demetria? Okay, on the count of three, we will all sing happy birthday to Demetria. It's a 1, it's a 2, it's a 3. Happy birthday to you. Happy birthday to you. Happy birthday, dear Demetria. Happy birthday to you.
And many more.
Had I known in advance, I would have had Dr. Elliott, who is so eloquent in how she sings, and she would have bellowed it throughout Tarrant County. But happy birthday, Demetria.
New way of saying let's get loud. And I was informed that we don't have any citizen addressing the board, so we're going to move to the next section, which is the approval of the minutes for the May 14, 2026.
Move approval.
Second. All in favor, signify aye.
Aye.
Any opposed? Motion passed. The first one is the board chair report. We have a board chair report, but I have prepared something for today. Before we begin today's board meeting for our FY 2027 budget retreat, I want to thank Dr. Duncan, Kim, and the executive leadership team and all the staff across JPS Health Network for their tireless work and dedication. A tremendous amount of effort goes into caring for our patients every day, and into preparing the plans and information that will guide our organization into the future. Today we have two important responsibilities. First, our regular board meeting, where we continue to work with our governance and oversight. Second, our FY 27 budget retreat, which will be led by our Finance Planning and Investment Committee Chair, Dustin, in a little bit. I want to thank Dustin and the FP&I committee for their leadership and the time they have invested in this process. As we begin, I want to remind all of us why we're here. We are here to serve. We're here to serve the residents of Tarrant County, especially those who depend on JPS for care, hope, and healing. We're here to be a good steward of the resource entrusted to us by our community. We're here to ensure that JPS remains strong, financially sound, and prepared to meet the healthcare needs of today and tomorrow. Today's discussion are not simply about budget, building, or numbers. Behind every line item is a patient, a family, a caregiver, and a community that relies on us. I appreciate the commitment and the partnership of my fellow board members, management, physicians, nurses, and staff. Together, let us remain focused on our mission, thoughtful in our decision, and and always mindful of those we are privileged to serve. Thank you, and let's begin our meeting. The next one is, do you have anything for
No, she's.
just the medical staff? It's going to be a short meeting today. So we're going to have a report on our staff committee requiring discussion, updates, deliberation, and approval. Dr. Fowler?
Good morning. And happy birthday, Demetria. I'm up to 4 now here of people that were working at JPS on their birthday, and I was like, you can take your birthday off, and I'm up to 4 that said, no, I was born at JPS. So that's why I'm working on the birthday there. So happy birthday. So greetings. I'm not your president of medical staff, your president-elect, Dr. Kirby. Hopefully he's on a great cruise somewhere at this. The rumor she has it. Really no controversy coming from the Med Exec Committee. We've got approval for reappointments and credentialing appointments in your packet, I think. No real controversy from that. So that's really our report. Y'all are all welcome to visit our Med Exec Committee meetings. Those that have, we appreciate it. And you can kind of see how it's done on the other side. So, but that's all I have for my report.
Thank you, Dr. Fowler, for your leadership there. The next one is,
So we need to
We need approval.
we need approval.
Move to approve the appointments.
Second.
All in favor, signify aye.
Aye.
Opposed? Motion passed. Next item is the FP&I committee meeting. Dustin, Austin?
Thank you, Mr. Chairman. So at our May 28th Finance Planning and Investment Committee meeting, we spent quite a bit of time talking about the master facility plans, and want to continue to invite everyone here to those meetings, because there's a lot of good in-depth conversation of those projects and where we stand. So kind of a brief overview. The Health Center for Women construction is underway. That's scheduled to go live December of this year. That's in our first floor of our parking garage. So that's well underway and moving along nicely. The medical outpatient building, you'll see the cranes out there. So that's well underway itself. That project's on track for April 29th. So moving along nicely. The CUP, which is a central utility plant, is development's complete and finalizing city requirements to obtain permits. That is near where we did the groundbreaking, and will provide future power needs for those towers. I saw an email come across. Obviously, we broke ground on the new tower, and will be an opportunity to preview some of the selections at some upcoming meetings. So everything's well underway. Things are moving along nicely on the master facility plan. As far as finance updates, Fitch S&P confirmed AA ratings. KDRA confirmed AAA ratings. That was finalized at the end of April. Obviously, we have a retreat today, so appreciate everyone being here in support. As far as income goes, income for the month totaled $14.1 million, which exceeded budget by $2.7 million. So to the good. It was primarily driven with activity related to CHIRP, FISH, and LPPF funding. The year-to-date net income performance totaled $103 million, exceeding budget by $27.6 million. Those were driven by inpatient volumes that remained below plan, offset by observation activity above plan. The patient service revenue was slightly below budget due to unfavorable payer mix, while Medicaid and supplemental funding, CHIRP, LPPF, were all favorable. The operation expenses were slightly above budget. That was being driven by the pharmacy assistance and vaccine for children programs. Labor overall remained favorable, supported by workforce optimization and FTEs below budget. Back to the master facility plan, just a reminder, our total budget's right at $2.5 billion, of which $953 million has been committed. That leaves a remaining budget of $1.49 billion. I don't have the exact cash to date, but of that $2.5 billion approximately, we only spent about $300 million cash to date. So the we've got a ways to go. Key performance ratios were reviewed, of which 9 of 12 metrics exceeded target. The committee approved the the April 2026 unaudited financial report. As far as contracts, 10 contracts were presented and approved. And Mr. Chairman, that was my update for finance.
Thank you, sir. Any questions for Dustin? I don't think we need approval for that, right? The next item on the agenda is the item to be approved on the consent agenda. So we have 9 items on there, with item D, E, and F, exemption to bid. May I have a motion or any question or motion approval?
Second.
All in favor, signify aye.
Aye.
Any opposed? Motion passed. And then we are now moving to the next section of our agenda, which is the budget retreat. Before we begin that section, I want to thank Dr. Duncan, Kim, and the executive team for the tremendous amount of work that has gone into this preparing for these materials. Developing a budget for an organization this size and complexity of JPS is no small undertaking. And I want to recognize the many people throughout the organization whose efforts are reflected in what we will review today. I also want to thank Dustin, Chair of our Finance Planning Investment Committee, and Alan, our Board Secretary, both of whom joined me in meeting with Kim last week to review the material and better understand the assumption and priority ahead of today's retreat, or should I call it the strategic planning session or workshop. That meeting was not intended to make decisions or predetermine any outcomes, but rather to help us frame a more thoughtful and productive discussion for the entire board. For some of our newer board members attending their first budget workshop, today's session is intended to provide context, perspective, and opportunity to ask questions. This is not simply a review of numbers on the page. The budget represents our priorities, our value, and ultimately our commitment to the people we serve. As board members, our role is not managing the organization. Our responsibility is governance. We are here to ask questions, understand risks, challenge assumptions when appropriate, and ensure that the resources entrusted to JPS are aligned with our mission and used wisely. Behind every line item is a patient waiting for care, a family depending on us, a nurse caring for someone in need, a physician delivering treatment, an employee working every day to fulfill our mission. Our responsibility is to ensure that JPS remains strong, financially sound, and prepared not only for coming years, but for the years ahead. As we work through today's presentation, I encourage everyone, especially a newer board member, to ask questions. No question is too small. The purpose of this retreat is understanding. Healthy discussion leads to better decisions. Our community has placed its trust in JPS for generations. Stewardship of that trust is one of our greatest responsibilities. Our challenge is not survival, our challenge is execution. We have a strong balance sheet, a transformational master facility plan underway, and a leadership team committed to continuous improvement. Today's discussion is about ensuring that our resource, priorities, and strategic remain aligned so JPS continue to fulfill its mission for the residents of Tarrant County and for many years to come. So thank you, Kim, Dustin, Alan, and the Finance Planning and Investment Committee, and the entire leadership team for the work that has brought us to this point. With that, I will turn it over to Dustin. Thank you, Dustin.
Thank you, Mr. Chairman, and once again, appreciate you, Mr. Chairman, and Al and Dimitri, and everyone that's involved in this, and JPS staff, Kim, CEO Dr. Duncan, and all the folks that have spent a lot of time and effort here today. So I've just got a few opening remarks. Last week, DT, Al and I had the opportunity to review the materials that we're going to see today, and felt that they provided a strong foundation for today's discussion. Just want to remind everyone that today's discussion it's not about approving a budget, making policy decisions, or revisiting our long-term strategy. It's rather an opportunity to understand the assumptions, considerations that will shape the 2027 budget. So before we evaluate the budget, we need to understand the assumptions that built it. The budget is just a roadmap. Today's discussion is an understanding of the assumptions used to draw that map. We've got newer board members. We've got some long-serving board members. So today's discussion provides an opportunity to, for all of us to strengthen our understanding of the assumptions behind behind the budget and benefit from the different perspectives around the table. Understanding these assumptions helps us fulfill the governance responsibilities and prepares us for the budget decision later this month. Healthcare is ultimately a people business. Every volume projection, staffing plan, funding source, and capital investments ultimately connects back to the patients, families, and the communities that we serve. But today, I just encourage everyone to engage in the discussions. With that, I'm going to turn this over to Dr. Duncan. So, thank you, Dr. Duncan.
Okay, I think I need the, okay, I was going to, okay. Alan asked that we not call this a budget retreat, but that we call this actually an all-day meeting. But I want you to know that this is the safety net definition of a budget retreat, and it is fiscally responsible, okay? We are making good use of our taxpayer dollars, and so.
They told me the retreat was coming. I wonder where we're going. Is it a hotel? Somewhere? I'm all excited. Where's the meeting going to be? Here.
Welcome, welcome to a county entity and the district hospital. So again, I want to welcome everyone, and I want to thank you, Mr. Chairman, both of our chairmen here, and the board for the opportunity for JPS and the board to come together today for the fiscal year 2027 annual budget retreat. We appreciate your partnership, and we really look forward to feedback, meaningful discussion, and more importantly, we need your guidance. It is our hope that you will gain a better understanding and a greater appreciation of the complex environment we operate within. And as healthcare uncertainty increases, together we will need to create stability for our community. I want to take this time to thank the incredible executive and JPS team members, our physicians, our staff members that serve alongside me every day. Kim, I want to extend my sincere appreciation to your leadership and to your finance team. I know how grueling this has been, and you've done an amazing job. Preparing a budget of this scale and complexity requires months of meetings, collaboration, and Kim and I will tell you some really difficult decisions that we had to make. JPS Board of Managers, we are confident that following today's budget retreat and the future presentation of the final budget, the board and the staff will deliver a fiscally responsible and strategically aligned budget to our community. Our mission defines why we exist and what our purpose is. Our mission holds us accountable to this community. Our mission is to transform healthcare delivery for the communities we serve. Before Kim shares the budget process and assumptions, it is really important for us to understand, and I go through this every year, but it's important for us to understand the current healthcare environment in which this budget is being developed and the challenging environment that healthcare is currently facing. I don't think any of us would argue that healthcare is undergoing some significant changes and transformation. It has been truly dynamic. It has been difficult. So what are those external forces and challenges that all of us will need to understand as we have our discussion today? Financial pressures, labor expenses, the largest part of our expenses, continue to go up. Pharmaceutical and supply costs, the second biggest percentage of our expenses, continue to go up. And you will hear from Charlie and Stephen today how they plan to manage through this as they help to set our budget. This is all being compounded by inflation, by tariffs, and more importantly, by decrease in reimbursements. Uncertainty in government funding, and Mike Spivey is here with us today. He's been with us for the last several years. He's going to give us an opportunity to see what he is seeing in his crystal ball. But the Medicaid changes over the last several years have been unending, difficult to keep up with. And there are upcoming work requirements that will also go into effect. So we're always navigating through these Medicaid changes. Supplemental payments that we depend on and state-directed payment programs are more at risk than ever before. There's growth in Texas in our population. Texas leads with the number of uninsured persons because we opted not to expand Medicaid. And so there will be growth in uninsured. We are still navigating through some of the premium increases with the marketplace plans, and we expect that there will continue to be some coverage losses. And then this is all overridden by the affordability bubble and crisis that we all are currently experiencing. The needs for mental health and substance abuse services continue to grow. Workforce challenges will continue to, that we'll be faced with. It's expected that a large number of baby boomers, will be exiting the workplace. And so it's going to be a challenge, and we're going to have to resource recruitment and retention. We are going to have to resource leadership succession and leadership development. We will have to develop the new leaders. And as we rapidly adopt new technologies, we will need new skill sets here, and we will need to create strategies to reskill our current employees to be ready to meet those future specialized needs. Healthcare can no longer turn its back on the emerging technologies. There are so many advances in technology, and AI is here. With that comes increasing threats of cybersecurity. And so you'll see in our budget that we are having to resource our teams, our skill set, and ensure that we are keeping our information safe. There are shifts to community-based care. This is coming from CMS, it's coming from our payers, but more importantly, it's coming from our communities. They want care closer to their homes. And so we will need to expand our virtual footprint, look at remote patient monitoring, even hospital in the home care that's starting to get some reimbursement. And so we will need to fund and resource that. And then the big thing that we're facing is really our capital projects and our capital investment. But you can see across the medical district here, there's cranes everywhere. You go to Dallas, Children's Hospital, Parkland even is starting some new construction again. This is ongoing as we have to really be prepared to meet the increased need and provide the access. And we have a lot of new construction projects. It's historical for JPS, the amount of growth and projects that we have. But at the same time, we have to take care of our aging infrastructure. And we have to resource and modernize and optimize some of our aging infrastructure. And then the needle that keeps moving on the interest rates around our investments continue to confront us. While these pressures affect many healthcare organizations, they do have a disproportionate impact on JPS. JPS is Tarrant County's safety net hospital. And as a hospital district, we are governed by Chapter 281 of the Texas Health and Safety Code, which mandates that we provide aid and care for the indigent and needy of Tarrant County. And we need to keep that out in front of us. We are mandated to do this. In addition, JPS serves the largest proportion of the uninsured population because of our mandate and because of our mission. And I can tell you, there is no other hospital system here in Tarrant County who is competing for that market share of uninsured patients. I have tried to share that. We're caring for a growing community. JPS is the largest provider of behavioral health, which is great because there are increasing behavioral and mental health and substance abuse needs. But board members, remember that reimbursement for our behavioral health services does not cover our cost of behavioral health. We have complex revenue sources. Kim will share that. Mike Spivey will share that. And as I mentioned before, we're undergoing a historical capital project. Those are all pressures on JPS that are going on now. So healthcare systems, as I said, all healthcare systems are under financial strain. There is, and there will remain, a fallout. And this recently came from Becker's, which predicts that over 700, and you can see Texas there with all those dots, are rural hospitals are at risk to close, with the majority of those being in Texas and in Oklahoma, because they're large rural areas. More than 30 rural hospitals have already closed in Texas. So for JPS, and the thing to understand about the rural hospitals is that they truly serve as a safety net for their communities. And so for JPS, this reinforces our need to maintain strong reserves, carefully manage our capital investments, including our new hospital, and diversify revenue sources. And I've heard that from every board member that you've challenged us to do that. So why does this budget matter? Why are you here today? It matters, as DT said, because this is not about an income statement. It's not about the financial assumptions. It's not about the strategic and capital investments, but it's really about the people in the community that we serve, in the community that depends on us. And every resident here in Tarrant County relies on us to have immediate access to specialized trauma care because we are one of the best level 1 trauma centers. And so that's for all Tarrant County residents. So the decisions reflected in this budget will influence our ability to preserve access to our patients and our communities that need us the most. As Kim walks you through the budget process, she will lay it out based on our strategic priorities that will position us for now and for the future. These priorities are set each year. The executive team goes off-site and reviews our strategic plan and sets out priorities for the following year. These priorities are the bridge between our strategic plan and our budget, and are more importantly, our guiding principles for setting the budget. So first, we ask, are we investing in our workforce like we need to? Are we creating a workforce of excellence? You will hear that our budget does reflect our continued commitment to our workforce. Second, we ask ourselves, are we preserving access and quality here in Tarrant County? JPS will continue to respond to our community needs, and we will continue to identify services and the care that's needed for our communities. We will look to expand through technology our virtual and digital footprint, which will include remote patient monitor, but we will do that while maintaining foundational high-quality care and operational efficiencies. Third, we ask, are we protecting our financial sustainability? Are we maintaining strong operations, and are we improving efficiencies, especially as we're undergoing new construction projects? Are we managing costs and expenses? And as I said, Charlie and Stephen will come up and talk about how they are helping us to manage some of our high expenses. Are we diversifying our revenue and not relying on our current revenue sources? And are we increasing the support from our foundation? This is the fourth one we've always shared with the board, the three that I just laid out in front of you. But we really are having more conversation about how we're preparing for future healthcare needs. And although you're only hearing about the fiscal year 2027, we find that it's important for us to look out ahead of us to ensure that we are going to be ready for the ever-changing healthcare needs and environment. And while the fiscal year 2027 budget prepares us for now, our budget does reflect our future needs. This includes our new hospital campus, new technologies and AI, our digital transformation, and our ongoing infrastructure optimization. So I look forward to the conversation and the dialogue that we will all have today, and I'll leave you with this, that our patients are our true north, that our workforce is our foundation, and that our mission is our guide. And with that, I'll turn it over to you, Kim. Thank you.
Excellent. Good morning, everyone. Thank you, Dr. Duncan. That was a great way to start this day that we're having today to talk about the assumptions and the foundation for our budget process for the next year. I do also want to thank DT, Dustin, and Alan for taking the time on Friday to listen and share their thoughts about some of the content for today, as well as Drs. Patel and Fowler, who spent some time with me this week also. And so again, just running it by them, seeing what the thoughts are. No decisions, as DT mentioned, but really thank you for that time. The second thing, I'd like to be grateful to Whitney Franklin and the finance team who really took the lead in putting this materials together with input from the executive team and many others in the organization. And it takes a village. I know that's an old phrase, but it does take a village or a basketball team or whatever you want to say, but a large team to get this done. So let's get started. I think up on the screen right now, we have the agenda for the day. We'll go through these sections. We will cover the budget, how it's built, the foundation of the volumes, which then create the revenue. And we'll hear Mike Spivey, as was referenced earlier. He'll talk about the very complicated supplemental program. So please make sure you have enough coffee in you, because this is very important. We do this every year, and if we need to do it again, we'll do it again in 6 months. But we always learn something every time Mike is here. We'll talk about expenses, and we've asked Charlie Cobb, the VP of Supply Chain, and Stephen Schultz, who is the leader of pharmacy, to come and talk to us about those very expensive areas. The second largest cost for our organization is supplies. And then we will walk through the non-operating budget. We'll talk about the Tarrant County programs, as well as our capital and debt, and then the next steps after we complete today, and where we'll go before we finalize the budget later this summer. So the agenda is designed to step logically through how we do things. It might not be logical to you, it is to me, so if it's not logical to you, please let me know. And so it's just designed, and if you have questions along the way, please ask. We may not be able to answer them all today, but in 2 weeks when we do come back to the Finance Committee, we can have more answers to questions. So with that, I think we will get started. So every decision is guided by our mission, as we know. We are a people business, which includes our patients, our employees, and the communities that we serve. We balance the budget aligned with our strategic goals. You'll see that on the left side of the scale, our strategic goals and what we're committed to for the community, balanced with the external pressures that we have, whether they're federal, state, local, even global. When we talk about global, that's supply chain. You know, when Hormuz closed, you know, there's issues getting supplies. When we have hurricanes in Puerto Rico, IV solutions are impacted. We have drug shortages, about 200 right now, so those all impact us. So it could be a global, it could be local. We also have the impact from federal down, where we get impacts with HR 1. You may not realize, but the SNAP program is actually going to be impacted by HR 1, and we're going to see the state administrative support is going to go from 50% to 75%. That's another $100 million the state is going to have to pay. And if the state also doesn't get in line with their error rate of appropriately aligning SNAP benefits with the right beneficiaries, they could also face about $700 million in penalties around that. And this is all effective October 1st. Now, why am I telling you this? Because health care is dependent on many things, including food. And food scarcity is an issue, and if we start looking at where we see a reduction in food for our patients and they don't have access to it, then we see downstream effects in the health outcomes of our community. And so just wanted to say that's a federal that comes to the state, that impacts us locally. It's basically a domino effect that we have. Many other things in HR 1. We've talked about Medicaid changes, but just wanted to share that there's so many things that indirectly affect us, and we have to balance that as we look at our budget and how we take care of the community. Our budget is built on the 3 pillars of access for the community, workforce, and financial sustainability so that we can secure the organization's future. I'm not going to do this very well. So just a short recap, where are we? This is the net income and the future fund. This is the only slide you're going to see a net income percentage on. The financials we will share at the Finance Committee in 2 weeks. This is all about the assumptions today that will allow us to bring draft financials back. But this is where we are right now. This is our trend in net income margin is the line. The bars are the future fund and how that is growing for us. So as we see our performance, we're going to come in at budget, slightly above budget this year is where our projection is based on some of the things that will be coming in at the end of the year, as well as we're seeing some changes in payer mix already hitting us. We're seeing an increase in the uninsured. The future fund, it shows you the growth. We expect to be at just less than 1.9 billion by the end of the year. That does include our debt that we currently have, and we'll go over the future fund in more detail later in the presentation today. We just kind of want to set the stage where we are today for performance. So some of,
Can I ask a question on that slide? With your projected net income in the far right side at 6.7, just slightly ahead of your budgeted net income at 6.5, how did you have 153 million extra in the future fund over what was budgeted? Where did that cash come from?
we actually did not spend the amount of capital that we had expected to pay. And I'll go over this later in the deck. However, you may remember in December, for those of you who were here, we did a $107 million transfer. 65 million of that was related to fiscal 25 performance. So we took cash that was generated out of fiscal 25. So we ended up over 180 days when we closed the books last year. And then usually what we would do is in December, move the difference, bring us down to 180. And so for this year, it's about 140 we've been able to transfer over. We were expecting about 40. And we were able to move more over because our capital spending is not as robust as we thought we would get to this year. Had better cash.
That's a lot. That's $153 million that our capital spending is that far below what you had planned.
It's not all capital spending. Some of it is we're having favorable financial performance at the beginning of the year with some one-times and some others. Can we take that and we can get into that more as we go into the budget retreat next week, 2 weeks, and talk about more of the details around current year performance. Is that okay with you, Blake? Blake, is that okay?
Yeah, that's fine.
Okay, I just want to make sure I'm not, I just want to make sure you're okay with that
No,
answer.
that's totally fine.
All right. As we talk about 26, we want to just talk about a few of the highlights. Some of these are underway, will be completed by the end of the year, again, in the 3 categories that we have. With the workforce, we are setting the foundation for optimizing our people resources for care. We're growing our future through workplace excellence, including the SHINE program, and we're in our 2nd year that we've kicked that off for this summer. As we look at access, we have quite a few points up here, but we're the first hospital in Texas and one of 5 nationally to receive the American College of Surgeons Emergency General Surgery verification. And we've received multiple recognitions for physician, nursing, and healthcare excellence. Around financial sustainability, the master facility plan has advances. We've seen the parking garage open this year, the groundbreaking this year. The PEC opened in September of 25, right as we started, right before the new fiscal year. So really that ramped up in this fiscal year as we opened that up. And then just preparing the future with a solid foundation with AI governance so that we can begin to move forward with the technology gains. And so a lot of things going on in fiscal 26. This list is just highlighting the things that we see are just great accomplishments by the organization, but there are many more things across the organization. So you look at 26, so it says, what does it say for 27? We have areas of focus for 27. We have workforce. We have the workforce optimization, which we'll talk about later in the conversation today. We'll be looking at market review and salary benefits. We have some physician and clinician workforce pipeline development. How do we get more physicians into the organization for us? And then looking at an internal medicine residency program. Around access, we'll continue to look at ambulatory expansion, and consolidating some of our strategies where it might make sense. Post-acute care services and community partnerships. Dr. Duncan referred to remote patient monitoring. How do we get out with the patient? How do we get them to the right setting for their healing? We have the Joint Commission Survey prep that's coming up this year, so that will be efforts that we will be focusing on, research and academic partnerships, and looking at our strategic real estate evaluation over the next year. Around financial sustainability, we are looking at AI integration into clinical and business operations. How can we bring it in? We have some transformation continuing with RevCycle. RevCycle has a huge opportunity. We have just reorganized revenue cycle into the delivery management that we have. I'm happy to say that I have hired a VP of RevCycle who will start later in July. So that will be a great benefit to us and our team. And as we move forward, financial performance focus, looking at our enterprise risk framework, it's very important because it needs to understand where our risks, and Dr. Duncan mentioned the 8 areas. Cyber is a big one. There's supply chain. There's other opportunities where we see risk, but we have to figure out how we're going to mitigate that if it happens or when it happens. And then we have philanthropic strategies, and then of course the master facility plan is foundational to us because that continues to be part of our work.
But Kim, can we go back to that and
Sure.
get some input from the board as to whether we're looking at this right? Is there anything additional that you think that we should consider? You may think of those things as we start to lay out more and more of.
One thing that concerns me is the master facility plan. We're talking about a lot new, some where we can address existing. There are some medical homes that have been on here for years. We want to get there's capital needs that are forthcoming with those facilities.
Yeah.
So I think we need to look at somewhere we start budgeting to.
Yeah, totally agree, and I think that's embedded in some of this that we're talking about. To your point, is really looking at some of the aging infrastructure. And as Kim has put up here, this kind of consolidation strategy in the ambulatory, to really look at our ambulatory footprint, ensure that we're in the right places with the right services, and whether we can consolidate some of that, much like we did out in the medical home southwest area. So totally agree, and we can call that out, so thank you.
But we want to make sure we look at Style 6 before we look at.
I already have a fundraiser for your new Stop 6, and then Viola Pitts is behind that.
I want to put.
I thought we'd consolidate those together.
Or then I'll be fine.
I think it's just very open, based on election and situation. So when we look at that towards the opportunities with workforce optimization, where this organization goes, and how you manage that cost and so labor is very good facilitation. All the way down to the payment and capital budget, so it's a good footprint. Obviously,
I guess one of the, I think it's embedded in here is looking as we go to the community, some of the services that we are providing, are we doing all the things inpatient, outpatient that we should be doing? So hopefully that's somewhere in here.
Yeah. Kim, we may want to, really that movement out to the community that Dorothy's talking about. How are we going to build that?
Kim, for the workforce, I think we may want to take a look at leadership succession and talent development.
What was the second thing, DT?
the succession, leadership.
I heard succession, but that's
Talent development.
Development.
development, thank you.
I think from the access one, we may want to look into population health and prevention. And then and then consumer experience. And from financial sustainability, maybe diversification of revenue.
Okay.
So I think, I'm not sure if we want to think about long-term for the entire category of digital transformation. It's coming.
And some of these things we'll address as we move into the long-range plan. So this is really looking at the foundation for the next 12 months. So some things will be foundational this year that will propel into the long-range plan, which in the coming months we will bring back to this group.
I agree with DT that
Yep.
I do think that as part of that access is that digital
Absolutely.
build that we'll need to do. And then the revenue diversification, we've also talked about, I think it needs to be included.
And another one I would consider would be academic medicine and innovation.
Academic research,
Mm-hmm. Yep.
innovation.
Yep.
Which is part of that pipeline there with the physicians, but I think we can call it out more clearly.
And I'm not sure it's for next year or the following year, but we may want to lay the groundwork for community and population health. You know, talk about housing, behavioral health, substance use, homelessness, maternal and infant health prevention.
Our financial sustainability are fairly popular, that's what it said today. Building our marketing and branding. A lot of people say, you know, we don't need to market to people that need us. We need to market to people who will help us financially. And I think explaining, every time I go to meetings, like we won this award, we won that award, we're a fantastic hospital. We need to get that message out to the people who can help financially build our future. And that's, I'd like to really work on the marketing and branding of that.
Yeah. And Ellen, would you say that marketing is different to the philanthropic group that the foundation is facing versus the community that we actually are serving, those patients that we are serving in that community?
Very much so.
Okay.
I know we saw a presentation maybe a month ago on what healthcare looked like, the unmet needs in 2035. We might want to take a look at the strategic growth. We support that.
Look at what?
Strategic growth to support 2035. Remember the presentation? What's missing and all that stuff. And then I would look at preparedness and resilience. How we're going to handle cybersecurity, supply chain resilience, emergency preparedness, financial stress tests, and workforce strategies. But I mean, it's a long term, so any one of those.
They're all foundationally, though, DT, I mean, they all have to have foundations that are being built on them. For example, cyber. How do we evolve our governance so that we move forward and have a good foundation? Because if we don't start planning now, when it happens, we won't be ready.
I have one, but on the workforce optimization, we had it in 2026 for the productivity and improvement, but on the living wages, I think we should also consider it with the $2.4 billion master facility plan. We need to look at it. We're going to have it for probably the employees, living wages, but what are we going to do with those people in our community that these construction people are hiring? The living wages should also apply somehow to the people that we're bringing onto these projects. And that has been done on other major capital projects that they're putting in through different cities. For instance.
So how do we, help me to understand how we drive that, because, you know, I can drive that at what I own, but tell me how that's been done.
Well, I'm not for sure, I know that our I mean, I don't know if it's OSIP or whatever, but from an owner perspective, you can set that with the general contractors, the trade contractors, when they bring them in your welcome package, however you want to present it.
Okay.
You have a livable wage of $22 or $23, whatever that is, right? And that's what they're required to be accountable for paying those laborers or whoever, the carpenters, whoever they're bringing in on the project.
So that kind of guarantees that the money is not going outside of, or being used for other, but does that increase the cost on those contracts?
Oh, absolutely not.
Okay.
I mean, I'm on a project that they're required for the city of Dallas for the convention center. We are required, matter of fact, they even increased it already. And that is tracked through the insurance. Marsh is who we have to report it through, and through LCP Tracker. They're, you know, and I don't know if, and I gotta look into it, Justin, on the LPC Tracker, the Davis-Bacon, like there is a standard rate that you pay people in Tarrant County, Dallas County, Johnson, whatever, right? But you can still track that livable wage just like you're gonna track what you're spending in B2G with the contractors. You know, I'm just saying that's gonna be part of economics. If they're in the community, we're building a $2.5 billion project. Why can't we bring the people in the community to make a livable wage
I like that.
on those projects? So I think that that's part of it. And the other thing, do we have anything in comparison with 2026 and where we, I mean, what did we, these are accomplishments, right, on the highlights?
The highlights are, there's not everything we did. Those are the highlights. There are a lot of the highlights that we did. And then for 27 is where we're then moving our focus.
So I was just curious, like, because we had the workforce optimization, productivity improvement in 2026. And how do we measure that against what we want to do in 2027?
So it's on 2027 too. It's that first dot point. And I'm going to actually do a few pages on that if you want to hold on that one.
Okay.
We'll talk about what we're doing.
We have translated it into.
Yes, we have the money that we've identified. Good question.
So Kim, before we leave this page, I would suggest workforce excellence is one pillar. And number two would be access and community health. Financial stability, you have it there. Digital and innovation. And the other one's academic and strategic growth. I think if we add those two, I think we'd be in a good place for looking ahead.
DT, if you would let us kind of take it back, it makes it somewhat easier for us to try to put that within those three in order to communicate it to the organization, directional wise.
But I see part of that academic integration, you're looking at the internal medicine, so I can see that you're already putting some of those things in there.
Right. And we've been really looking at technology as an enabler of all of this. And so trying to put it in one place is really difficult. So
I
how do we
think-
make sure it's
I think
threaded throughout?
Those three are very good. I think in the horizon, the other two, so that we don't lose sight
You're
of them.
saying like under future readiness, that fourth one
Yeah,
that I kind of added?
Yep.
Start adding it so
Okay,
that we,
okay.
we
We can
start
build
thinking
that
down that
vision.
path.
Okay,
Right.
yeah.
Anything else from the group? All right, we're going to start diving into the detail as much as your butt can handle. So let us know. So the budget is built in 4 tiers, and I can't emphasize this the most. Volume, 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 that is the foundation. This is the demand for our services. And so it starts here. It doesn't start with the revenue we have and we build backwards. It starts with who do we need to serve, who's asking to be served in the community, and what are we able to serve and want to serve in the community. So it's the starting point. We look at the expense, the revenues and the non-operating. That's the components that, what do we need to put forth to provide services based on those volumes. Then we look at the operational changes and initiatives. We just looked at the focus list. We're gonna go back to that list a little bit later, just to recap it. And then on top of it is what capital, what can we afford both for the master facility plan as well as our routine investments. And so we really look at this approach bottom up. We start this process in January. Our leaders do their budgets in February and March, and then we work through all of the capital planning for the routine. We work through the staffing models, the supply chain models, and departmentally, all the way up to the executive team reviewing the budgets. And so it's a process for us right now. You guys are where we are today, and looking at the assumptions from the board after input from leadership in the organization and outside sources. So as we look at volumes, which is where we'll start, we know that our community demand is exceeding our capacity. You hear that from us all the time. We know that the ED is very busy. We have patients who are in the house, probably actually longer than we would like them to be in the house. And so we are looking next year at length of stay. I know that Dr. Assad is really working hard with her team. We're looking at bringing down the length of stay through multiple initiatives. We're also looking at bringing the observation or the outpatients in a bed down from being here for 40 hours to at least 33 hours, if not less, next year. We'll also be looking at shifting the payer mix from observation to inpatient. So you'll see that. And the reason is when a patient's in observation, if we look at how we document the care and their stay, they may qualify as an inpatient. We're still giving them the same care, but as an observation patient, we're not getting the reimbursement for those resources as if they were an inpatient. So we want to make sure they're in the right status. I see, Dorothy, you're nodding. You totally get this. It's get them in the right status. We get paid for the care that we provide to these patients. So we're looking at a little shift in the mix. On behavioral health side, we're looking at a slight reduction in length of stay, and we're looking in the local commit alternative. This is the behavioral health involuntary commitment program that we are looking at a slight reduction in length of stay there. That program, just so everyone knows, is funded on a per bed basis. So we are fully funded. We lose on this program, but we get funding from MHMR, which I'll talk about a little bit later, for the LCA program. So it's not a payer program. It's a local involuntary commitment program in behavioral health.
These reductions that you have on here, is it just a percentage, or is it based on hospitals?
It's based on the efforts that we have in place and the initiatives we have in place to lower the length of stay. So if we have patients we have a lot of long lengths of stays. We have patients who could be here 1,000 days. And so these are based on what initiatives, based on the populations, can we do? Are they not getting out because we can't get them durable medical equipment? All right, they don't have the resources. We probably should take one step back. With a 40% uninsured population and another 15% Medicaid, those populations don't have the resources available to them per se to get discharged, to have the resources or the support at home or go to a post-acute facility. So many times we're finding, is there somewhere they can stay? Sometimes they're from out of state. We have to find a family. We have to get them DME. They need to go to a subacute. Sometimes they're jail patients. There's no room at the jail to discharge them. And so it's really based on what are the initiatives for the population so we can lower the average length of stay to create more capacity for the patients coming in.
I get all that. I'm just curious as to if it's just a rule of thumb percentage that you guys are running with, or you guys spent a lot of time.
We spent time.
Like 16 different topics and coming up with an average.
We spent time. We spent time.
And it does translate into a dollar. I mean, really, there is financial implications, even with a small shift of 5.8 to 5.4.
How do the lengths of stay here compare to other hospitals?
They're higher.
Ours are.
They're higher because of our patient mix with the uninsured and the Medicaid.
But I mean, I'm talking public hospitals.
We might be a little higher. Not than Parkland per se, but.
Yeah, I was going to say for the area, I think we're.
I think we're in line with.
Because we have the same challenges that they do. Yeah. And I think this is really a strategic conversation for our board, because our teams have really probably taken care of all the low-hanging fruit. They're squeezing as much as they can in order to bring this number down. And the reality is that there is not enough post-acute places in this community, but especially for our patients. It costs us because we have such a high uninsured, so we have to negotiate, that care after they leave here. And so, we do have internal conversation. I think this is conversation for the board as we begin to look for future access. Can we build some of that post-acute care in the community that takes care of our patients, which are largely uninsured, but also be able to provide it for some of our hospitals that actually have good payer mix, because they also need post-acute care. So I think that's a conversation, because we often talk about building clinics and hospitals, but I think we really need to look at what's keeping our patients here, and how can we maybe build places for them to actually go to, so that.
Karen, do you think those long-term care facilities can be profitable?
I do. I think we'll have savings because it's more of a continuum of care and we own it. I think we can do it for lower costs, but I think we can also build enough capacity in the community, understanding what the need of the full community is, and fill those extra beds with patients from other hospitals that are also struggling with this.
The cost structure for those facilities is much lower than our cost structure too. So some of our patients, we will send them and pay for them to be at those facilities versus keeping them here. It's also a better place for them to heal than sitting in a acute hospital. So, but the cost structure on long-term care, assisted living, group homes, definitely lot less, as well as home care. What do we do with home care?
What about behavioral care? Can it be provided profitably?
I would have to say it depends on the population, but behavioral care is very important to the whole continuum of care. And so as we do that, that will actually lower it on the medical side. So you have to look at the whole, to DT's point, looking at population health and the continuum of care. So it can contribute to that.
Can you explain again what LCA, specifically what type of services?
Those are behavioral health inpatient beds where patients are involuntarily committed by the court.
And how is that different from Trinity Springs? Is that just
That's a regular inpatient behavioral health unit, which is a voluntary program. So you're sick, you have a behavioral health issue, you're admitted to Trinity Springs. The court, involuntary.
And where are we sending patients that need that sort of service? That's not us that's providing, that's out. That's
LCA?
Pardon?
LCA you're talking about?
Yes.
That's us.
That is us.
That's us. And we're paid by MHMR for those beds.
And is that here in this building, or is that a different facility?
No, it's down the street in its own.
So you're trying to reduce that by 4 days, essentially, next year?
Yes. And we've worked very closely with Zillia on these behavioral health lengths of stay and where we see opportunity.
Okay, but that's a separate building than Trinity Springs.
Mm-hmm.
How many beds do we have here?
42.
42.
42.
Kim, before we move out this page, there's a typo in here you may want to check. The 60.8 and the 39.9 is 0.7% off.
I know, it's a rounding error, so, okay. We will fix the math. All right, thanks, DT. All right, so this slide is showing you all of our inpatient plus observations. So the inpatient, which is the blue, which is in-house to the hospital, the neonatal, the behavioral health is in the dark blue. This is inpatient, so this is not the PEC, this is the inpatient. And then the green is the observation. So these are all patients occupying a bed in our facilities. So we're seeing an increase. We looked at the growth in the population in Tarrant County, which is growing at a tune of over about 1% a year. We've looked at the aging of the population because we know that care needs go up as patients age in the community. And so we looked at where we would see this. You'll see the increase in inpatient, the blue, with a slight decrease in the green, because as we mentioned on the prior side, we're looking at more patients being categorized as inpatients versus observation patients as we move forward into the next fiscal year. This is actually very important when we look at this growth and the length of stay reduction. We don't want to be cohorting in the ED, cohorting patients or having the patients in the hallways in the ED. So bringing that length of stay down also gives us capacity for getting them in the right room, which also accelerates their care in the organization.
So you may ask, you're talking about all this growth that's going on, you're talking about this increase in uninsured, so why are you only talking about a 4.3% increase? And it's because we cannot build this new hospital fast enough. It's because we're at capacity, and hence why we've got to look at decreasing that length of stay until we can get into new hospital. And again, this may be a strategic conversation. Do we kind of lease beds in other hospitals that may be sitting a little abundant? Because I think that's a long time, it's 4 years. But we're at capacity when it comes to the inpatient. We do have capacity in the outpatient. And so we're trying to move a lot of the care into outpatient settings. A lot of the surgical procedures now that we can only get reimbursement if we do out in the outpatient. So trying to move a lot out of the hospital setting into the community. But the reason why this number is not going up as fast as our outpatient is that we are stuffed to the gills. And so,
but I do think that as a part of looking at this, then we do have to have a plan of how we can offload some of that. That is no longer waiting in the waiting rooms and all that. So as a part of our strategies, yeah, we do need to look at what we could do. Do we rent another, do we lease another hospital?
or partner with, maybe a hospital that's not having much capacity and, maybe, pay for some of those beds. But I think we are going, to your point, Dorothy, have to look at how we decompress this hospital. Because I don't think, I think Jill would agree, we don't have room for another bed in this hospital. I know our doctors, Dr. Fowler and Dr., right?
So we know that, so is this budget looking at us moving toward that? Or are we just talking about it?
No, we'll continue to look at it. The budget does not contain monies for that, for a new additional hospital or leasing. But we will bring that back and find it within the budget. I'm sure the board will help us find within the budget if something moves that quickly.
The one deal where you have a long length of stay, how could we address that? Because that's more so for long-term care. And could we focus on that piece of it?
So for the budget piece, based on the line of the patient care and the stay, we got this so much prior, but is there a single the driver behind that primarily is a weekly play, that you play those things typically for stay on the patient side?
It's everything. And a lot of that is it's really not a weekend play. We've been looking at the weekend play. We've looking at surgeon discharge behaviors. It's really around our population and what they need in order to be discharged. And it's many things. And so the plan that we were talking about, that Dr. Assad's team is leading, and we have a throughput team. That's how we get patients through the system. That meets every day. And we talk about who can go where, how do we get them out. We're working with the connection program and saying, where do we have ability to make decisions quicker? Where do we give PACE management the authority to make decisions quicker? And so we're really looking at those types of things, and including technology, and that will help us.
Dr. Assad, do you want to add anything? Because I think that's a good question. Is there any variation in kind of how we're...
Where are you going?
Really no variation given the time of the day, but all these questions are very good questions. And I think it has to involve a multi-pronged approach to fix this length of stay. I think at the time of entry, we are looking at how can we look at the nurse triage protocols, making sure every patient is sent to the right location. Not everyone should be sent to the ED. Currently, our run rate is 22 to 24% of patients in the ED end up getting admitted. We have worked with our ED teams and the hospital medicine team, and we've looked at what are the we've identified about 10 low-risk admissions. Who are the patients, if given the right resources based on their DRG, like low-risk DVT, low-risk chest pain, hypoglycemia, which we can, with appropriate resources and appropriate follow-up, discharge. We have developed a mechanism of track and trend. It went live June 1. Again, it will help us decompress on a daily basis about 2 to 3 patients. Again, it's not just one thing that is going to solve. When it comes to the clinical course in the hospital, we are exploring a new technology and hoping to go live with it by fall, which is rapid identification of the bugs in the blood culture. Right now, we feel that we could have, it's called BioFire. We are looking at it. And again, we are not just looking at it, we are going to go live with it in fall. What it will save us is about 2 days, roughly. And especially, I know Dr. Fowler and Dr. Patel know, we have any times contaminated blood culture is a very easy fix. With that, we'll be able to identify the bug pretty quickly, and we're not keeping a patient there when it's just a contaminant. So that is another one. We're working with our pathology team to look at how we can identify rapidly bone infections and not just rely on the bone biopsy result, which takes very long, looking at a proxy like marrow. And then we are looking at remote patient monitoring. We already have a contract. We want to make sure that that is leveraged maximally. Why remote patient monitoring is important? It affects the entire continuum of care. It really allows us to discharge patients sooner so that patients can be actually monitored outpatient safely, or even prevent patients, like patients from the clinic could actually be set up with remote patient monitoring and really not ever enter the hospital if that can be prevented. We are not only fully utilizing our existing contract, we also started very closely working on that this month, but we are also planning to expand. One of the key things which, if people who attended the quality meeting, our top diagnosis across everywhere is high blood pressure, and a lot of these patients come in with very high uncontrolled blood pressure to the ED, and then with end organ damage and get admitted. That is the first one we are starting with, and then expanding to diabetes and a couple of others. Then comes the discharge, which is, I think, our biggest reason for length of stay. Any given day, our number of medically cleared patients in the hospital ranges from 80 to 102, 105.
So what does that mean when you say they're medically cleared?
Yes, medically cleared means they have actually completed their ability to meet staying in the hospital in terms of their care, acute care needs. At this point, they do not meet their acute care needs to be in the hospital. They are ready for either home health, SNF, IRF, any setting, but not in the hospital. Any given day, we range from 80 to 102. What are our common reasons? Common reasons are disposition issue. Many patients have insurance. Yes, we have about 40% who have no insurance, but there are people who have insurance. They don't have long-term benefits. They end up staying over here because they are not ready to be discharged safely. We have patients who are SSI pending, Medicaid pending. They cannot be sent anywhere. We currently have pilot program. We are planning to expand the pilot program. Also, we need to make sure that the patients, when they are being sent, they've outlived their stay in the hospital. They need to be sent to a SNF or a long-term care facility. We are expanding the number of facilities we are contracted with. This is our pilot program, but also we need to make sure that they actually have the CMS star rating. We just don't want to send people to 2-star rating facilities. So SSI pending, that's our longest. Those patients could end up staying about a year in this hospital. Medicaid pending, usually the state grants in about 90 days, but that 90 days is a big deal. When they discharge, and it hits the length of stay for that month. Every month you've seen we have about 1,500 days, anywhere from 900 to 1,500 days, which are from long length of stays. Jail patients. On any given day, our jail census is about 20 to 25. Any given day, our medically cleared jail patients is about 4 to 5. They also have their surge level. When they're in surge black, they can't accept patients from us. Surge red, yes. So, and that is also a recent change in the last 6 months, I feel. Previously, we were not, our jail volume has gone up significantly. So we are looking at avenues where we could have SNF facilities where once the patient is medically cleared, they could be moved. Now that's true for county. Federal already has a good mechanism. They have contracts with LTAC, patients can be moved. So we are looking at the jail patient. The last thing is, so okay, we look at the disposition situation, so Medicaid pending, SSI, and jail patients. The last thing is once we discharge, what are we putting in place that these patients, we can prevent a readmission? Because that obviously is tied to capacity, and then obviously with especially commercial insurances, you don't really get paid. We are actually looking at a predictive model with our research team. So DT, I appreciate when you mentioned research. Yes, with our D, we have a very good, decent research team. They are looking at a predictive model. We tried every model, John Hopkins, Medicaid. It really does not reflect our patient population. So our team, research team, developed our own model and actually looked at it retrospectively, and that model actually is able to predict the readmissions. The difference is, historically, we've always gone after the multi-visit patients, which is 3 or more. Okay, every resource is then deployed if they've had 3 or more readmissions. Every resource is deployed to prevent that admission. But I think it has to be done more proactively, which is, how do you identify a person who's actually never been admitted before? How do you identify and deploy every possible resource towards that? That model is actually being looked at. I know Kim's team is helping to see how we can actually build it in Epic. So with that, we'll be able to appropriately identify, and then Dr. Bedamosi is leading the effort to develop care pathways. So our highest risk of readmission is CHF, then respiratory, UTIs. So we will build a pathway just for CHF. So whoever is working in the hospital, whether a brand new resident or an attending, everyone will be able to tell, okay, for this particular CHF patient, you need to actually move them now at this point to probably oral diuretic, or at this point, these are the resources available in the system. You can actually, like a CHF coordinator, you need to, or what other resources are available based on what the patient needs, whether the patient is going to go to a shelter, whether the patient is going to go to a group home, but those resources, it's a care pathway which will be developed. So this is one strategy which, once the patient discharge, how we can prevent them from coming back. So I know this was a long-winded answer, but length of stay is just, hopefully that answers some of the questions.
I have a question, Dr. Assad. Going back to the jail population, so when a jail patient is no longer acutely ill and shouldn't be in the hospital, what's preventing them from returning to the jail?
There could be a lot of reasons. Like, I'll give you an example. ADLs. They can't do their ADLs, they can't return back to the jail.
Average daily living, the things that you dress yourself, feed yourself, those types of things.
We're a clinic, we're not a hospital. So we, the setup in the jail is similar kind of setting that we set up for a clinic. We're not a hospital, so we cannot move it from our hospital to a lower level of care is not available there at the jail. Although I think we're doing a little bit of work in trying to build some of that.
Yes.
Again, their space is limited, and so.
Male patient, but only female beds are available. Female patient, but only male beds are available. Low bunk bed is needed for a patient, no low bunk bed available. So there are a lot of reasons why a patient cannot go back.
There's not infirmary space?
There is, but it's usually at capacity. And they give our patients a priority when they are returning back.
Are the jail infirmaries, which Chuck and I toured last week, are they adequate for the discharge of these patients that no longer should be in the hospital?
Meaning adequate for the clinical care? Yes. Their team, actually, one of their nurses is attending our throughput meeting every day. And every patient who's ready from our perspective is actually evaluated by Dr. Thomas, who's their director, or whoever else is there. Yes, he's very good. And they basically let us know that could this patient clinically, could their needs be met in the jail? So yes, the infirmary is capable.
And there's more than one infirmary unit, right? There are 2 or 3.
That I do not know.
I think there's one. There's one infirmary.
But that's part of our length of stay problem is jail patients.
About 4 or 5 patients are medically cleared any given day.
How many?
4 to 5.
Thank you, Dr. Assad.
Yeah. Thanks, Dr. Assad.
I think one of the things also that community-wide, there's a lack of understanding that we don't have beds.
Mm-hmm.
Person comes to JPS, they think, I need to get a room.
Mm-hmm.
You're amazed at the number of people who complain to say, hey, my loved one has been in emergency, or been in a holding pattern for days. A lot of community doesn't understand that there's not bed space. I don't know how we convey that to the community that we're building a new facility, but we still won't have bed space once that gets there.
So what do you say, because you have determined the capacity of the
Yeah.
So the 5.8 days, the 5.4 days that's after, then what does that relate to in terms of patients? Can you guys map that out?
So right now, it's really the same amount of patients we're seeing right now. So if I go to the next slide, this is the medical only. So I broke down medical just to break it out from the chart. We're seeing about a 7.6%. Some of that is the move from observation outpatient patients to inpatient. So this is capacity we're already seeing, but at this status, we call it patient status, has changed. So from observation or outpatient to inpatient. And some of this is the growth. To Dr. Duncan's part, we are at capacity. So any length of stay, to Reverend's point, is going to be a patient moving from the ED up to a bed, or an increase in surgeries that we can accommodate on an inpatient basis. And so we actually budget past capacity right now. So right now, we're assuming we're gonna, on the average, be cohorting, doing what we've been doing in order to take care of the community.
Kim, if we had more capacity right now, would that increase our operating margin or decrease our operating margin?
We would
be
look,
more profitable or less profitable if we had more capacity?
it would depend on the type of service.
Depends on who walks in the door. and
It
whether
depends
they
on
have
who walks in
insurance.
the door. So, and really, the ones without a payer are the ones that are our biggest challenge. So to Dr. Assad's point, if you have Medicaid or even some commercials, you don't have coverage beyond the acute care walls. And so how do you get that coverage? And many of that goes to self-pay. Medicare's different. There's coverage for up to 90 days. There's certain coverages for Medicare, but that's only 20% of our business. And so, so as we look at it, if you looked at if they're all don't pay and we try to lease beds to take care of more of the community, it will be a loss, but we will be taking care of the community in the right way by getting them out of the hospital, right? And getting them to the right healing environment.
Keep in mind too, we have shared beds. So if an inmates come in, we lose the whole room.
So this slide breaks out the medical acute admissions, which are the hospital admissions. On the right-hand side, it shows you the length of stay change. It also shows you case mix index, which is the line on the right graph. Case mix index is a measure of the acuity of our patients. We're showing a slight increase for next year, 2 basis points. That is about just under $5 million in revenue for us. As we are putting together a more intense documentation program to really look at how do we help the physicians, the residents, document everything that they're doing for these patients. And so we are on a roadmap right now to enhance that education. What are we doing? Changing out our technologies in order to help us do that.
So Kim, are you doing that through resourcing additional CDI specialists or
We're doing
team
it
members
twofold.
throughout to help our physicians? Because we do, we truly do see patients that have delayed health care and are sicker that come into our front door, but agree with you that because of our documentation, it often doesn't come across with that, you know.
Absolutely.
So is part of the budget next year that you are going to enhance that?
It's twofold. One, getting CDI more at the elbow, because right now CDI is a remote function for us. They need to be there with the doctors and working with the doctors and get familiar with them, and then through some technology that will help identify the opportunities.
Okay.
Kim, question. With length of stay, would it may be different from payer, but are we not paid more for each day that somebody stays, or are we just paid one amount whether they're here a day or 4 days?
We are paid one amount. We get a DRG payment or a fixed payment for the majority, Medicare, Medicaid. We get a fixed payment.
And commercial?
Commercial, there's just like one, we get percent of charges, but it's really low. We get a fixed payment, and the case mix index is the severity. So sometimes those fixed payments are associated with, you get paid $6,000 for this one, but if they have complications, you get $8,000. If you have major complications, you get $10,000. And so, because the resources are more intensive, that's what the clinical documentation improvement program will help us with. But we do get fixed payment, so it's kind of like having a cap system. So for each episode, it's not beautiful, but it's been around for a very long time.
So it's safe to say it's almost always financially better to have somebody leave the hospital sooner?
Financially, yes, but not necessarily the right thing for the patient. So,
We're talking here length of stay beyond what should be necessary, that's.
right, so we actually look at, Medicare has average length of stays by each DRG. So if a patient is in for a specific condition, I don't want to make up one, but let's just say the average or the mean length of stay is 5, and we keep them in for 10 days, we look at that ratio of 10 to 5 and say, oh my gosh, we're at 2 to 1 or 200%, we need to get that down to 1. And that's kind of how we, one of the ways, not all the ways, one of the ways we look at what should the length of stay of these patients be? What does the Medicare geometric mean? Doesn't mean it's the only thing we look at, but it's one indicator to look at.
Is your 5.43, which is the lowest on the chart, is that an aggressive goal or is it attainable?
All of the goals you'll see will be depending on outside forces, depending on the type of patients we receive, the severity of the patients we receive, and the community's capacity for us getting them out. So
They're achievable goals.
They're achievable. All right, any questions? We will move on to the emergency room. Emergency room is our front door for the facility. This is the place that many people come first. We'll talk about the community, the health centers in a minute, but we are looking at 172,000 visits for next year. This is the emergency room, the main ED, which is the bottom largest section. You have the PEC, the Psychiatric Emergency Center, as the 20,000, and then you have the OB triage. We are in the 5th or 6th busiest ED in the country. So we are very busy. Parkland's in the 242,000 range. They are the busiest in the country. And so
we're the 6th busiest emergency department in the nation.
Uh-huh. Yep, we see a lot of patients every day.
Of public or of all?
Of all.
All hospitals.
Yeah. Yeah, so we're very busy. So ED, front door, this is, you're seeing the growth. I'm gonna break down the main ED in just a minute, but just wanted to show you overall, trying to get patients to the appropriate setting. But again, for these patients who don't have resources, that are uninsured, their first place to go is where they think they're gonna get care. And the ED is required for us to at least triage these patients and make sure that they're safely taken care of. And so we have a lot of entries into the ED.
I think that's a great point, too, because if it's 6 visits, between the patient and the pay, right? Insurance, whatever that's focused. How are the other 5 below us or around us, they have the same type of influx? Meaning, those new patients come in more at a private scale or higher in insurance versus GPS, because you got that ratio, you can show how aggressive we are. Why others may go out and run us based on length of stay service. So, like, these are all challenges that you guys do daily contact with these. And the other folks probably can be right there with us, recycle faster for all reasons you already know.
Right. The other EDs take care of different populations than we do. They do have the uninsured showing up, but with 17% uninsured in Tarrant County alone, we get the majority of them.
I think that's a win somehow, show based on the side switch up.
Absolutely. Very good point.
Good point.
This is the main emergency room alone, on the right-hand side, and then on the, left-hand side. The right-hand side shows you how it's split between the emergency room, just the outpatient people coming in for care and then being discharged, the observation where they are in a bed getting treatment, and then the inpatient. And so you'll see 100,000 of our visits are basically come in, get treated, get released, but we have about 37,000 that end up with patients in a bed, whether that's observation or inpatient in the facility. As we look at surgical services, which Blake, I know this is your area that you love. So as we look at surgery, sorry, my notes are, I'm having 2 clickers, I apologize. When we look at surgery cases on the left-hand side, you see inpatient, outpatient at the main facility. Those are both at the same facility. And then you have Jessica or JPS Surgical Center of Arlington. So they build up from the bottom. You see the same growth in surgery cases where you'll see the growth. You'll see the outpatient in the hospital, the dark green in the middle, relatively flat. It is flat for next year, with more cases moving over to Jessica, to our outpatient. And we're really trying to use the capacity over at Jessica. We're actually in the process of moving to 5 Da Vinci 5 robots. Those are the robots that do less invasive surgery for the patients, and we'll be implementing those. You'll see that come to the board, and then we'll be implementing that. But moving to that technology that not only is great for care, but it helps us with recruitment for our physicians. The surgery type is on the right-hand side. How does it break down between surgeries, endoscopies, and invasive labs? Just giving you the breakdown of how we're growing those services. Right. Clinic visits. This is our front door in the community. This is non-ED. This is where we try to see the patients first and really try to bring them in. The growth assumptions are, again, aligned with the utilization trends we're seeing in the community, the growth in the community. This also includes a full year of Las Vegas Trail and Medical Home Southwest. So full years continuing to evaluate and expand services. We have primary care on the bottom. We have the middle green is specialty, and then the top is behavioral health. For primary care, we have multiple initiatives going on in that space. We have Call Us First campaign, which encourages them to call us first before they go to the ED. Can we get them in today versus them just going to the ED? We have open screening appointments, wellness visits, and new patient clinic days that are closing care gaps, as well as women's health is expanding, as you know, is opening the new center in December. On the specialty side, we're really looking at the same, the opening screenings, the wellness visits. How do we get people to start proactively looking at their health? We have the women's health expansion, which I mentioned, and in behavioral health, we also have social worker initiatives and direct referral pathways to really help them find that referral in behavioral health. So we have many initiatives. We have a new operational leader who just started. And he has many great ideas as a partner with Dr. Gabash. And so we're very excited about getting into the community and how we get patients into the clinics versus having them get to the EDs and helping them stay well and be well in the communities that we all live in.
I have a question on the specialty area. That's one of the areas where it's hard to get in. We have a long length of stay. So I guess I'm a little concerned that we're showing that's going to be able to increase unless you're bringing in some more doctors. I don't know how that number, because right now, that's one of the longest areas for patients to get in. Unless there's a program going on to reduce some of those requests, I don't see how you can grow unless you're bringing in some additional positions.
So I'll start, and
Jill,
you can go, or Jill. I was going to say, Jill.
Speak to kind of how we're looking at this.
Yeah, I think it's twofold. I think we've identified through some of our provider compensation and schedule, looking at their schedule, there is some opportunity for improved productivity in some of those specialized areas. I think secondarily, I would say, we talked earlier about really assessing and understanding our ambulatory footprint. Do we have the right services in the right locations? And I think that's a part of it too, specialty in these primary care medical homes and making sure they're the right specialties. And then the third thing I would say is it really is around those referrals and appropriateness of referrals and looking at does it require a specialist? I'll give an example. Diabetes back long ago used to be a referral to an endocrinologist. It no longer is. With our large primary care, family medicine, residency program and all those things, what are some of those other diagnoses that really shouldn't need a referral to a specialist? And that's really partnership with our providers to say, really that can stay, within primary care to continue to manage. So I think there's a lot of optimization work that needs to be done in the specialty areas in some key areas.
I don't know if our physicians want to weigh in on this. Dr. Fowler, you may want to weigh in on it. It's just you know, just even the ability to recruit enough, what's in the pipeline for us to even be able to bring on some of these specialists.
It's nice having our own pipeline there because we kept 3 this year, 4 from last year,
Yeah.
which helps, which means they hit the ground running too. They've already had a clinic population while they were residents here, and they continue on with that too. And it's a juggling act as well. Our number of nurse practitioners, APPs versus physicians in terms of referral numbers and things like that, making sure they're comfortable with their referral rates and watching that individually. So, and a good act with and backfilling vacancies too. I think we're pretty darn good for right now on ours, and Dr. Patel's done a wonderful job with especially for referrals to backfill those vacancies. So that's been very helpful too.
Yeah.
We are also looking at tablet utilization, also, clinics have been more proactive in calling patients to ensure that they show up for appointments, so less of no-show rates. They're also going outside, different southwest, northwest, different specialists that those patients can and including access.
Dorothy, I think there is opportunity, and we're working with our physician group to backfill very quickly when those positions open up, because all it takes is one physician, especially a specialist that many times has 30, 40, 50 patients on their schedule to leave, and then that third next available really stretches out. So we're looking for timing in bringing, in the recruitment, in the credentialing and privileging, so that we don't have those gaps in times, because that's what we're seeing a lot of.
The one complaint that I get from in the community is I go to the ER, or I'm seen by one of our own doctors, and then they say you need to be seen by a specialist within, and they're saying they tell me I need to get into the specialist, and I get an appointment for 6 months, and I'm thinking, well, you'd probably be okay. But can't say that. But, it's that piece that we need to coordinate a little bit better. Because when they tell a patient, you need to be seen by a specialist and this need to be urgent, then 6 months is not urgent. But I try to explain that to them. But that's the piece that's really hurting us is one doctor is saying you need to be seen by a specialist pretty quick. And then they call and it's a 6 month.
Before you get in.
And I think there's some work that needs to be done, right? Because I think we all know sometimes you don't need to go see the neurologist right out of the gate, but really you need to be connected with a primary care provider who can do some, beginning tests and things like that and make sure. So I agree with you.
Okay.
There are some opportunities there.
Okay.
I think also, we're competing with all across the country, and all these specialty areas are hard to recruit for, and we're not unique to that, right? And so I think not only building the pipeline, we talked a little bit about, IM residency, that also helps build the pipeline of some of these hard specialties, I think of that are hard to recruit, and we're not unique in that. We're all struggling across the country with some of these.
With the Call Us First that you were discussing earlier, is that telehealth?
It's call us first to come in for an appointment, but it also can include telehealth, yes.
Is that do we contract out the telehealth, or do we have our own system?
We do our own telehealth.
You have our own system? And is it visual? So it's like
It
FaceTime?
is. It is. And it's through our MyChart, through our electronic health record. It's through our MyChart application. So when you have a MyChart account, you log into that portal to do that telehealth.
How is that performance compared to clinic visits? Is it actually, is there room for improvement on that to get more people going there?
Absolutely. Yeah, absolutely. I think that's something you have to constantly pulse. I think of me, right? I need to go see a doctor. I need to see them now. If I got that email about, telehealth 6 months ago, it's not top of mind. And so it is something that you have to pulse constantly through MyChart or through other mechanisms to say, our communications department does a phenomenal job, and we're seeing like high rates of flu, and we know that it's that, that season in the fall and the winter. They're very good about helping get the message out about telehealth through our social media platforms, and we do see the uptick in usage of telehealth during those times.
Yeah, that's the problem, is just knowing, so maybe, I don't know, if it shows up in the search for JPS, we're looking for the phone number to call.
Right.
Is it like right there?
Yeah.
So that I can just click on that instead of the phone number?
It's through it is online through your MyChart application. But again, I think it's just reminding people that it's available.
Kim, what's the reimbursement now on virtual visits?
It's still low. It's still very low. It's, you know, compared to an in-office visit, which you might average over $100 for that, you might get about $35. But
you
it's
see them
virtual.
quick and they're not coming
Yeah.
to the facility.
Yeah.
What about the specialty care? Is that also something that telehealth?
Yes.
It depends.
Yes.
Yeah,
Yeah.
Dr. Patel can share.
Especially also.
There's some, you know, a physical exam is important, so you're seeing an orthopedic doctor, you know, they want to feel and touch, so it really depends on the specialty and the reason for the visit.
Depending on the specialty, you have some subspecialties available within weeks. It's not always months. I mean, they've done a wonderful job doing that. My chart's also generated some fun. It's a beautiful thing for communication, but a patient can also, we've really gotten our no-show rates down, which has helped a lot with on capacity, but then they could actually cancel on my chart, so that's another struggle we're working with in terms of how to deal with that too. But if the communication's better, there's pro and cons.
Is that good or bad?
Well, we have to set it up right. I mean, if you cancel it cooks, you can't cancel the day of or 2 days before. You have to do a phone call, and we're working the policy to be able to do that right. So, but when so many people using it, we're able to cancel. At the last minute wasn't good because it ends up being like a no-show. So they're not no-showing, but they're canceling. So we're fixing that.
Is there a penalty for if you cancel your appointment within 24 hours, there's a penalty? Well, that might be something to think about it, because on mine, if I don't cancel my appointment within 24 hours, I still have to pay $45. So that's kind of incentive for you if you're gonna cancel. Yeah. Got just throw it out.
We put that in our budget as a revenue diversification.
I was gonna say, it's gonna cost me more, it's gonna cost us more to collect that $45.
We will call it the Dorothy plan.
The Dorothy plan.
But I do think there's opportunities though, I mean, because you can use your technology, maybe not in the punitive financial way, but you can utilize your technology to look at, you know, Dorothy DeBose cancels so many times, right? And so we're gonna actually overbook when Dorothy's scheduled, because we don't think Dorothy's gonna arrive. And so there are, you know, some, you know.
That's
intelligence.
probably case management that now needs to.
Intelligence back in Epic that you can utilize.
But I also think that we have to also show something. There is a disadvantage for you not to cancel within 24 hours. I don't know if they're gonna ever collect their $45, but that comes to me in a text message.
Yeah.
It says if you're going to do it. So
Dentists have been doing it for years.
Kind of reminder, even though you might be saying they're never gonna pay, but then they don't know they might not pay, and this is not some insurance gonna pay for you.
Right, right. And I think with all the conversation we have is the technology, and we're actually constantly looking at how we're using Epic in order to enhance the patient experience and whether other digital opportunities there are to enhance the patient experience,
Yeah,
as well as the physician's experience in taking care of it.
Start sending it to you at least a week before. Then, the first time is just to remind you, but after that, it's that 45 is in a different color.
Warning, warning.
I'm just telling you, so.
I mean, from time to time we do, from the physician side of it, we can, but as far as staffing, we've done a lot of setting targets and productivity work with our staffing, and we're in a really good place with being able to kind of right-size that. So, and we have a lot of takes on job openings. We're not seeing a decrease in the number of people who are applying for our jobs, and so it's pretty healthy on that end.
Can we go back one slide? This is an important slide for me. You know, not all surgery is the same. Right? You can have 100 eyeballs, different than cardiac surgery type thing. So I'd like to understand or to look at, you know, where are the growth assumption coming from? is it from existing surgeon or new programs that we put in? Right? Because it's, to give you an example, like existing surgeon doing more cases, or new surgeons, robotics, orthopedics, cardiac, oncology, or ambulatory migration to surgery. And because that ties with the acuity, right, with the case mix index and all that stuff. And depends on our growth coming from high acuity procedure or just a simple volume. Because some of the investment that we go through approving new technology or new stuff for that area, I just want to make sure that you guys build it from the ground up, but not just take this and say, our growth is this, and then just plug the number for growth, because that drives other decision-making process for us. I don't want to know the number, but at least the thinking around how we built those.
We built that by provider. We start at the service line level, then we go to the actual provider surgeon level, and look at what cases we think are predicting that they will perform. We mentioned earlier the importance of moving those outpatient cases to the outpatient setting. And so we know there's opportunity, for example, in the general surgery area to move them out of the outpatient, the inpatient area into the outpatient area, so we know we're going to see growth there. We're currently evaluating other procedures that might be new that we would start performing. We have a new EP surgeon starting in the fall, so that's part of this prediction or this modeling that we've done for next year, in addition to some other key specialty surgeons that will be joining in the fall.
So like when you move them to an ASC environment, then we have to worry about anesthesia service and all that stuff. Are we still using the model of surgeon bring their own anesthesiologist, or is it one?
Sound is our anesthesia group.
Okay. Do we have a policy to look at how we use anesthesiologists, CRNA and CAA? Do we use CAA? And then are we compensating them equally so that we look at the quality and the outcome? Because otherwise it may perceive as trying to lower the cost and sacrifice on the quality type thing. So I just want to make sure that we are looking at those things also.
So, I would say that, I don't know if you want to answer that, Dr. Assad.
Yes.
There is a very standard supervision ratio, which is 4 CRNAs to 1 MD, and we don't deviate from that. There's also a ratio for the student RRNAs to the CRNAs, and there are locations where we actually don't allow the RRNAs, it's only CRNAs, but the ratio of CRNAs and MD, we do not deviate from.
And we don't have CAA?
That I don't know what is the CAA? I apologize.
The anesthesia assistants. There's a lot of organizations moving toward that.
We only have CRNAs and MDs.
Okay. Are you sure that sound doesn't use CAA?
No.
Okay.
Dr. Fowler, I know you do scopes. You do.
To my knowledge, yeah.
No. Yes.
And sound's billing or we billing?
They do their own billing.
Okay.
Our acuity of patients would not allow, I don't know what that CAA is, but we only do MDs and CRNAs.
And I should have asked this when we approved the new rate and everything else. Is there a set realization of what, if they don't get paid, or is there a set minimum that if they don't get paid appropriately by the case, we subsidize, or how does that work? Anybody knows?
There is an agreement that we pay and we reconcile based on fair market value that we pay for the physicians and the CRNAs. And we do fair market against their collections, and then that is what we pay to Sound.
Is that the contract
That's the contract you saw at the last meeting. That was
And
approved
today.
today, yes.
That amount is what they're not able to collect directly.
Correct.
That's our subsidy. They also bill and
That's a good-
collect on
that's a-
Medicare and Medicaid pays.
Or
the-
commercial, yeah.
Yep.
So what we're paying today that is in that contract is for the collection, is for connections or what you call self-pay mainly.
It is for the gap between their collections and their cost of providing the service to us.
So even in Medicaid, there may be some subsidy that we're paying.
So they are guaranteed 100% for them, which I still believe there should be some review of that. I mean,
My concern is
Yeah.
this, right? If we have that in place and they're not doing a good job with their revenue cycle management, we underwrite everything of their
Yeah.
mistake. Give you an example. If a patient coming in here and is in network and supervising the case, so that they're gonna split the bill into one case can have one bill, two bill, or three bill, right? Because if you're an anesthesiologist, you're supervising, and then if that's the block, you do another claim for block. If they put them all in one, they're not gonna get paid. And then if they are out of network, they're gonna get paid very low, unless they know how to bill for out of network. And it has to be under ERISA. And if they don't bill correctly, they may realize
So
$200 or
DT,
$300, where the claim could be $2,700, and we're gonna underwrite all that stuff for the lack of knowledge on that side.
DT, I'm totally on board. Anesthesia is very difficult to bill on the pro fee side and not always done correctly. We have the ability in the contract to audit their collections, and they just converted billing systems, and so we are on plan to audit their current billings and collections, and we are allowed to do that in the contract. So to your point, we bring in somebody to audit their billings and what they're doing against.
Do we know enough? Because, let's give you an example.
We aren't gonna do it. We will bring a third party who is an expert at anesthesia billing in to do that for us.
Are we bringing like Marwood or somebody else in there to look at it, to do that QOB? Give me an example. Under contract, let's say for you supervising, you charge 3 units.
Correct.
But if you out network, it's 5 units for the anesthesiologist. Not a lot of people knows that.
Right.
I can guarantee you that much. So, okay.
Thank you.
All right. I think, Mr. Chair, we'll do one more slide and take a quick break, if that's before we get to the revenue, because Mike is gonna, I think everybody needs a break before Mike. So the last slide just oops, sorry, we went back slide. These are the total outpatient volumes. This just brings together all the outpatient that you just saw, plus the ancillaries. So we do over 1.2 million in visits, so 100,000 patients a month that we see, half of them coming through the clinics. The line that you see, the very dark one that says ancillary, that's for the visits that are like lab or imaging alone. So that's what those are. And so as we go up this, 1.2, it's a lot, 100,000 visits a month is what we're doing to serve this community, and the demand continues. And so this is, the whole conversation we just had, and your input has been fantastic, is around how we build the volumes based on what we see the community asking of us to serve them. So is any other input that we can always take input later too? If you think about it, take a break.
We are busy.
We are busy. I think we say that a lot. We are busy.
And ancillary is mainly lab.
It's lab radiology, anytime like one-time, physical therapy, those types of unique one-time services you would get. All right, so are we, Mr. Chair, do you, 5 minutes, 10 minutes, quarter after?
Be fine with me.
10 minutes,
10
quarter
minutes.
after?
10 minutes, thanks.
Back. I'm glad you got a little break because the revenue section is going to get a little intense for you. We do have 4 streams of revenue. We have our patient revenue, we have supplemental payments, we have specialty pharmacy, and then we have other revenue that includes grants and some other revenue from pharmacy assistance program. So as we look at our mix of revenue that we have as an organization, and of course my notes aren't moving either, you saw this, for those of you here last year, you saw this. This is the mix of, our 5 sources of revenue, because I forgot to mention the ad valorem when I just said that as a 5th source. The dark blue on the left side is our net patient revenue, and you can see over time that more of our revenue has been coming from net patient revenue. The middle source is pretty standard, constant, and then the ad valorem has been going down while the patient revenue has been going up. So not as much dependency on the ad valorem as we look at the mix of our revenue. And I'm not going to say dependency is a light word, so it's not as big of a mix of the revenue that we receive, but still important to the revenue stream we receive. The revenue sources that we have for the supplemental payments, you're going to see this in another chart form when Mike is done. But if you look from the bottom up, we get somewhere between $200 to $300 million over time in these supplemental payments. And you'll see there's various programs. The legend is on the right. I'll give you an example. Look at the blue bar as you move up. 23, big number in 24, little number in 25. Remember last year we had a $60 million reduction in DISH. And then, 27, there is no blue line. Well, that's going into HARP, which is the dark blue line. So these things are moving around and they're kind of crazy. I'm going to show you the absolute numbers once Mike is done. But let me introduce Mike to you. Mike is an asset that we cannot live without. He is nationally recognized in the Medicaid space. He helps us with the Local Provider Participation Fund, or the LPPF, that we facilitate for the hospitals in the county. That is a pass-through program to allow these hospitals to gain matching funds from the federal government in order to support their providing care. So I will turn it over to Mike to give you some overviews over Medicare and Medicaid. And this is a presentation we do every year because we all learn something every year when Mike does it. So don't feel like we know everything either. So thank you, Mike, for being here.
My pleasure. It's always good to be with you here at JPS. You're my favorite client, I must say. Don't tell my others I said that, but you are my favorite client. And it really is a pleasure to work with Dr. Duncan and Kim and her staff. You have really strong people here, and people really committed to your mission, and it's therefore a pleasure to be able to assist you and work with you. Today, Kim asked me to talk about, to sort of polish my crystal ball and talk a little bit about the future of supplemental revenue programs. At the outset, let me apologize because I'm going to throw a whole lot of acronyms at you today. There is a cheat sheet at the end of the presentation. You can go look in the appendix and it'll give you a list of those. Memorize a few. You can throw them around at your next dinner party and impress people. I will say that, as you could tell from that previous slide, one of the reasons we're talking about these programs is that they are extremely, extremely important to JPS and other safety net facilities. It is not exaggeration to say that without supplemental revenue programs, there would be no safety net. There would be no safety net facilities. Now, having said that, as that previous slide also showed you, the mix of supplemental programs has changed and will continue to change dramatically. And so I'm going to talk a little bit about the importance of the programs, give you a little bit of history, and then talk about the programs in particular. And if you have questions as we go through, don't hesitate to stop me. First and most important, why are supplemental programs important, and how can we categorize those? Because there are really three different kinds of supplemental programs. The most important point here is the last one, that to restate what I just said, that they are essential to the very survival of safety net facilities. You simply cannot survive on Medicaid and uninsured patient revenues. Even though those patient revenues are becoming a larger part of your revenue stream, you still cannot survive on those payment streams. And luckily, public policy recognizes that. So if we think about the supplemental programs, we can think of them in essentially three different buckets. The first bucket are those kinds of programs that directly supplement the cost of care to patients who are uninsured or Medicaid patients, the patients that you lose money on. And unlike hospitals that take care of a large number of commercial pay patients and Medicare patients, you don't have a place to cost shift. You can't make up for the losses there with profits off of commercial pay patients. So these supplemental payments serve that function. They are designed to bring you, if you will, even with respect to that class of patients. The second big group of payments are directed at services that themselves are costly and cannot be easily covered by the revenue streams that you have. And so trauma services, graduate medical education, those kinds of services, I don't have to tell you, operating a level 1 trauma center is really, really expensive. And it's expensive whether you have patients or not. It's not as though you can shut it down and say, we don't have anyone coming today, so we're not going to pay for it. You have to maintain that regardless of volume, regardless of payer source, regardless of what's happening out there. And so these payment streams are designed to reimburse you for those extraordinary cost services. And then the final bucket of care that I would suggest is relevant to the supplemental programs are those payment flows that are designed to redesign the health delivery system. Those payments that you get, for example, that are intended to improve coordination between managed care plans and providers, or to improve information systems within the hospital. They're not directly related to the patient population you're serving. Rather, they are intended to make you more efficient and better able to serve those patient populations. So keep that in mind as we're talking about that typology, as we're talking about these programs. One other thing I want to say at this point, which is also important to keep in mind as we talk about individual programs, are limits on payments. It is not as though the federal government or the state government can pay you whatever they want to pay you, assuming they did want to pay you for all those things that you do. There are limits on how much you can be paid. And there are three particular limits that are relevant to keep in mind as we talk about these payment programs. The first is the DSH limit. And we're going to talk about the disproportionate share payment program. It's one of the oldest programs that is out there. I was actually involved with the creation of the DSH program in Washington way back when. And so there is a limit on DSH payments. If you are a DSH hospital, you cannot receive more than your cost of care to patients without health insurance. That's the exact language from the statute, plus any unreimbursed cost you have for Medicaid patients. That is your limit. And so we calculate that amount, and all these other supplemental payments, everything we're going to look at, if it is a Medicaid payment, it counts against that cap. And so one of the things we're going to see is that these programs are interactive. You increase one, you decrease another because of these limits. The second limit, the uncompensated care or UC limit, that is simply a variation on the DSH limit. That exists pursuant to the Section 1115 waiver that governs Medicaid within the state of Texas. I'm going to talk about the 1115 waiver in a little more detail shortly. That limit is the DSH limit plus some other costs of uninsured patients that you can include in the DISH limit. So if you employ physicians, for example, and they serve uninsured patients, you can now include those costs in that limit. So it's slightly higher. The final limit is the Medicaid charge limit. You cannot be paid more in Medicaid reimbursement than your total charges for Medicaid patients. And that's important because, again, as we have these supplemental payments and they're counted as Medicaid payments, it's not just the patient revenues that you have to worry about in terms of the charge limit. It's also all the supplemental payments that go into that as well. And we're going to see an example of how that has actually impeded the ability to make certain supplemental payments and what the state is doing about that. So keep those things in mind as we begin talking about these programs. So let's look at the history of supplemental payments. In the beginning, there were graduate medical education, or GME payments. Those are sort of the oldest supplemental payments that existed. They were created both within Medicare and within Medicaid. And I'm going to talk a little bit about the Medicare supplemental payments, though most of my time is going to be spent on talking about the Medicaid programs. Then, in the mid-'80s, we created this proportionate share hospital program. DISH payments were created as a result of the disconnection between Medicare and Medicaid. In the mid-'80s, there was a rule known as the Boren Amendment that required states under their Medicaid programs to pay what Medicare would pay. The good old days when you could get Medicare-level payments for Medicaid individuals. We haven't had that for a very long time. Congress passed, in the Reagan administration, a new rule that disconnected the two programs and allowed the states to pay whatever they wanted. Guess what states wanted to do? They wanted to pay less, and they did. And so, as a result of that, the ability to again, cost shift onto Medicare for Medicaid individuals due to the Boren Amendment was lost. Hence, we created the disproportionate share program. And what the disproportionate share program did was it said, look, there are some safety net facilities that take care of so many, a disproportionate number, of low-income patients that they need additional reimbursement to help cover those costs. And so we wrote the statute, we set qualifying criteria, a disproportionate number of patients. Then, of course, the folks who were not going to get DISH payments got involved and said, well, let's amend that. Believe it or not, in order to be a disproportionate share hospital provider today, you only have to have 1% Medicaid utilization. I don't know, that doesn't sound very disproportionate to me, but that's the federal statute. And so states took advantage of that, and states especially took advantage of that to make state-owned facilities disproportionate share hospitals. And guess what? State-owned facilities, including those in the state of Texas, are generally guaranteed 100% of their allowable DISH or UC caps. They're first in line for these payments. At any rate, we've got GME, we've got disproportionate share, and that's where things stood until the early to mid-'90s. At that point, I and others realized that under then existing rules, as long as you could come up with a state share, as long as we could, and you do this in large amounts, as long as you could intergovernmentally transfer tax revenue to the state, we could fund additional supplemental payments. And so we created the UPL program here in Texas. And the only thing, there's nothing particularly complicated about UPL in theory. It simply lives within the DISH caps because no safety net facility was ever paid their DISH cap. And under UPL payments, now we IGT, and we could pay facilities up to the amount that a commercial payer would pay for similar services. And so very important revenue stream. In fact, UPL became more important than DISH to safety net facilities. And then the final iteration of that occurred in 2011 with the implementation of the Section 1115 waiver. And there, we created a new program called the UC program. The reason for that was that UPL was under threat. The feds had published, in the Bush administration, they had published a rule that would have greatly limited the amount of UPL payments that could be made. No longer would the equivalent be the commercially available rate, it would have been a much lower rate. Then the next threat occurred early in the Obama administration when there was an attempt legislatively in Congress to totally eliminate UPL payments. They would no longer be allowable under federal law and rules. And so we, working with HHSC in the development of the 1115 waiver, said, let's simply take that program, convert it into the waiver, because the way a waiver works, the first and most important thing about the waiver is the calculation of what is known as the budget neutrality limit, the total amount the state can spend over the term of the waiver, calculated on an annualized basis with inflation. How do you get to that number? You look at what you're spending today. We looked at everything we were spending, including UPL payments, calculated the budget neutrality number, and then took all that UPL, converted it into a UC program, and that's why we now have UC payments today. The other thing that happened under that waiver is the expansion of all of these other acronym programs. The Fed, CMS, they've never been particularly fond of DISH or UC kind of payments. I once had a CMS official say to me, we don't like these programs where you just put the money on the stump and let the providers come and get it. We want them to do something for the money that we're paying. And in fact, what in the early aughts and teens they attempted to do was implement through waivers pay for performance. So now we're going to have these programs. You will get the money provide you meet certain performance standards or thresholds. And so we have a variety of programs which I'm going to talk about under the 1115 waiver. All right, so let's back up for just a moment and talk about Medicare. I will only spend one slide on this. From a dollar standpoint, it's not as important as all the Medicaid programs, though the amount's not unimportant either. So Medicare is a federal-only program. Medicaid is a state federally funded program. Under Medicaid, the state makes the rules. The state creates the programs. The state puts up its share. It claims the federal share of money. It makes the payments to the providers. Under the Medicare program, it is purely federal. This is all federal money. It's all governed by federal law. It's all governed by federal rules. The formulas are there. And so there's really no role for the state to play in this. There is Medicare DISH. You qualify for Medicare DISH. I believe you were actually a pickle hospital under the relevant rules, named for former Representative J.J. Pickle here in Texas. And under that provision, you automatically, as an urban hospital, qualify for Medicare DISH payments. The formula is set in statute. It is not subject to change. The only thing that really affects these payments is the amount of money being budgeted by the federal government for DISH. These are very stable. They also do not interact with Medicaid. So they don't count against any of those caps that we talked about before. You get $61 million, or did in 25 in Medicare DISH. You get 16 in GME payments. Again, all this is by formula. Under GME, there are both direct GME payments and indirect GME payments, pursuant to formula contained in federal law. So the good news is that that's all you really need to know about the Medicare payments. They are stable. They are set by federal law. They're not subject to much change absent budgetary changes at the federal level.
I have a question for you. Mark.
Yes.
Medicare DSH and GME appear to be very stable now, according to. As JPS continue to expand residency program, are these opportunities to grow GME funding proportionally?
So, and I'm gonna ask Kim to jump in here as well, but the short answer to your question is that there's only so much that you can do because there are residency slots assigned. And if you expand the program beyond what's allowable under federal law, you're not gonna get paid for it. So I'm not sure where you are now with respect to that.
We're over our cap.
Okay.
We are over our cap. But we are consistently, Dr. Elliott's staying on top of it with our reimbursement.
Yeah, Dr. Elliott's looking to, to increase that
looking.
cap.
Looking for revenue opportunities.
I know you are. Thank you.
Thank you.
And, quite frankly, this is one of those areas where there does need to be change at the federal level, because I think most everyone agrees we have a doctor shortage at the moment. And how do we address the doctor shortage? We increase the pipeline that's there. In order to increase the pipeline that's there, we need increased reimbursement for residents, interns and residents. And so this is above my pay grade, but this is one of those issues that I know physician organizations are working on, that they're talking to Congress, and Congress really does need to deal with this. All right, let's turn to, that was a simple part. I started you out easy. Let's turn to the more complicated part of this. Medicaid supplemental programs. I've already mentioned most of these things. So DSH, GME, Section 1115 waiver. Under the Section 1115 waiver, there are a variety of programs. This is where our alphabet soup comes into play here. We have UC, which we've talked about. We also have the HARP program, the ATLAS program, the CHIRP program, the AFRICAT program, and the URIP program. I will give credit to those at HHSC that created these program names. I think the acronyms are very, very clever and creative. I especially like Africa, that one, and there's a Q in it. You gotta like those. These are interdependent programs that all affect each other, and I want to talk about all of them. Before I do that, I think I missed no. Thought I missed a slide. I did not. Okay. So let's talk about each of these programs. Historically, DSH is the oldest. Historically, it was the most important of all the programs. For many, many years, most of your money came through the DSH program. It has become less important in the presence of the 1115 waiver and with the existence of UC payments. The other thing that's really important to keep in mind with respect to DSH, Medicaid DSH, is that it is not particularly stable, unlike Medicare DSH. There are proposed cuts, significant proposed cuts to DSH that were enacted at the time of the adoption of Obamacare. And here was the theory. Under Obamacare, we're now going to cover more individuals. We're going to do it through these supplemental regional programs, as well as generally increasing market-based insurance. If we do that, there are going to be fewer uninsured individuals going to places like JPS, and therefore they're going to need less DSH funding. Makes a lot of sense, right? If now you've moved someone from the uninsured bucket into the insured bucket, you don't need that payment for the uninsured anymore. The only problem was it didn't quite work out that way. Very early on, there was a Supreme Court case that challenged the ability to require states to cover individuals. The whole premise of this reduction in DSH was that states were going to have to cover uninsured individuals. Those individuals would then have payment attached, and we wouldn't need the uninsured payments. But now that became optional, and so many states, especially red states, did not expand Medicaid coverage. They created the market-based insurance program, but they didn't cover more individuals, bring them into the Medicaid program. Even though, by the way, the federal government was going to pay 100% of the cost of that increased Medicaid coverage. And so that undid the rationale for eliminating DSH payments. So providers went back to Congress and said, delay the cuts. The cuts were supposed to be delayed for a couple of years. It's now been over 10 years, and the cuts are still delayed, but there has been a rattling of now instituting those cuts. There was an attempt to do that in the big, beautiful bill, and that attempt was beaten back. But there is a lot of noise that it will happen in the near future under the federal budget. Earlier projections, this will be devastating for states like Texas. You can see the percentage here on the slide. 56%, over half reduction in the amount of DSH funds flowing to the state of Texas. The only good news for you is that you are much less dependent on DSH than you used to be. And as I'm going to get to in a moment when we talk about HARP, for the coming year, you're really not dependent upon DSH at all. And so your exposure here to the federal cuts is very, very minimal. One of the other things I want to mention as well, I'm going to get at the end here to my crystal ball and the known unknowns and the unknown unknowns, and to quote a former defense secretary. But one of the things I want you to keep in mind as we build toward that is the unpredictability of these programs. I said at the federal level, Medicare, DSH, and GME is really only uncertain based upon federal budget priorities. Here, that's not the case. The amount of DSH you get is dependent on several things: policy decisions that are being made, budget decisions that are being made, but also what's happening among your fellow DSH hospitals. This is a limited pie. If one hospital gets more DSH because their DSH cap went up, everyone else gets less. And so in any given year, trying to predict what you're going to get from some of these income streams is really, really difficult because we don't know what's happening at other hospitals. I can answer the first two questions. I can tell you what's happening from a policy standpoint and a budget standpoint, but what I can't tell you is whether uninsured utilization is going up at Parkland or Harris County. Hint, it did significantly at Harris County over a year ago, which affected you. All right, so that's DSH. Graduate medical education. $7 million. Again, this is a state-created program. It mirrors the federal Medicare DSH program, GME program rather. This has a standard formula. It doesn't change a lot. 5 years or so ago, there was a revamping of the GME program here to the benefit of safety net facilities like JPS. Bottom line here, this stays relatively constant year from year. It's also not a large amount of money in terms of the overall supplemental budget revenue stream. The Section 1115 waiver. It's important to understand how the waiver works and then look at how the programs operate within that waiver. The first and most important point about an 1115 waiver is it allows the Secretary of HHS in Washington to waive any and all requirements of the Medicaid program. Any statutory provision the Secretary can waive. It also allows a lot of flexibility on the part of HHS in terms of calculation of that budget neutrality number. In the last iteration of the 1115 waiver, and the 1115 waiver here in Texas, as I mentioned, was adopted in 2011. It's been renewed once, and for a long period of time. The budget neutrality calculation under that waiver was extremely favorable to the state of Texas. It was in some quarters characterized as Trump's parting gift to Texas at the end of the Trump 1 era. The waiver then allows the state flexibility with a large amount of money to implement programs both to care and reimburse for uninsured patients, but also to bring about some of these systemic changes that I was talking about before. As I mentioned before, the first waiver folded all the UPL program into UC, so UPL went away. All that is now paid through the waiver. The second thing that the waiver did is it created this program we call DSRIP, the Delivery System Reform Incentive Program. And what that did was it paid money to providers to make certain changes in the way care was delivered and the way care was coordinated. You can now forget about that acronym because it's gone away. So, the timeline. Originally approved in 2011, extended in 2016, formal review, then a 10-year extension in 2021. This, by the way, is the only 10-year extension of a waiver in the history of any 1115 waiver program. Look at the number, $3.87 billion a year allocated under that waiver. A very generous program. Then the Biden administration came along in 2021, and they rescinded, or attempted to rescind, the approval and to renegotiate the 1115 waiver deal, reducing the amount of money under the waiver. Under intense political pressure, they withdrew the rescission, and actually the amount allocated to the waiver increased from the previous amount. Finally, 2028 to 2030, there will be some recalculation of the budget neutrality amount based upon various factors, including uncompensated charity care cost. The other thing to think about in terms of the waiver is that the new directed payment programs have actually outpaced the cost growth, resulting in an expected reduction in UC. And let me just spend one moment explaining that jargon for a second. The other thing to understand about programs is that there are really two kinds of programs within the category that we've been talking about. Directed programs and non-directed programs. And what do I mean by that? If you are serving patients on a fee-for-service basis, you are paid directly. The program is created, state calculates the formula, it calculates your utilization, it pays you on some method, usually a per patient, per capita basis under that program. If you're treating patients through a managed care organization, however, they can't do that. It is impermissible under federal law to make a fee-for-service payment to you for someone who's enrolled in an MCO. Now, another rule comes into play called actuarial soundness. Under managed care plans, the managed care plan can be paid up to an amount that an actuary certifies to the state, that in turn certifies to CMS is actuarially sound. Guess what? Because states want to save money, they usually don't pay anywhere the actuarial soundness limit that's certified, creating an opportunity for directed supplemental payments. So how does that work? Now, the state creates a program. It makes an additional payment per capita, per member per month, to the managed care plan. But then it directs the managed care plan to make a payment to you. So if you serve one of its members, it has to pass through certain amounts to you as a directed payment, consistent with the requirements of the program. So you get both of these kinds of payments. And from a financial standpoint, they all wind up in sort of the same bucket, but it's important to keep in mind that one, you have more control over the fee-for-service payment, whereas the other is subject to either state direction or negotiation with the managed care plan. The LPPF. This is a little bit of a divergence from what I've been talking about so far because first, technically the LPPF itself is not a supplemental payment program. It's a funding mechanism. The second most important point about this one, or maybe the most important point, is you don't get any money out of this. You are doing this for the benefit of private providers in Tarrant County. And so how does the LPPF work? For many years, JPS and other public hospitals cross-subsidized private hospitals through the DISH and UC programs. How did that work? They cannot make an intergovernmental transfer for the obvious reasons they're not governmental. You can make an IGT. You make an IGT of the state matches that with federal money, it pays the money out. It takes some of the money you transfer to the state, it matches it for the benefit of private providers, it pays them a DISH payment, or it pays them a UC payment. In fact, for several years, we were actually disadvantaged under the formulas because we did not get credit for the amount that we were transferring on behalf of those private facilities. Luckily, we changed that formula. We gave ourselves credit for that IGT amount, so we were no longer at a disadvantage making payments, making IGTs on behalf of those providers. However, there was also a limit to how much we could do. Your limit was the amount of ad valorem taxes you could raise. So, what do we do? What did private hospitals do? They created the LPPF, pursuant to federal law. Now, you act as a taxing entity, you raise funds, that money goes into a dedicated fund, the LPPF. You now transfer that money on behalf of private hospitals to the state matches that with federal money, they get paid through these various programs. You are not using your own revenues anymore to cross-subsidize private facilities. The only thing is that you also don't get a benefit of that program as well. You don't qualify under the LPPF for any payments because the statute says the JPS can only be reimbursed $150,000 for its expenses in maintaining the LPPF. That legislation, by the way, is up for renewal. One of the things that we're going, and Kim and I have talked about this, one of the things that we're going to do is at a minimum go try to increase the amount of reimbursement for your administrative assistance because that hasn't changed in 10 years. But I put this up here so that you know not only are you a receiver of funds, you fund these various programs for private hospitals, make sure they send you a thank you note. Next, uncompensated care.
Mike, are we required to do that?
Are you required to do that? No.
So we're just being good neighbors?
So you're being a good neighbor. You are doing this because I am quite sure, Dr. Duncan, if you decided, did this board decide they were not going to do that, that you would have every private hospital in Tarrant County down at Commissioner's Court yelling and screaming about how horrible you people are and how you're trying to destroy them. So,
Probably be well received.
To as a good neighbor and to promote peace and harmony within the community, you do this. But under the state legislation, you are authorized but not required to do this. The other thing is that, and I don't know how many of you know this, you actually have an agreement with the private hospitals to do this, and they are required to do certain things under that agreement. They don't always do those things, like, for example, giving you information. You are entitled under the agreement to request information from them. That doesn't always happen, but this is voluntary on your part. All right.
I think it's important for the board to know that there is a third party that is facilitating this for the private hospitals. We are the mechanism and we do the billing, but there's a third party that decides how it gets distributed. And so I just think it's important the board knows that.
Absolutely. And so I want to be very careful here in what I say and how I explain this. Under federal law, we can impose this tax on the private hospitals. The tax has to meet certain federal criteria. It has to be broad-based, it has to be uniform, there can be no hold harmless. We cannot adopt a special rate for some hospital as opposed to others. We have to tax everyone within our jurisdiction. And most importantly, we cannot make any offset payments to any provider as a result of that tax liability. If we do that, we are in violation of federal law. The entire program falls apart. We are subject to repayment of all those monies that we collected. And so one of the things I stress regularly in our phone calls is that we have to be absolutely 100% certain that we are following those rules and we're applying that tax in a legal manner. The second point regarding that is that we don't control then how the money is distributed to the individual providers. We make the IGT to HHSC. They then make the payments to the individual providers. And for the reason I just explained with respect to hold harmless, we can't know what, and do not want to know, what private providers are doing among themselves with that money. So there is this third-party entity that is doing something, but we don't know, we don't want to know, we want to make sure that we are protected in terms of any potential argument regarding hold harmless. That doesn't mean, by the way, that we can't ask them for utilization numbers, for data regarding their uninsured patients, for any expenditures of those monies. That's fine. We just can't exercise any control over that payment. Make sense? Yeah.
This seems like a Gordian knot. Is this the same in all the states, or this is just how Texas funds their non-governmental share?
So this is fairly unique to the state of Texas. There are no LPPFs I'm aware of in other states. The main reason for that is that most states don't have public hospital districts with taxing authority. So take Georgia, for example. There are public hospitals there. They IGT to the state to fund DISH and UC and other, or UC-like payments and other similar payments, but they don't have revenue authority. They don't have taxing authority. They could not create an LPPF and levy a tax on the other providers within their jurisdiction. And so what happens in most other states is that you have this rather random hodgepodge of public facilities that have money that can IGT. So you have a bunch of urban facilities that are public. You have private rural hospital districts that receive state money. They can IGT that money. But you don't have this kind of LPPF model in other places.
And why is the IGT necessary, no matter how it's funded? That's a Medicaid rule?
No, it's not a rule. It's a practical reality. Without IGTs, the state's not going to make these payments. The reason so DISH, when it started in the late 1980s, the first year the DISH program was $12 billion. That was it. I say 12 billion, like it's a small number, but by Washington standards, that is a small number. And the reason was simple. Even though the federal statute told states, you must make additional payments to these facilities, states didn't do it. They didn't do it because they didn't want to spend general revenue funds to use as a state share to make these payments. And so the thing I did early in my career, the thing I figured out was that under the statute, we could actually use local funds, governmental funds, to fund the state share. So I went from state to state and I said, all right, you've got a public hospital here. That public hospital can make an intergovernmental transfer to the state of its revenue, of its tax revenue, or actually any non-Medicare revenue that it receives. The state can use that as a match, and it can then turn around, draw the federal funds down, and pay that to the provider. And so within a period of 4 years, the DSH program had grown by 20-fold. States didn't have to put up their own money. Now they were more than willing to make those additional payments. But you had to have public hospitals, governmental entities of some sort that could make those IGTs in order for that system to operate. The weakness of that program was that the program was heavily dominated, not surprisingly, by public hospitals. Private hospitals wanted to get in on the action. They started lobbying for getting their share of the payments, but they couldn't put up any money. And so now public hospitals were put in the position of cross-subsidizing those other facilities, which reduced your net payment. This LPPF mechanism solves that problem. They now pay, in essence, they pay for themselves.
I thought we weren't getting any money.
You're not, but you're not losing any money either. You're now not having to put up your ad valorem tax revenue to support a payment to THR. You're IGTing, but you are IGTing only for the payments that you receive. You're technically still IGTing, but you're IGTing LPPF funds, the money they pay in taxes to you to pay for their payments. Does that make sense?
There was a point you said where the private hospitals didn't get any of this and lobbied to get in, but if the public hospitals weren't getting anything and the private hospitals weren't getting anything, who was getting anything at that point?
So at that point, public hospitals were getting something, but they were getting only what they were funding for themselves. And so we got DSH payments, we got UC payments, but we are transferring your ad valorem tax revenues to Austin. That's being matched. It's coming back. The amount you transfer plus the federal money is coming back to you. So you're happy to do that, right? You get your ad valorem tax money back, and you get this federal money that you wouldn't have had but for that transfer. The private hospitals couldn't do that. So they said, well, we want that too. But the only way they could get that was that if you transferred for them. And of course, the public hospitals said, wait a minute. Why are we giving up our revenue, transferring our dollars to go subsidize these hospitals? If they want to get in on that, if they want to participate in those programs, they need to put up the money for themselves. Some states solve the problem by levying statewide provider taxes. So Alabama, for example, every hospital in the state, except public hospitals, pays a provider tax. The state collects that, they use that to match, they transfer it, they don't have to transfer it. They tell the feds they have it, the feds give them the Fed match, and then the provider tax along with the Fed money gets distributed out to the private providers. There's one major weakness, one major problem from their standpoint, though, with those kinds of approaches. There are winners and losers. If you are a private provider, private hospital, serving a large number of Medicaid and uninsured patients, you are happy to do this. Let me pay my tax. I'm going to pay my tax on net patient revenue. Now I'm going to get a big payment for those patients that I am seeing that I'm not getting paid for. If, however, you're a private hospital that primarily serves commercial patients, you don't like this at all. I'm now going to have to pay this tax for my commercial business. I don't serve Medicaid patients, at least not many of them. There is no way a supplemental payment coming back to me is going to cover the amount of my tax. So I don't want to pay that tax. And that's a dynamic that occurs at the state level. The LPPF solves that to a degree in that now the fight over provider tax is not statewide. It's now locally. Are there winners and losers? Sure. I imagine THR is probably a loser under this tax. But you're not having to deal with every hospital in the state in order to implement a provider tax. Plus, the third-party administrator of this is probably doing something there to keep everybody happy so they keep paying. We, however, as JPS, we don't involve ourselves with that. We levy the tax. We levy it on a broad-based amount. We collect it. We IGT it. And then it's the state. We are advantaged by this in that now we're not having to use our own dollars to IGT. We're using their dollars in the LPPF to IGT for them. We save our dollars to IGT for ourselves.
One more question. It's interesting that forever JPS was the only Medicaid in Tarrant County. But you're saying this is probably adequate enough that one by one other hospital systems have opened up to Medicaid more. So it's enough money in there for that.
Well,
I
think like Cook Children's probably has quite a bit of Medicaid, right? I mean, they have their own managed care plan and.
Baylor's Cotton White's not always taking Medicaid, but now they are recently.
Yeah, and that's an important point is that Dr. Duncan said earlier, people are not actually out there competing for your patients, and that's very true. But at least with some of these supplemental payments, other facilities who might have been on the margin, now there's enough money there that they're not turning them away. You know, they're not doing wallet biopsies at the door or having a taxi fleet outside saying, take them to JPS. And so it does in an indirect way, at least, broaden the safety net a bit. Are we where we need to be with respect to that? No. But you're not entirely by yourself serving this patient population.
Competing over Medicaid seems like an oxymoron.
Exactly. And traditionally it has been. I mean, people just don't compete for Medicaid patients. However, do keep in mind, and I saw this happen in real time in St. Louis. St. Louis Regional Medical Center they only saw uninsured Medicaid patients. They had zero commercial business. They had 1% Medicare business. Once we created these new payment streams for the uninsured and it supplemented Medicaid patients, suddenly the three other facilities that were in the same zip code that also were facing the same patient population, we're not just turning them away anymore. They now saw, well, we can at least break even, maybe make a little bit of money on this. They still weren't breaking down the door to bring in Medicaid patients, but they weren't shipping them to St. Louis Regional Medical Center anymore. All right. Great questions. HARP. Now just think about it for a moment. How long do you think it took them to come up with augmented for this acronym here to make that one work? So the Hospital Augmented Reimbursement Program, or HARP, $58 million. This is really sort of another method. This is in the same bucket as DISH and UC. This is another form of payment that seeks to subsidize your uninsured and Medicaid patient population. It's authorized through the Section 1115 waiver. One of the reasons this exists is, again, because we have this very favorable budget neutrality amount there. This was created initially as a transition program. In the original waiver, there was DSRIP, which I had mentioned, which was a delivery system reorganizational model. there was no real accountability and there was no performance under DSRIP. And so in the renewal, they got rid of DSRIP, they created this. This is, as I say, much more, this is not really performance-based, it's much more like DISH and UC. The HARP methodology is subject to change, has been changed, will be changed again. In fact, just recently, they've revised the schedule and the forecast. And so for 27, the amount of HARP money is supposed to double. This will result in a significant increase in money for JPS. It will also mean, and this goes back to Kim's earlier slide, you essentially won't be getting DISH anymore. This will replace the DISH money that you were getting. Remember, you were subject to the DISH cap. You're subject to the UC cap. So when we double the amount of HARP that you're getting, it means those other payments have to decline in order for you to remain within that ceiling. So the reason for this change on the state's part is that I mentioned earlier the Medicaid charge ceiling that was there. So for certain providers, the Medicaid charge ceiling was limiting the amount of Medicaid payments that it could get. HARP counts against that charge limit. And so by redoing the way the formula works and adjusting its relationship to DISH, they allow more people to get HARP. They take the money that was being left on the table for HARP because of the charge limit. They now redistribute it to other people that had room under their charge limit. So they expend all the money under HARP under the waiver, which then reduces the pressure on DISH. And again, that's a good thing. I mean, I've got to compliment HHSC for this strategy because per the previous slide, if there was going to be a 56% reduction in DISH for the state of Texas, you don't want your eggs in that basket. You move it to the waiver under HARP, you guarantee you're going to maintain those payments. If there is a cut to DISH, it has little effect on the state of Texas. So, good way of doing this.
Questions. You're talking about Medicaid DISH here only, not the Medicare DISH.
Correct.
And second, I know how our state works. How did they figure this out quickly enough to make this change in time to help everybody?
They have providers helping them think about these things. There is a challenge at HHSC, and I'm trying to be fair to them. There are staff challenges there. It is tough to get people to work on these programs, but there are lots of hospitals that have experts. There are lots of consultants running around that we think about these things, and so that information is flowing to HHSC. And also, Blake, we've seen this stuff coming. This is not as though this suddenly popped up and now we are in crisis and we've got to do this. We've had 12 years to think about DISH cuts, and so a lot of time to think about how do we mitigate the harm that could result from that.
Is HARP Texas only?
HARP is Texas only. Yeah. Other states, we're not the only 1115 waiver, as I mentioned. We're the probably at this point the longest standing 1115 waiver and certainly the most generous 1115 waiver in the nation. Other states don't have a HARP program per se, but they have variations on the UC pool, and they have sub-pools under their UC pool, which accomplish essentially the same thing. You can use UC in the same way that HARP's being used here. With the right waiver, I can now move money out of DISH. I can move it under the waiver. I can protect it from any DISH cut.
And are is it similar metrics to qualify for HARP as for DISH? For JPS, we have to check similar boxes?
That's a great question, and I'd have to go refresh my memory. Do you remember the qualifications for HARP? I know we don't have any trouble meeting the qualification standards for DISH, UC, or HARP, so I don't tend to pay a lot of attention to that.
None of the safety nets have a problem meeting the requirements.
Yeah, I mean, any of these, we are going to be there. Your utilization is such that you're never even close to dropping out of any program. But I can follow up with you on that.
Drop out, but you may get $1 million less, or something like that.
Well, that's a different question, though. That has to do with the distribution formula within the programs. And so utilization is important from that standpoint. And I'm going to talk about that a little more in terms of that interactive effect that I talked about. Because that's one of the biggest unknowns that we have to deal with. But I'm happy to follow up with you on the HART requirements if you'd like for me to.
Okay.
All right.
Be careful when you make that offer.
We'll work with Mike and get it for everybody.
That's the question I was, is there retroactive payments that can be done off HARP Medicaid? Or that's set, plateau year 27 and beyond, you go back?
No. So there, for all these programs, there's a reconciliation methodology. And so the initial payments were made based upon lagging data. We're always a couple years behind the data that's being used for reimbursement. And then all that subject to final reconciliation against cost reports. But in terms of the change in methodology, no, it's a go-forward basis. So these, and this is important to understand, when the state makes these changes, every change is subject to CMS approval. They can't just go say, we're going to do away with DISH and we're going to pay everything under HARP. First, there's a federal requirement they actually have a DISH program, so they got to keep something in place. Second, the HARP program is authorized by CMS under the waiver. If they want to go change that, they have to have permission. When they did away with DISRUP, they had to get CMS's approval for doing that. Actually, in that case, it wasn't so much approval. CMS told them, we want you to get rid of DISRUP and do something else.
Mark, can I ask you a crazy question from a policy standpoint?
Sure.
And you can see how crazy I can get. We do away with the tax on tips, right?
I'm sorry, we do away with?
We do away with federal tax on tips.
Yeah.
Why not do away with tax instead of raising reimbursement and all that stuff? Medicare and Medicaid, make it tax-free. When you treat that, it's a lot easier for us to treat and recruit and retain doctors from burnout and everything else. Because if you look at an average primary care physician, right, the tax-free portion probably around $196,000 when you treat Medicare and Medicaid.
Yeah.
Make that tax-free, you have an effective rate of about $50,000 to $70,000. So now the doctor's making $280, now making $340 to $360.
Yeah, I was about to say, that certainly would go a long way to improving the pipeline for doctors if you knew that you were not going to be taxed on treating, this class of individual.
Because it's just moving buckets of money here and there and raise it up, and then it's a lot of politics play into that from administration.
Well, and it's an intriguing idea. I actually want to. It's a little crazy, I admit, but it's not too crazy to not think about, because it would address other problems that you have, access to care as well as doctor availability and access.
Especially rural area and everything else.
I would suggest to you that, one, that's going to be a heavy lift, because changing the tax code for individuals to eliminate that revenue base, there are going to be a lot of folks lobbying over that. But the other reason I think that it might be a really difficult thing to do is that the one thing that, let's take one step back. Think about this presentation. Mm-hmm. Think about all the pieces in here and the way these pieces fit together. Would anyone design, if you started from scratch, would anyone design a health delivery system that looked like this? I don't think so. But the reason we have this is because creating this kind of system gives those who run the system control over sub-pieces that they can adjust if they need to. If CMS decides, if they were to decide tomorrow that they don't like the Texas waiver and they want to renegotiate the Texas waiver and change the budget neutrality number and do away with these programs, they can go do that. Again, the secretary can do whatever the secretary wants to do. Now, they'd be sued by the state of Texas, but there is a control in this kind of lump sum payment bucket methodology for this patient population. And you don't have that if you did what you were suggesting there. All right, let me, I think I'm taking more of my allotted time. Let me move along here. Atlas, advancing technology for long-term information sharing. This was all a program to increase and improve electronic sharing of patient information, especially between HMOs and providers, but also among providers. $148,000 under this program. Sorry, that doesn't even meet the minimum level, minimum number of being important within the Beltway. Therefore, I'm going to move on to another program that.
Although it's $8 million.
Do what?
It's $8 million next year.
Okay, well, then we can talk about it next year. When I visit you next year, that's enough. We can talk about it.
What did you say it was this year, 148?
148,000.
This past year, it was nothing, then it got revamped. It'll be about $8 million.
CHIRP, Comprehensive Hospital Increased Reimbursement Program. So under CHIRP, there are a couple of different programs. There are, and I'm going to skip to sort of the bottom of this one here and focus on those payment programs. There is URIP, there's Africa. The URIP program just provides a uniform rate increase payment across providers. It's open to everybody. In some ways, this is redundant of HARP. It's another facility-specific way of improving reimbursement. Africa, Alternative Participating Hospital Reimbursement for Improving Quality. This is one of those programs I talked about before where there are desirable program outcomes. There is an optional pay-for-performance component in here. It's open to both urban and children's hospitals, not to everyone else. My sense is that Africa has not been well embraced by the hospital community, especially the pay-for-performance piece of this. This is something that CMS is interested in, and CMS pushed in terms at the time of the renew waiver. It's not unimportant in terms of the dollars.
I have a question, Mike, on this. It says managed care is paid through the managed care capitation rates.
Yep. This is directed payments that I talked about. So the way this works, again, we've got different caps that come into play. On managed care, there's actuarial soundness. We can pay more because the rates to those plans are under that amount. And on the fee-for-service side, we've got a different cap here. So now, several years ago, folks realized that we were capping out from supplemental programs on the fee-for-service side, that we were hitting up against DISH limits or UC limits or charge limits. You couldn't pay any more that way. And so now what we do is we direct the payments through managed care plans. We look at the differential between the capitation rate that is paid to the plan, the PMPM, and the amount that could be paid. We calculate that difference. We multiply it by the number of members. That gives us a global number of the additional amount that can be paid to the plan. Not surprisingly, if you're now going to make a payment to the plan to assist hospitals, the plan wants a piece of that increased reimbursement. So either there's a negotiation between the plan and the hospitals. Oregon, for example, pays through the plans, but they don't direct how the hospitals are paid. And so the hospital and the plans, fight it out over who's going to get what piece of the pie. In Texas, we actually direct a certain amount of payments flow through the managed care plan to hospitals. And so you now enter into an agreement with the managed care plan. That directed amount, the plan has to tell the state, we are paying the providers that directed amount. By the way, so I'm about to get to the crystal ball part, that has been controversial at CMS. CMS believes that the directed payments are an end run around fee-for-service payments, and their view is that once the payment has been made to an HMO, it is the HMO's money. And the state should not tell the HMO what to do with that capitated payment. So far, and they threatened to introduce a rule a couple of years ago that prohibited any restriction on increased payments to HMOs. Fierce lobbying, and they have backed off of that rule, and so as of now, directed payments continue. Multiple states use this methodology. In fact, it's the fastest growing piece of this expanded reimbursement universe. It will, I think it's unlikely that they will be able to restrict directed payments just because so many states have become dependent upon them. And if you think about this for just a moment, again, you're using non-state revenue to benefit both HMOs and providers, and that's what the state wants to do. And so states are dependent upon this as well and not having to spend their GR funding to increase rates to HMOs.
So to receive Africa or Europe money, JPS would have to be a participating provider?
You have to be a participating provider.
Medicaid HMO plan.
Correct.
Are we in one plan, Kim, or two? Multiple. So we're considered a provider. We're not running the plans, but we're a provider.
Correct.
Otherwise, we wouldn't receive any of this money.
Correct.
But so is there something, because this is a lot of information for me anyway.
No, it's a lot of information, period.
I know that you have you have the Africa up there, 22 million. Is there a dashboard? Is there something that
Just
shows?
at the end, I'll show you all the money.
So it's gonna be enough for
Yep, it's in your ear. It's in here. Yep, you got it.
Does all these programs sit on top of all Medicare, Medicaid, or only managed care, Medicaid, or just fee-for-service?
So these payments are on top of these are supplemental payments again. These are on top of what you're getting either through a payment from the HMO or on a fee-for-service side. So if you think back to Kim's chart before, when it has patient revenues, that first block, that second column there, the supplemental payments, this would fall into there. So it's related to your utilization, but it's not coming through as a payment for the service provided, if that makes sense.
Let's frame it a little bit different. Let's say you do the fee-for-service, and then you receive all this stuff, and then we create it and then participate in MSSP and team. Would that consider double dipping?
So let me answer your question this way. When the supplemental payments started, there was really not much managed care. Everything was on the fee-for-service side. And again, we could make UPL payments up to the amount that a commercial payer would pay for similar service. And we collect all the data, we figure out on a DRG basis what commercial payers pay, we figure out what that ceiling is for a particular service. Now, we treat a Medicaid patient, you get paid a set amount by the state, but I now know the difference between what you got paid and what you legally can be paid based upon that upper payment limit, and I now make a supplemental payment to you in that amount. That counts as a Medicaid payment. It counts against your dish cap, it counts against your UC cap. It doesn't count against your charge limit because it's a supplemental payment, right? Now, what happens next? We begin moving people from fee-for-service to managed care. The moment we do that, we lose UPL room. I'm treating fewer patients on a fee-for-service basis, which means I've got a smaller gap between what I was paid and what I could be paid. And now they're over here in the HMO, and the HMO is getting a capitated payment, and I'm only getting what I negotiate with the HMO. I've lost all that UPL that I had. But now I convince the state to create a directed payment. that is similar to the UPL. I load it into the capitation rate. So I look at the volume of the HMO for the previous year. I take my calculation of the UPL equivalent. I divide it by the number of patients, members. I then pay that through the capitation to the HMO. Now the HMO is very happy, but I hospital am still out of what I had before, so I get the state to direct the HMO to transfer, to pay a certain amount of that increased capitation to the hospital provider. And this can work in various ways. It can be a directed per cap, per member amount that's being paid. If JPS serves X number of members of HMO Y, we're now going to get paid a lump sum amount based upon a per member per month amount for those that we're serving of that HMO. Alternatively, it might just be a pass-through amount. Here's the increased reimbursement that the HMO is getting. Let's say it's $10 million. You guys are going to split it. HMO, you get to keep $5 million. $5 million you have to pass through to your providers. Different states do that different ways. But it all starts with the payments directed by the state, directs the HMO to pay the increased capitation in some form to the provider, and therein lies the rub. Either it's negotiated and HMOs will want to keep as much as they can, or there's a formula for directing the payment to the provider, and when that happens, CMS starts to get nervous, and that's what we saw with that, for that rule. That helpful? Okay, so the last slide. Where's my last slide?
You talk about the unknown.
There it is. Yes, I decided to quote a former Secretary of Defense when he was talking about knowns and unknowns. And obviously, the known stuff you can plan for, you can budget for. We have a sense of what the knowns are. The unknowns, you don't know what you don't know. Some unknowns we can predict. Some unknowns we say, here's where the trends are going. And so we can at least think about those unknowns. And then there are those where I've just got a question marks here where who knows. The starting point in thinking about this is that in Washington, we have a serious budget problem. Our national debt just passed 100% of gross domestic product for the first time in history. Our deficits each year are not getting better, they're getting worse. And we have macro changes in society that are going to exacerbate those, not make it better. More baby boomers retiring, more baby boomers qualifying for Medicare and Social Security. I'm one of those. Thank you all for paying for my Medicare and Social Security. And so that fiscal pressure is going to be felt in terms of program reform for Social Security, Medicare, and Medicaid. Guess which one of those three is most likely to face assault?
Medicare.
It's not Social Security, and it's not Medicare, so that leaves what you do. And here's what we do know about what's likely coming. One, directed payment programs will continue to be under attack because they now cost the federal government a significant amount of money. They cost the federal government more than DISH. And therefore, one way of reducing federal expenditures in Medicaid is to simply say you can't do directed payments anymore. The state would have no particular incentive to increase the rates for HMOs if there was no pass-through amount. They could get the HMOs to serve the patient population as long as they say everyone has to be in an HMO. The reason they're doing directed payments is to try to support the provider base. And so if now you can't do that, directed payments go away, saves the feds a fair amount of money. Second, continuing desire to reduce dish payments. Dish payments are not terribly important for JPS now and in the future, but in other states they are quite important. In certain states that don't have 1115 waivers and therefore do not have UC programs, DISH is the largest supplemental payment that exists. California, significant amount, the largest DISH cap in the country, most public hospitals in the country, significant amount of money flowing through that system. And so it's it continues to be a prime target. Finally, we've heard rumblings about block granting Medicaid for years. We will hear it again in the near future. In the early 90s, there was an attempt to block grant Medicaid. There was another attempt during the Bush II administration to block grant Medicaid. The reason is always exactly the same. The thing that block granting Medicaid gives the federal government, is budget certainty. Now I am going to give a state a pot of money. The state, you may spend it however you want. We're going to do away with all these rules. You're not going to have to worry about HARP or Africa or UC or DISH or anything else. Here is a pot of money. You figure out what makes the most sense for you and your state, and you can go spend that money. So there's a certain attractiveness to the state as well for that. But there is a dark downside to this. If there is, in fact, a recession, guess what happens? Medicaid is counter-cyclical. And so if there is recession, more people become eligible for Medicaid, which means that the federal cost increase and the state cost increase as well, but the federal government reimburses the majority of that increased cost. Under a block grant program, guess who bears the full brunt of any recessionary effect? The state does. And so the states, there was an attempt for a grand bargain in the late 90s in which the states would take over all hospital and physician care, and long-term care would become part of the Medicare program, no requirement by the states to pay for that. That deal fell apart. When the recession then came in the early aughts, states suddenly looked at this and said, this doesn't look very attractive to us. We don't think we want to do that at all. Maybe talk of block granting, if we do have another recession soon, that may put the kibosh to further talking about block granting. But I can assure you that it is on the table. I can assure you that reform, that dramatic reform of Medicaid is on the table. And that is something that we know it's a known. What it will look like will be an unknown. How generous it will be is an unknown. And it's something that we're going to have to pay careful attention to, because the first impact of block grants will be on safety net providers. Again, pleasure to be with you today. Sorry for all the technical, all the acronyms and all the technical information, but there's kind of no other way of explaining this, I'm afraid. And again, any questions you have, feel free to follow up with Kim and myself.
Quick question for you. If Medicaid is moving toward block grant or per capita cap, which safety net hospital you think is more prepared to go to deal with it?
Who's the most prepared? The hospitals that don't take care of Medicaid patients.
Safety net.
Yeah, I mean, the reality, there are two different aspects to this block granting program that's problematic. The first is that block granting won't do anything about covering people. Mm-hmm. And so the uninsured population, in fact, as you probably are aware, as a result of the big beautiful bill, the uninsured problem has gotten larger. The latest estimate is something like 10 million people lost insurance coverage. The people who are signing up through the exchanges, that the sign-up rate is 30% below what it was. We have headed in the direction of more uncovered individuals and more unreimbursed costs than less. Block granting will not address that in any way. That trend line will continue. At the same time, because then the block grant will be calculated on the number of Medicaid eligible individuals, it actually has a deleterious effect on, ironically, those states that did not increase Medicaid coverage, like Texas. The per capita amount will be comparatively lower to other states that increased coverage. And so so for facilities like you, and I hate to end on such a down note, but the reality is that the challenge for a facility like you will be twofold. You will likely experience a reduction across the board in supplemental payments to help you cover cost of the uninsured. But the capitation that you will receive, the state receives, and that you will in turn receive based on the number of Medicaid uninsured, will not allow you to cross-subsidize in any way either. So, I am not, as you can probably tell from my comments, I am not a fan of block granting. I don't think it's the right policy. I think it will place tremendous strains on the health delivery system and on the safety net in particular. I hope there's some other way we can figure out to fix the system other than that.
Can we ask you a little bit about cost report?
Can you?
Ask about cost report?
Sure, I'm not a cost report expert, but.
From the policy standpoint.
Oh, from a policy standpoint, sure.
How much variable exists among safety net hospital in maximizing allowable costs? And are we confident JPS captured all legitimate costs available under this program?
So, so the short answer to your question is yes. I think you do a great job here. And one of the things that Kim and I have worked on is making sure that for all these caps, that we're capturing everything we can capture and putting in those caps. Now, keep in mind, at the end of the day, that's not really, it's not so much a cost report problem as it is a reporting and tracking problem for your Medicaid and uninsured individuals. And there are sub-issues underneath that. So, and let me just give you one example. The federal statute says that for DSH purposes, you can include all costs for a person who is uninsured, a person without health insurance. Not charity care, it's those who do not have an insurance. So how do you document that? And are you making sure that you're capturing everyone you can within that bucket? Some providers, and I do not recommend this. In fact, I think it creates exposure for you that you do not want. But I have had providers suggest to me that we can count 20% of our bad debt as uninsured. And my response to them has been, okay, prove it to me. If I audit you, do you have the documentation to show that those costs that you included there were actually uninsured? If they weren't, then even if they had an ART-linked letter policy, I'm old enough to know what that was, they still are insured, and you cannot count them in that cap. And so JPS does not play that game. At the same time, Kim is very, very thorough. We look at your caps regularly. We compare your caps to other public hospitals. We look at the trend line of your caps. I think you are doing a tremendous job in making sure you're maximizing those caps and therefore maximizing your reimbursement.
And then two more questions
So
for you.
Mike has his playing catch, so.
Let me
Yes.
highlight, and then we can catch up. I'll submit the question to you, and then you can
Yes,
ask.
you can, any
But-
questions,
but the
happy to
next-
give them to me, and Mike and I will follow up. We can also bring him back again in 6 months if you need a refresher course, so.
One thing that jumps out is the pharmacy, special pharmacy opportunity. You know, do our peers, do peer system derive a large percentage of margin from specialty pharmacy than us? Because I know that there's opportunity to expand the specialty pharmacy as a hedge against the supplemental revenue uncertainty. And I know Parkland and Harris Health have invested heavily in this area. Is there anything there that we should be looking at?
So I will confess, I am not an expert on the pharmacy purchasing program. I do know someone who is, and so if you'd like for me to put you in touch with that individual, I'm happy to do that.
We have grown our specialty
I know there's been,
pharmacies. We've
I-
done.
you have one?
We
Okay.
Yeah, we have grown our specialty pharmacy and just built out recent space over at Medical Home Southwest, so it's a growing,
I think revenue diversification, I think that's probably where you're going, DT, is about how we can cover ourselves if the world comes to an end on the supplemental payments.
so.
I do want to make sure you get.
Yeah, Mike, I want to thank you. I hope the board appreciates kind of how complex this is and how it is that we have to really juggle this and to be on top of it, to be aware of what those changes are, and to be able to respond. And so I truly thank you for helping us navigate through this very complex supplemental world in which we live, and also for advocating and having developed a lot of these programs for us, because we would not be here today to be able to serve this community had it not been for individuals such as you that see the importance of safety net hospitals and communities. So I truly do thank you. You are a huge part of our financial success and our sustainability.
Thank you, Dr. Duncan. This is usually the point where I give you a test about all the acronyms, but since I got to catch the plane, you guys are off the hook today. Take care.
All right, I think I have 3 slides, and I think if we then could break for lunch, then I'll talk about JPS Connection after. We're going to do a working lunch today, just so everyone, so we'll take about 15 minutes, gather your lunch, do what you need, and bring it back. But I just want to quickly, I don't want to lose this momentum, or I don't know if it's momentum for you or not, but Demetria, here is the summary of the dollars that you'll see. This is in your packet, of course. The highlights on the left have to do with the bar chart we saw at the beginning, and that's just, some people are visual, some people like chart numbers. This really shows you the supplemental payments that we get and we've gotten over time. You'll see the very top line, the dish for 27. Now, keep in mind, as Mike said, some of these we can estimate, some of them we can't, some of them are draft, some of them we actually don't get the final numbers till after the budget's approved. And so we're taking our best estimates. But DISH right now is expected to go to 0, but you see it's going into the third line for HERP. All of these go down to the total supplemental line, where it says total supplemental, $261 million for fiscal 27. We always talk about the one-times that we incur, you know, the gifts we get from prior years, from reconciliations, and as Mike had alluded to, these reconciliations are really behind because HHSC is behind. So sometimes we'll get one for 2019 or 2021 because they're finally to the point where they can reconcile. We do have one distribution that we are getting. We've gotten a couple of payments we will be budgeting for next year. We expect to get this payment. Right now, we're evaluating if there's any other potential one-times we should consider budgeting for next year. Nothing is popping out yet because we don't really understand where they are in some of the reconciliation processes. But I know that's one thing that as we talk about the financials, that when we come in and say, oh, we got another one-time, oh, we got another one-time, we're trying to put less conservative estimates in here. Want to be totally transparent with you as a board that we are doing this so that you understand what we are including in the budget. Right now, most of these numbers are what we expect. DISH is the risk this year because we haven't gotten our final DISH numbers. It'll be later this month or early July, but that's for this year. And so these numbers right now are where we feel they're going to land, but some of them are not final until September, and that's after you approve the budget. So, and we'll also let you know when they're changed.
Reimbursement, do they happen on a monthly basis
It's periodic. Some of them are in threes. They'll do one interim, and a final. That final then says, did we give you too much? Did we give you too little? And that's where they gave somebody too much. They have to pull it back. And that's where those reconciliations come from and those settlements we get, because they're reconciling people who had to pay back. Or they had money left in the pool and they had to then reconcile and distribute what was left in the pool. So that's what the one thing you don't see on here, and you're probably going, I don't know what's not on here, it's CHIRP. CHIRP does not come through the supplemental program line on the income statement. It comes through net patient revenue because we get paid based on how we see the patients. So that's why it's not on here, in case later you're comparing the alphabet soup. We get about 66 million from CHIRP that goes through net patient revenue on that line. But it's in the income statement, we have net patient revenue, supplemental Medicaid, so we have two lines. It comes through patient by patient, so we get paid on CHIRP as we see the patients.
Ken, I've got a question. So this is pretty important to me because we've had some big misses year over year. So, I mean, do we feel pretty conservative in that 278 budget number for next year?
We're actually evaluating if there's any other one-time. So for example, this year we have not had a lot of them, as you can see. We're about $5.6 million of one-times. There's some other sitting in the net patient revenue. Remember, so the CHIRP is sitting up there. That was another benefit that we're looking at.
But if I'm looking at this year, we're at 213 was our budget, and we're anticipating 259, right?
Right, and there's the two one-times in there for $30 million.
I just want to make sure that we're being extremely conservative.
We're not being extremely conservative.
Okay.
That's why I'm putting that 17 million in for next year. I have a high confidence that we're going to get it.
Okay.
Yeah. We're less conservative this year than we've been in
Yes.
previous years. Is that?
That's what I'm after, yes.
Okay.
I just wanted to make
We're
sure.
somewhere between 0 and what we're gonna get. I mean, we're just, you know what I mean? It's kind of a crapshoot. But we're trying to look at them to say, can we estimate it? Then ask for grace later when our estimate was too high. I'm just gonna put that out there.
I agree, yeah.
Kim, I got a couple questions. First, we've talked about Medicare and Medicaid DISH. You've got one line for DISH here. Is that both combined?
No, this is only the Medicaid supplementals.
Oh, that's right.
Medicare,
So that's different.
Medicare, DISH, and GME also go through net patient revenue. That's how we get paid for it, is on a patient basis.
Okay, and the GME too, is it that way?
Correct.
Okay, that took two of the questions off. You'd mentioned earlier on, Mike was talking, because he was saying we only get 148,000, says 149,000 here for Atlas, and you said, oh, well, next year we're gonna get 8 million. But you've got 8 million this year too.
Mm-hmm.
So that's now.
Yeah, he was giving you the 25 numbers, which was last year's.
Okay, he was telling it.
His numbers were all 2025,
Okay,
because
but this year,
we're getting 8 million this year. It'll be
8
later.
million more than you thought. When you
No, yes, we are getting some of it won't get. So what happened, this is the short version, because I know you're all hungry. The short version is there was the first year of the Atlas program, the way it was distributed, it was more related to your interoperability with the MCOs or managed care Medicaid directly. And that's why we have such a little number, because we didn't have the relationship with the MCOs. Then HHSC terminated the program in December because they really felt that the MCOs should be getting the money and figuring out how to distribute it. So they changed the program in the spring. The MCOs are now getting the money, and they're distributing it based on the relationship they have with the provider. And so we're getting more now because we have the relationships with the provider in the way that the MCO is defining it. Does that make sense? And the utilization. So.
Isn't this a technology payment?
It is.
Yes.
I thought it'd be like for expanding, Epic or something.
Well, it's related to technology, but to interoperability related to providing care.
So the MCOs wanted the information, basically, and so they
Yeah.
wanted us to be able to send information back and forth, which Epic was really set up for us to be able to pull information from other Epic systems. But this was really thought that it was really built so that the MCOs could be able to pull some of our information with the hopes that they could do more case management around the patient and decrease their cost of care. And so that's really what started this whole kind of push to make sure that MCOs could get some of the patient information and help us manage cost of care.
And when you're saying MCOs, this gets back to the Medicaid managed care plans and the directed payments. It's the same organization that would be paying us those directed payments through a higher cap, I guess.
Direct, yeah.
Indirect, yep.
That's who we're supposed to be interacting with, and that's what this $8 million's for.
And that's what we
Okay.
do. We actually have an intermediary that sets those, agreements for us.
From Mike's presentation, I thought it had to do something like with my chart or something, providing information.
You would think based on what the program's named.
Yeah, my chart is Epic, but it's not the only electronic health system out there. So there's Cerner and there's other electronic health records so if you have those electronic health records or services, you also are responsible. But my chart is Epic.
Right.
Yeah.
Okay.
So if a long-term care facility has an EHR, we have one, and the pharmacy has one, it's bringing all the data together to a complete picture of what resources the patient is using. And
This is I guess is helping us pay for things like Epic and other technology
this
expenses.
is helping us pay for the
Patient
cost of just taking care of patients.
Okay. My last question, if this is a supplemental program chart, why do you have a non-supplemental one-time column at the very bottom? What are those non-supplemental payments?
That non-supplemental payments are for a prior year CHIRP reimbursement that we're getting. And so that is going through the net patient revenue line. I just wanted to call it out for the board today to know that we're putting in this one time into the budget.
Do we have line of sight on that those payments that the managed MCOs could change their mind at some point? They're doing this to really get us going and get us motivated, but then kind of like they did with attestation statements, and then they decide, well, they're just not going to give us that much anymore. Is there?
They can change. They can change how they.
But we have agreements with how
We have agreements with them.
between them as to how they'll pay. Yeah.
Yeah, we have agreements, but every year they could say, oh, we're gonna change it, and then we do the agreement again.
You're right. They'll
Who's
fight.
funding Atlas?
Huh?
Who's funding the Atlas payment? Is it the MCO or
No,
the state?
No, the state.
it's the state. State pays it.
So this MCO couldn't change what the state's paying.
No, they give it to the MCO, who then defines how they're going to distribute it. So the payment is made by the state to the MCO.
The Atlas payment?
Yes.
The price you pay for early adopter, they may change things.
Yeah, that's true.
Okay,
We
Two
are
more slides.
1/3 of our way through.
2 more slides. 2 more slides, DT. This is payer mix. We've talked about this in various categories. I think you can take a look at it. Payer mix, the arrows are the only ones, if they're going up or down. If they're flat, we didn't put an arrow because it made it really messy. Medicare is on the bottom. We're seeing a little increase aging population. That's what's driving that. Then the light green is Medicaid, going down slightly. We have the work requirement going into effect January 1st. So that's going to be an interesting, see if we have a little bit of decline there. We have the worst, or one of the worst Medicaid programs in the country, so the work requirement will just put a little stress on it for those few people who are eligible. The commercial ACA is the teal, it's 6.9. You'll see that going down. You can see it's been consistently going down since 24. And the elimination of the extended tax premiums for this, Texas had 94% of the people in Texas who are on the ACA getting these premium tax credits. Texas did a great job, another great job by Texas, of getting those maximized tax credits and how they put their program together. So really, again, kudos to figuring that out. The dark blue is commercial. We've just left flat. It's been 10%. We've left that flat for the time being. You'll see that connection and self-pay added together, a slight increase there, and then the other. And the other is like the VA, motor vehicle accidents, those types of things. That's what's sitting in the other category. So really our assumptions here is we're going to see an increase in Medicare because of the population. We're going to see a little bit of a shift to self-pay based on the ACA for the organization. This is a risk area because patients come to see us, and we see them regardless of their payer. So this is a place where, you know, we take our best estimates, we keep our assumptions intact, and then we measure against what we thought we would see.
You're talking about the self-pay?
It's in it, so the more self-pay we see, we won't make money on that self-pay. And so as the population is less covered by ACA, if the work requirement comes in for Medicaid, they're gonna go to the connection, self-pay, so.
I mean, is there a concern in '23, we're at 12.7%, now we're at 21?
Which one are you talking about, Medicaid?
You're talking about the self-pay.
Yeah, oh, it continues to go up. So during COVID, we also had a bunch of people who are eligible for Medicaid based on the emergency order that went into effect. So that's the, when you see Medicaid sliding down after 23, that also happened. Then they moved up into self-pay or connections. And that final validation of all those people is happening now. The big bolus was at the beginning of these 2 years that you see up here, but the final validation is going on of who can be on the roll.
Yeah, it is a little deceiving when you include kind of what was going on with COVID, because they didn't roll off of Medicaid. They stayed on, so we were able to benefit from that. And then as soon as they unwound.
Yep, and 24 is when they're rolling off, and that's when you see it go down to 19.
Start to see it slightly.
And then you see the validation going on that happened over this past year.
For next year, we're anticipating we're going to lose a little bit more just because of the work requirement. We're trying to get that rolled out.
When we look at this number, are we looking at primary pay only, or do we look at?
This is driven off primary pay, but we assume that there's still the same mix of people with secondary when we look at these numbers. We do look at, is there secondary and ACA, which they probably would never have, but we look at the duals.
And that's what I was going to say.
Yeah, we look at the duals. Duals for this group means you have Medicare and Medicaid coverage. There's not a lot of duals in Texas.
Is self-pay, what percentage of what we bill do we collect? 1%?
Maybe. Maybe. 1 to 3.
So what's the difference in that and connection?
So the difference is Connection is our charity program for Tarrant County residents that are lawfully present. And that's what Connections is. So they're basically self-pay patients. However, I'm going to go over the program after you get your lunch and go over what self-connection is. And self-pay is people without insurance or people who choose not to use their insurance.
So the JPS Connection, we're using the dollars, our ad valorem to pay
Yep.
for it. So we're kind of a payer, a provider and payer.
All right, one more and then we're going to break. This one's short. This is just the pharmacy revenue. Stephen's going to talk about the pharmacy when we get to the expense section. The bars are the sources of revenue, and this is net revenue. This is what we collect. The dark line is the number of prescriptions that we fill, and you can see that has continuously gone up. I do want to highlight the very top blue bar where the majority of the revenue is sitting, because this is our specialty pharmacy, which of course has the smallest amount of prescriptions filled. Our average collection is very high, or excuse me, our average cost to the patient or for the insurance is much higher by 10 times than when you get a retail prescription. A retail prescription can run around $60 to $70, and you get $7,000 per prescription where you're talking about specialty pharmacies. They're compounded, they're very high-end drugs for our patients. And so it's very important that when Stephen talks later about the 340B program, this is what we're doing to help our patients. Because by doing this, we're being able to do it at a lower cost, helping them get it at a lower cost or no cost to take care of themselves. But this is the other major revenue, but I think Stephen's going to go into it when we talk about the costs a little bit after we eat lunch.
Is there an opportunity for us to use something like Cost Plus from Mark Cuban? For maintenance drug?
So Mark's using the discount cards, which are you talking about doing our own methodology or using his cards?
It's either way.
Okay, we actually don't accept the discount cards primarily because we have such a rich 340B program and we can keep the price really down far for the patients. With discount cards, we don't get a benefit from the discount cards. It's basically a throughput opportunity for the manufacturer to get their drugs out there and distributed.
But it's low JPS connection though.
JPS connections, almost all of those will run through the 340B program. Yep. Yep. So, Mr. Chairs, I don't know which one we're talking to. You want to take 15 minutes, grab lunch, and then we're going to come back and talk about connection and what it is, and then we'll go into expenses.
We are at 1/3 of the way, so.
Well, it'll go a little faster because Mike was an hour and a half.
We should be done by 8 o'clock tonight.
No, we will not.
Yeah, so yeah, late afternoon plan. Yes, sir.
It's ordered in and
talk about policy in a future meeting and what we could maybe change or what we might want to do with the program. But I wanted to give you an overview of the JPS Connection program that we provide to the lawfully present Tarrant County residents. To start off, though, I do want to talk about Medicaid eligibility because oftentimes you're like, well, aren't they eligible for Medicaid? On this chart, it has who qualifies, parents and caretakers of minor children, pregnant women, children under the age of 19. We do have the work requirement coming January 1st, which will impact these individuals 20 hours a week that they need to work. They can also be doing job training, some other things, and then there are some exceptions to that. The eligibility is on the right side. As you imagine, they have to be a U.S. citizen or a Texas resident or a legal resident. They all have to be here lawfully. The income thresholds are the important thing. Texas Medicaid, and this was new for me when I got here, because Texas Medicaid looks at people's income based on a fixed amount, not a percent of the federal poverty limit. Most organizations use the FPL or the federal poverty limit. It is very low. On the right-hand side of the page, to qualify for Medicaid, if you're a parent with one child, you have to make $103 or less a month. Think about that. That's very low. Pregnant women and infants under 1 are 198% of the federal poverty limit. So and then the children, you'll see, are 144 and 133. Taking care of pregnant women and the children are the primary focus here, as you can see, for Texas Medicaid. Just wanted you to understand this requirement. The state of Texas has a law that says every county must provide health care to the indigent patients in Texas. Every county. Whether you do it through partnership, do it through the county, or do it through a hospital district, that's what you do. The base for the state is you must at least provide it for those at 21% of the federal poverty limit or less. You can raise that up. You can make it higher, at least at 21% and lower. So I just want to tell you about that because we do have a requirement in the county to provide care. Most counties raise it above that 21%. The other thing is we chose not to expand Medicaid in the state of Texas. If we had chosen to expand it, we would be taking care of people up to 138% of the federal poverty limit. But we did not expand, and so we did not raise the threshold for eligibility. I know we're giving you guys a lot of technical. All right, what is JPS Connection? It's basically, it's our primary coverage or our program for the residents of Tarrant County. This is what our ad valorem is funding, or partially what it is funding, for the residents of Tarrant County. It's basically, it helps us get these patients getting care where they might not get care proactively and they might just all end up in the ED. And so this is a way to actually put a program together to give them financial assistance. We do it up to 250% of the federal poverty limit, and there's some steps to that depending on where you fall in that bracket. And it's really the payer of last resort. If you have a payer, if you have the ability to get access to a payer, you're a Medicare eligible patient, you are requested to get the insurance that you do have available to you. So we make sure that there's no other options for these patients. This is a grid to help you understand the JPS Connection program. We have JPS Connection, we call it 1, 2, 3, and then we have the supplemental. The supplemental, and just to start with that, is if you have Medicare or another plan, then we will help you after your primary insurance with co-pays and other services that are allowable. The JPS Connection program policy currently is around Medicare allowable services, and that is the policy that we have today for what's allowed. But if you look at the 3 programs we have in the columns, I gave you 2 lines. There's if you're a single person or if you're a 4-person household. This is where you would be eligible for which of the programs, and this is an annual number. This is not a monthly number. So the first category is someone from 0 to 21% of the federal poverty limit. Their income determines this. People experiencing homelessness fall here, and basically we cover their care. There's no co-pays. They get their pharmacy and medical. On the second program, it's anything between that 21 and 100%. And then we actually ask them to pay a copay on pharmacy. We have a fee schedule. And then the third is anything from 100 to 250%, and we ask for copays on medical and pharmacy. The simplistic plan design. I do want to share with you that this is the current federal poverty limit scale or level scale. The first 3 columns or 4 columns are the connection program limits. This may look a little different in your packet because I took 133 out because we didn't really need that. But I want to emphasize for a family of 4, $82,000 a year, $82,500 is where they qualify at the max for connection program. That's someone making just under $40 an hour. They have to meet the qualifications of the program, of course. But the other thing is we have up to 400%. We have a sliding scale charity policy also. And for a family of 4, it would be a family making $132,000 a year. These are very common limits. You will see 250% for the Dallas program and the Harris program for Parkland and Harris. Well, no, actually, Parkland's 250, Harris is at 150% for their program. But for their charity programs that they see, they do sliding scales for coverage. And what that means is you might get half of your care covered, or you might get 25% or 100%, depending on where you are on the sliding scale. We all have self-pay discount programs, and these self-pay discount programs, for example, Dallas Parkland gives a 60% discount off on charges for self-pay elective services, or excuse me, it's not elective, non-elective services. Harris does the Medicare allowable for self-pay. That's actually a lot of math for them to always be figuring out. We do somewhere between 40 and 80%, depending on the service and the sliding scale for the self-pay. And you'll see that THR, Baylor Scott & White, and Baylor Scott & White do 40% on hospital services as a discount for self-pay.
And these are net income. I mean, I know you say gross earlier, but this is net, like for self-employed.
This would be off of charges. The percentages, in this case for self-pay, would be off of charges, and that's what we'd give them the discount on. Nobody pays charges, but charges tell us about the resources we use. So, but just to give you an idea of where, I just want you to know where the people fall when it comes to an income level. When we're talking about 250, a single person making $39.9, which is just under $20 an hour, is the maximum eligible for connection.
We have a ratio of what expected 27, what we think will be there now.
We have our eligibility that we have today in a chart in 2 slides. This slide right here. You are so good. You anticipated that. This is the mix of our patients, 1, 2, 3, and then the supplementals for the insurance, and you can combine those 2 numbers. Our total active memberships, meaning the people in the program right now, because we have to revalidate their income on an annual basis, is about 60,000. We have about 40,000 active, meaning they've been seen in the last year. And so about 2/3 are in it. They might have been seen last year, and they're still in their 12-month period, but haven't used services this year. But this is the mix of our current JPS Connection program. And then no wonder I'm confused. Yeah.
Different counties in their particular connection program. Do we compare ours with their other counties to see where we are?
Yes, so Dallas, for example, Parkland, they actually cap at 250% of the federal poverty limit like we do. I haven't compared the details of their program per se yet, and then Harris is at 150%, but we're probably more comparable to Parkland being the DFW area. So most of them center around Medicare allowable services is what I've seen so far. I haven't really seen anything get extreme around bariatrics or other cosmetic type services, just mostly Medicare allowable services.
How do we know if one person goes off into next year?
So we have to validate their income every year. It's a requirement that we go out and revalidate them. So if they're still eligible, then they're still on the program. And we have we have a service that helps us do that every year.
So that connection person must re-up every year?
Yes, every year. We do the revalidation, though. We don't call them up and say, you like Medicaid says you have to enroll, and we'll auto-enroll you. If you don't like the plan, they have to do something. We basically keep checking to see if the patient's eligible on an annual basis. We don't want to make it difficult for the patient, because when they do present and they've forgotten, we want to be ready when they come.
So Kim, at 400% of poverty level, we give a discount?
Mm-hmm. Well, we, depending on the size of the family, we give a charity discount to them, and it's a sliding scale up to anyone's at 400% of the federal poverty limit.
But up to 250, they can participate in some level of protection.
Yes.
So between 250 and 400, there's some sort of a discount.
Correct.
You call it a charity discount.
The reason is it doesn't fall within the defined connection program as we've defined it today. And so we have a sliding scale of charity beyond the connection program. That's for all patients. So they could be Tarrant County residents.
Okay. And that's between 250 and 400?
It goes from 0 to 400 because you pick up the non-Tarrant County residents. So we have a charity policy that sits next to the connection policy.
Do you gather the same financial data for those patients that you do for connection patients? So
Yep.
to get this discount, they have to provide
They have to provide the same documentation to show that they're eligible for that discount.
And technically, that's not connections, but it's sort of the same process.
Right. And all health systems, at least not-for-profit, private health systems, well, actually, every of them have this process of charity and looking at patients' ability to pay. All right. Just to bring that all together, I had mentioned the light blue is the membership, and then the dark blue are the active members. Again, it's about 2/3 that are active, but we always want to be prepared when they show up to get service from us. So I know this was really a quick overview. It is in your deck, but we do want to come back to this group and talk about policy at a future date and what should the policy be, what it is, and do a deeper dive. All right, operating expenses. All right. On this slide right here, this shows you for every dollar we bring into the organization, that's all of our revenue. That's including patient revenue, supplementals, ad valorem, all the revenue we bring in the organization. Where does the dollar go? As you can imagine, people being the largest part, 54 cents of that dollar goes to people, 20 cents to supplies, about 18 cents to purchase services and other. Then we have our debt service, and then we have our capital and our future fund investment. This is where the dollar goes. That 2 and 6 cents are really the bottom line, because, not the full bottom, but the bottom line of our income statement, because those payments are made off the balance sheet. Does everybody kind of understand that? You have an income statement, but debt you pay off your balance sheet with cash, and what we're doing with capital, you pay off your balance sheet with cash. The reason I wanted to emphasize that is we go to the next page, and it says 54 cents we spend out of every dollar, but that's 54 cents. The first 4 categories you have up there are 74, 84. I'm sorry, I can do it backwards. 94 cents, the first 4 categories. So when I look at just those categories, and I look at our operating expenses, labor is 58% of our expenses. Okay, so I just didn't want you guys to go, why is it not 54 and 58? Okay, because I do that. Our expenses in the breakout hasn't changed very much, as you can see, unlike the revenue that has really shifted toward net patient revenue. What we get in the largest category we have are the people. And one of the efforts that we're working on is workforce optimization. And the opportunity that we've identified when we started the work in June was about $52 million on an annual basis. This fiscal year in '26, we will have realized about 26 million of that because we're ramping up on the opportunity. And in fiscal '27, we expect to get the rest or the balance of that initiative at about $52 million. So when we look at the optimization project, the purpose is to align the staffing with demand. Again, remember I talked about volume drives everything, so that's how we staff the organization so we can sustain quality. It's important because we don't ever want quality to be sacrificed at looking at how the workforce delivers. Access, engagement, and financial performance. So we look at a benchmark and right-size the staffing. The benchmarks are looking at similar hospitals. And then we'll streamline the workflows. We do have to look at process, and we'll look at technology, and then we'll equip the leaders with data for monitoring this. On the right side, it shows you the target I just had talked about. It's $24 million improvement in '27 that will get us to the $52 million that we identified this year. With that, just a quick background so you understand. We did start in this past June. Jill and I are partnered on this, and we did the operational studies, benchmarking, and productivity. We used a third party to help us with those to make sure that we had good targets, and they did a lot of on-site review of our departments. We now have management action plans going on, process improvement. We have bi-weekly FTE meetings, monthly labor council meetings. We have a Strata dashboard monitoring. Strata is our decision support system, and we look at when people want to replace or have new positions, we look at their last 4 periods and how productive they are. Are they at 85%? Well, maybe you don't need this FTE anymore. Or what's happening with this department? If you want to expand services, what does that mean? How do we monitor it? So this is something our leaders are getting used to. They're understanding it. We're working through it with them. And really, it's a journey all together on how we're going to work through continuing to optimize our workforce, strengthen the leadership accountability, and then advance process improvement. And I think that's important because technology is going to enable us, but we have to have it powered by people and process because technology only works when you know the problem you're trying to solve. We'll align staff to the demand and reskill. It's really important. As we reorganize, we may need to reskill. We implement technology, reskill. So the purpose is really where it supports efficiency and care redesign while continuing to provide the high excellence that we provide as an organization.
So Kim, can we step back a little bit here because we did bring in someone to help us with this, but this was work that was done across the entire organization in which we sat down with each of the areas. That's how extensive it was. And to understand from them, what is the work that you're doing? And so part of this optimization is if the nurse is running down and getting the dietary food because she wants to make sure the patient gets their food on time, or going down and get linen, and Dorothy knows how it is, right? They're gonna make sure, hey, it's not here, I'm gonna go down and get it. How can we resource dietary or linen to take this off of the nurse so that she can remain in with that patient? And so we did a lot of that work with the teams, with the business units, and came up then with what would be the necessary FTE to do the amount of work that was being done in that area. We had a lot, and Jill, I don't know if you want to speak to it, but we had a lot of great input from different teams. There are areas in which we see a little bit more FTE than we see the amount of work, and so we're working with them to make sure, since we're a 24/7 organization, that they don't have everybody coming in from 8, the first shift from 7 to 7, that there is good coverage on the evening shift. So there may be some changes to maybe scheduling. This is, and the reason I'm bringing this up, because when organizations, and many organizations, healthcare organizations, have already done this work, we were kind of late to the game with this. And we felt that given our labor expenses that we really needed to push forward with this. When organizations do this, sometimes staff, especially when you say we're going to take, 20 of your first shift and we're gonna put them on the evening, that first shift sometimes thinks that you're taking something away from them. They may think that your organization's undergoing a RIF or a reduction in force. And so you may hear that since you're out in the community. I want you to know this really is nothing about removing FTE, but it's really about making sure that we have the right number of FTE for the work that we do in each of the areas. There are areas that are doing a lot of work with a lean number of employees, and so we don't want them to burn out. We don't want them to have a lot of overtime, and so we are resourcing those areas. So this has been long overdue. It's a heavy lift with the organization, and I want to thank Kim and Jill for really navigating this throughout the organization.
That is really great news to hear. So a little side story, just under a year ago on City Council in South Lake, I pointed out that the city of South Lake compares itself to all these other cities in North Texas, like all these top 20 cities of similar size. And one of the things that I pointed out in the City Council was that the number of FTEs that it has more FTEs per capita than any of the other cities, 1 in 74. And what I've tried to explain to them was like, you know, if you went to 1 in 80, you would save $3 million a year off your budget, and you still would be just under the 20. Like the next closest was 1 in 80, and then it went 1 in 84, and 1 in 110. And I cannot tell you how much grief I got from other members of City Council, where they're like, you know, you can't fire staff or whatever. I'm like, no, this does not make any sense. Why you're going to spend all this money? You got to take a look at this periodically, because certainly there are people who need it, but you got to be realistic on who you're actually employing. So I'm glad you guys are taking a look at that.
Yeah, and to your point, I mean, there's attrition that goes on, and so we have this FTE committee that evaluates, and so if somebody leaves and we see their, you know, targets or, you know, or high or low, I don't know which one it is, but anyway, that we may not refill that until that productivity goes up, and so really being disciplined with it. But yeah, you're right. The first thing people think is, oh, we're riffing, we're getting rid of people. And Kim spoke about the fact that we've really got to reskill people for future healthcare needs. So really being able to take some of that workforce, excess workforce, and begin to reskill them to do some of the other work. It's also work that we're doing.
I think the timing is also important as we're moving into new facilities, that we do get our productivity where it needs to be, so we're prepared with these new spaces that we're going to have, you know, efficient and effective as well. So it is a journey. It's not a one and done. We just did it because you are constantly improving processes and identifying bottlenecks in the process along the way. In any department, in any area, clinical and not clinical for that matter. New technologies that come on board, Kim mentioned, and so it changes your processes for the better. That's the goal. So it is a constant journey, and we are a little bit late to the game. You have other leaders that come to this organization from other health systems, and they have been doing this for, you know, for their entire career, most likely. And so it has been a muscle that we, you know, had to get in the organization, and so it's continuing as well. And so it has been, you know, a year or so since we started the journey, but we still definitely have work to do this next year as well.
And it is data-driven, so it's data that they can work with as leaders to be able to adjust.
I take my hat off to you. That's a hard journey, and it's just amazing how you have FTE creeps, but it's so hard to take it back down. So, but it's needed. Okay.
All right. So that was a good segue, Dorothy. Here is our FTEs since 2023. We got a little past COVID, and we went up a little. Determined that we needed to come down. And so you'll see from 25 at 76.26, we've come down to 74.78 this year. It's 148 FTE reduction. You'll also see that the line is FTEs per adjusted Tchd, which is a common metric used in healthcare. For next year, we're looking at a reduction of 200 FTEs in our workforce around our workforce optimization, coming down to 5.44. You might ask, I know Jonathan asked further to go. It just means, contacts, but we are coming down, and I think that's, the leadership has done a nice job of making this a priority.
So a national benchmark for institutions our size, safety net hospitals would be 5 to 5.4?
So I put us, so it's hard to get the safety net, that data is not out there.
Okay, but just big hospitals.
Academic or trauma one about our size would be 5.4, 5, down there. And then if you get to the community hospitals that are not like us, they'd be at like 4 or 5.
Okay, but
I'm used to running at 4 or 5, not that we get there, but, 5 to 5.5 would be great. Because in the academics, we have more FTEs because we're running the residency program, and we're doing research, and we're doing other things that a community hospital per se would do.
We see that growing on the APD side, there's probably forward, there's patient side, there's things like
Right, so,
optimization of that patient.
right, so we'll flex up and flex down on what's flexible. There's some staff that's fixed, of course, but you'll see that because adjusted patient days adjust for in and outpatient volume. So the volume goes up, if we kept our FTs flat, that number would come down.
Can I make a quick comment? If we look at 2 years out and we look back, I want to make sure that field FTE is the list we're looking at. It's important, but let's make sure that, it's less turnover, less burnout, reduce agency labor, high productivity, better access, and improve employee engagement. If we don't have that, we're going to have a really messed up culture as we go forward. So
Yeah.
I know you guys are looking at that, but I just want to make sure that we pay attention to those.
The elements to looking at our people, so.
And we measure that engagement. Burnout, we're way past that because we're all burned out. So I just want you to know, you don't even need to look 5 years.
Can we call that passion?
Okay, our second largest spend does sit in supplies and pharmaceuticals, and I know Charlie is itching to get up here. So, we are looking at pharmaceutical spend. That top line is our pharmacy and supply expenses as a percent of our revenue. And we try to keep that flat so that we're using the same amount of each dollar for supplies, not higher. So we felt today that would be very helpful. We talked about people, we talked about Medicaid supplementals, but really hearing from supply chain and pharmacy about those two areas because they do drive a lot of cost in the organization. So I'm gonna ask Charlie Cobb to come up to the VP of supply chain. Charlie is this over here, and he's in the middle of a restructure. So I will let you take over. How we do this. Thank you.
Can you just pause just for a second? I think Shannon wants us to pause for a second.
Oh, yes, okay. Board members, these are our volunteers.
Speaking
That's
of
why they
supplies.
look so young, and they are bringing you some popcorn. Board members, since you loved our pet therapy, we also have some pets here in case you need a little bit of therapy.
That's great.
Yes, so thank you for everything I have. Just moving stuff around.
It's good seeing you.
It's hard to retain control, so when you have all this happening.
No, I don't care you, but how are you? It's nice to see you. I want to really thank Shannon for really the growth that she's had in our volunteer program. And I believe this is the first year that we will have volunteers in the community sites as in addition to the volunteers that are often here on the main campus. So, and she's pulling those volunteers from the community. And so, great work that's being done with our volunteer program. They are the few, not only they get exposure here, but they also, from a philanthropic, are going to be future, donors that have, as you said, the knowledge of what JPS is doing here. So it's great work that she's doing. Thank you, Charlie.
Sure, thank you. Tough act to follow, but hopefully that outcome gives us an energy for good afternoon. I'm gonna stay on script, get us through in 15 minutes, and save room for questions at the end.
Really?
But thank you for having me today, and I'd like to provide an overview of healthcare supply chain environment, the challenges health systems are facing nationally, and how JPS is positioning itself to ensure uninterrupted
Charlie,
supply.
before you get started, I know you're trying to do 15 minutes. Can you just tell the board a little bit about you?
I have a whole slide.
Okay. I'm sorry.
I'm just setting it up. Many people think supply chain is simply just purchasing, distributing supplies. In reality, it's a critical operational function that supports every patient across the network. My goal today is to provide some context around the increasing complexity of the healthcare supply chain and the strategies JPS has in place to navigate those challenges. So talk a little bit about JPS supply chain, and remember, we're a health network, so the map represents the 26 clinics outside of the main hospital that we have to support as well. We'll talk about why supply chain matters, current risks in the market, JPS strategy and stewardship, and really future state, where we're going, and then close out and save room for questions. That's me. So just a quick, I'm from Texas, actually grew up in Forney. My grandfather was in the Air Force, my dad was in the Air Force, I went into the Air Force, was in logistics, loved it, went to Texas A&M to pursue my degree. Pre-supply chain, it was called Information and Operations Management, it is supply chain now. Was hired out of college, thank you. Hired out of college to a management training program with Cardinal Health, where I spent 13 years. Most of the logos on here aren't companies that I work for. I helped them with their supply chains. So Cardinal used to outsource the materials management, so I ran the
There, it's on now.
I run Cardinal operations. About halfway through my career, I got my MBA at University of Arizona, and really had a passion for the provider side. Started working with a lot of county and academic hospitals, and believe it or not, they were some of the worst supply chains. Some of the larger supply chains were a lot more mature, and I kind of, after my meeting, CFO at University of Arizona Health Network, so went down there, they purchased a county hospital, cancer center, a practice plan. They were implementing Boston at the time and about to implement Epic, so help them rebuild their supply chain. Thank you. They were bought out by Banner Health, which was a larger supply chain in Phoenix, and so I took it as an opportunity to come back home to Texas. That brought me to UT Southwestern, where I spent the last 10 years rebuilding their supply chain before moving here to JPS. But I'm happy to be here. I love the mission, love the purpose, and love what I do. I am a supply chain, healthcare supply chain professional. That's what I do. But it's not just me. It takes a good team. We brought in several. I've been in the market a long time. I know a lot of people look for the right fit and culture. Judy Allison is a retired master sergeant. She's a surgical tech. Worked on both the provider and a medical branch and UT medical branch in Arlington. So has some state government experience as well. Being on the clinical side, she's a great fit for the procurement and contracting. So she has 23 FTEs, responsible for $2.3 million. Danny Blunt, same thing, over 25 years in healthcare supply chain. He runs all supply chain operations. He spent some time at Johns Hopkins as well. He also spent some time out at University of Texas, Arlington, Galveston, and knows state procurement very well. I showed this in the last but not least is Beth Hall. She's over our systems analytics. I'll talk a little bit about data
and making sure, particularly as we move into the AI and digital generation, we have to digitize the supply chain. So Beth is going to be leading our systems and analytics team as we move forward. That continuum along the bottom is really what I consider the core supply chain. There's a lot of things in supply chain. You'll hear it called source to settle, procure to pay, but there's really procurement functions, sourcing, contracting, purchasing, and then operational functions, receiving, distribution, inventory management, clinical logistics. At the end of all that, there's an invoice that we got to three-way match and pay. And then we got to look at the analytics along those entire continuum. So this actually is an excerpt from a healthcare supply chain book. If you ever, I reference it on the bottom. If you ever want some late night reading to put you to sleep, you can read this book. But it does a good job of really showing what supply chain is. I talked about those functions in supply chain. On the right are really the procurement functions. On the left are the operational functions, but at the core of all that is data management and technology. You have to be data driven. That has to drive the processes that you do. And that goes beyond supply chain. I heard someone, you were talking about linen, and we need data around linen. We need to know how much linen we have, how much was consumed, when they need it, where they need it, because when we don't, nurses have to go find it, right? So we need to bring data not only to supply chain, but everything we do in operations. There's a definition that I wanted to share of supply chain. This actually came from North Carolina State, which was one of the first supply chain schools in the company. But supply chain is an active management of supply chain activities to maximize customer value and achieve sustainable competitive advantage. It represents the conscious effort of supply chain firms to develop and run supply chains in the most effective and efficient way possible. Supply chains cover everything from product development, sourcing, production, logistics, as well as the information systems needed to support these activities. By definition, this is a change in scope from a legacy transactional activities to an integrated strategic purpose, right? That's where healthcare supply chain is going, right? We can't be just the guys moving boxes. We have to be integrated, tied to patient care, and use data to drive everything we do. So why does supply chain matter? Every patient interaction at JPS depends on supply chain, whether it's in the trauma department for emergency, surgical procedure, laboratory test, or routine inpatient care. Supplies, pharmaceuticals, equipment, and services must be available at the right place, the right time, and the right price. Supply chain is often invisible when it works well, but when disruptions occur, the impact is immediate and highly visible. Supply chains also represent one of the largest non-labor categories in healthcare, making it an important component of both operational performance and financial stewardship. Again, historically, supply chain was viewed as primarily a purchasing function or an operations function. That has dramatically changed over the past several years. So how has it changed in healthcare? Healthcare supply chains have undergone significant transformation. In the past, success was largely measured by securing products at the lowest price. Today, health systems must balance costs with resiliency, continuity of operations, risk management, and supplier diversification. The COVID pandemic fundamentally changed how healthcare organizations think about supply chain. If you go back before COVID, there was SARS, there was the bird flu, there was Ebola, right? These have been building up to COVID. So supply chains have been forced to mature, but COVID really put it over the edge. Today's supply chain leaders spend as much time managing risk and resiliency as they do managing cost. Supply chain, again, has evolved from a transactional function to a strategic integrated enterprise. Current and emerging challenges. There are several external forces creating ongoing challenges for the healthcare organizations. Many medical products are manufactured outside the United States. In fact, when I first started in healthcare supply chain, there were lots of manufacturers in the United States. I'd say 90% are manufactured outside the United States today, making us very vulnerable to geopolitical events, trade policies, labor disruptions, transportation challenges, and global shortages. Healthcare organizations continue to experience intermittent shortages of critical products and ranging from pharmaceuticals to medical devices. We're also seeing increased cybersecurity risks within our supplier ecosystem. Not too long ago, there was an attack on Stryker. A cyber attack impacting major manufacturer or distributor can create as much disruption as a natural disaster. Many of these risks are outside our control, which makes resiliency planning essential. Tariffs and financial impact, why we're here today. One of the most immediate concerns facing healthcare supply chains today is the impacts of tariffs and inflation. Right? We tried to outsave inflation, now we have tariffs and a lot of other things that are putting pressure on that. Tariffs on imported goods can increase costs on products frequently and used in healthcare, including gloves, masks, syringes, pharmaceuticals, and medical devices. Many of these had very stable pricing for many years when we consider commodities. Now, one shortage on one of these commodities, all manufactured overseas, can bring healthcare to a halt. While individual product prices may appear modest, when applied across hundreds of millions of dollars of spend, the financial impact becomes significant. Healthcare organizations nationwide are actively evaluating implications of tariffs and geopolitical developments. Even small increases in supplies can create a meaningful budget pressure, making proactive management critical. So how is JPS responding? Our approach centers around 4 key areas: strategic sourcing. We partnered with Vizient, one of the nation's largest group purchasing organizations, to leverage our national pricing, market intelligence, and benchmarking. Again, as a standalone hospital, we don't have the leverage that THR or Baylor. We can aggregate that volume with Vizient to help mitigate our costs. Operational collaboration. We work closely with our physicians, nursing leadership, operational leaders to ensure product decisions support both clinical outcomes and financial stewardship. Standardization, standardizing products where clinically appropriate helps reduce variation, lower costs, improve inventory management, and simplify operations. So it's around getting clinical people out of the supply chain, really standardizing across the entire network, and controlling that variation in cost. Resiliency planning, again, we've talked about this. We actively monitor supply risk, maintain contingency plans, identify alternate suppliers, work to reduce dependency on single source. Again, years ago, sole source was great. You could get the best cost. Now, if you have all your eggs in one basket, it's a risk to the organization. So we have to strategically know when to sole source and when to have multiple source of orders.
I have a question. On your chapter financial impact, with where you purchase your gloves, masks, needles, pharmaceutical, medical services, are you guys considering local buy instead of what they're having to bring over from China and Mexico?
And I'll give you an example. During COVID, there was a mask that was produced here locally. It was a vendor. It was an N95, but it was double the cost. So they got a lot of business, but essentially it shifted back. So it is a cost versus some of the other benefits you get with having something local. So there's other things we can do, like we can bring in more safety stock. We can have alternate suppliers. But it really, at the end of the day, it's what's best value for Tarrant County. And those are decisions that we look at. We would love to source products locally. Right? That is great. Shipping from overseas, anything can happen. You can get backed up at the ports. You can have a strait closed down. You can have raw material shortages, which you have little control over. Having it in the U.S. or in North America provides a lot of benefits. But there's very few manufacturers that still manufacture. We've seen some come back, but it's few and far between.
So the ones that are here, what's your outreach? Because I know a couple of manufacturers that's going to fall into this needle and syringe technique that's going to be right up in North Dallas. So what kind of outreach? Would you go find them, or how can they come find you? How do we make that connection between procurement and the new people that's coming up?
Yeah, so we're trying to approach spend by category. So typically, we'll look at a category when the contracts are coming on Vizient. We don't just automatically award to Google Music. Right? We look at who's on Vizient, what's going on in the market, there's market intelligence, we see if there's any local vendors, and then we decide, do we want to go to bid? Do we want to use one of the Vizient contracted vendors? Do we want to do a bid so that it's kind of an all play and see where we end up? But it's really just a market analysis by the category, and we'll make individual decisions.
But how do they find you? How do they know that you're the person, your team, and I think I saw something that somebody had 82 FTEs, somebody else had. How do they find you?
They show up at our front door every day. Suppliers, we actually have a pamphlet that says how to do business with JPS. So we're trying to teach vendors how to work with us, right? We want to make it easy to do business with us. We're actually going to be working on an external page. We have one today that posts bids. but there's not a lot of information on how to reach us, how to do business with us. So that's some of the outreach efforts we do, because we don't want it to be hard to get in. We want to know what's going on and who's local. But we also have to ensure best value and that they can compete from a quality and pricing perspective. But essentially starting with purchasing and finding out who the contracts and when the bid cycles are, that's the first thing.
So on it, I mean, do they, procurement, is it like a buy board, or, you know, you can go, I think we mentioned DIR, or, you know, these big boards that you can get. Is that your go-to for procurement, or, because I know it's easier because you don't have to write an RFP and go through all the paperwork,
Yeah.
you know? So what's your preferred method of ordering these type of things?
It depends on the categories. I call it a contract hierarchy, right? Vizient is our preferred, right?
The Vizient is the.
It's our
GPO.
It's a, okay.
So Buy Board is a state similar aggregate group, but Vizient covers the majority of healthcare commodities. The reason they're our preferred is because if I'm contracting outside of them, I'm de-leveraging their leverage. So they're aggregating all of our spend and getting better pricing, right? So if I start undercutting them, then I lose that benefit, right? So I want to support my GPO whenever possible, but it doesn't mean I have to go with them, right? So we strategically make decisions to go outside of them or not. But a lot of services aren't covered by a GPO category, so we have to go out to bid for a lot of services. Capital products aren't necessarily covered by GPOs as well. So it's really your high volume, what we call med surge products. And then it bleeds over into the physician preference a little bit as well.
And Vizient has, I know we just approved some things from Vizient. And forgive me, this is like my first full circuit of having one of these meetings. I came on last year, so now things are beginning to kind of click with me. So how long, so Vizient, we go through them to order. We just approved them for some things here recently, right? But I do notice that we do a lot of procurement over and over and over with the same vendors. So is that because we're using Vizient? And
No, Vizient has a competitive bid process as well. It's just on a national scale. And typically, because they're covering so many health systems, almost every category is a multi-source award, right? So what we will do is run those Vizient awarded suppliers through our clinical value analysis team, and we will select which one's the most clinically appropriate for us, best value for us. But
They do the same thing as all of the pharmaceutical goods, US surgeons, myself, rationalizing all these, so you'll have 6% change different, right?
Yep.
Once you're in top 5.
Yep.
Standardizing gloves, yeah.
Yeah, and I would say, you know, historically, supply chains, particularly in smaller systems like this, have been very decentralized, right? You have surgery departments, and they're one surgery department, right? So they kind of operate it. Obviously, when you get to a large health network, and you have particularly multiple hospital surgery centers, you can't have each one doing their own thing. So that's where supply chain comes in, is to really look at what we're buying across the network to make sure that we're using one glove, right? Or a set of gloves under a certain contract, and then we're standardizing that across the system.
Do you manage PPI or other department manage that?
Say that again, sorry.
Do you manage PPI or other department managing that?
We manage PPI. We've worked through a dozen PPI categories over the last year. The challenge is it's really important to partner with the physician, right? Because they have all the leverage, they have the physician relationship. So a lot of it is sharing the data with them and getting them on board, and then we can attack the categories. So we've been working with Dr. Beam on trauma. I can name several categories, but the physicians here have been very supportive in driving some of these.
Good success.
Contract compliance, you checks that. If they're not meeting the expectation, one, they'll cover those things for the.
Yeah, so the way so we have about 500 million to spend. About half of that is PO, half of that is non-PO. We're trying, and think of procurement as a funnel. What I want to do is shove all that spend into that funnel so that I can make sure it's on contract, has KPIs, and we can manage it, and link the POs to that unit. So we're in the process of shifting all that over and standardizing all of that, and that's what we do on a daily basis. There's about 550 product categories individually. Imagine do that, we're trying to drive more and more to the next stage.
So that small vendor, sorry, is not able to compete then.
It depends. I mean, it is harder for some of the small vendors to compete on, right? Obviously, it's hard for them to get on a national GPO, right? But there are exclusions and supplier diversity initiatives through Vizient as well that they can take part of and get on those contracts. There's a variety of methods, but they can work with us and we can kind of coach them and show them ways. But at the end of the day, it's got to provide value to us as an organization, to the county. So their hardest challenge with a small vendor is just volume pricing. That's what drives the prices down. So it's a balance between the two. But there are certain things, obviously, in the construction world, there's a lot of service vendors that we have a lot of local businesses. It's a little bit harder in the big commodity markets.
Yeah, what makes it easier is if the owner decides that it's going to support those small businesses, or they'll never have a chance. They'll never get to the volume. But how do you, everybody had to start somewhere, right? So I think we have to be intentional when it comes to our smaller companies, if we're going to be, say we're going to support small businesses.
Sometimes it's the ability to scale.
Yeah,
Like that
I think
right now
that's
is
the big
part of
thing.
the battery company.
Yeah.
And it's awesome battery system. And the US government came to them and said, great, can you get us 10,000 by next week? And we're
Well,
like,
you can find a partner.
no, they can't. The pricing was good and everything was good, they just can't do it.
And I think there's opportunity. I agree with you, and I also agree that it's really being able to scale up and keep our stock and supply going, because we run through huge amounts. You guys approved, I think it was tubing or something, with multi-million dollars and things like that. At the same time, you heard Charlie speak about that we've got to put some redundancy in the system so that we're not relying on one vendor who may be shipping in from overseas. And so maybe there's opportunity for some of these smaller vendors to say that a certain percentage of that, that we may be able to allow you to supply. But also, as we start to see a decrease come in because of the street being closed or whatever, that we're going to shift some of that to totally great.
Or it could be an opportunity to have a small business program back in play, or something sort of, let's see that thing. And then you can kind of start tying them in with Vizient and all these other larger manufacturers. I mean, if that's what the goal can be someday in the future, like it used to be back in the day. But I'm just saying, because we have to, at some point, we're gonna have to take care of small businesses. And if we gonna run big projects, big campaigns, be about the community and economic development, where do they leave small businesses?
Totally agree.
If major entities.
It's so hard.
Totally agree, but agree with Charlie that we're balancing these financial strains at the same time. And so, every dollar we're trying to be.
I get it. I understand where
So-
you guys are coming from, but also
It's very
we have to
hard.
figure out how we.
you gotta have to figure out, because it's still, who's gonna do it, right?
I think it's hard because you got pricing, you got volume, and then the other one's value out of it. And flipping on the other side, 'cause I was on the GPO side before. Now I'm on the vendor side. It's my sales team that has the responsibility because they have to find a way. And it's like you put someone in the dark room, and then they're trying to get out, and they just hit the wall, they try again, take a few steps and go back again. You gotta find an opening somewhere, so that's called sales. Because you can't teach them sales, they have to recruit people that are good with sales, who find a way to partner with the big guys or something like that. It's that hard. Otherwise, and I'm not sure we have the capacity for the knowledge to go guide people of how to do the business with us. We can do it in a grants, in a standard way, but we can't customize like each individual.
How do you gather big businesses and do business with us? I mean, I don't even understand that.
You got.
I mean, that's why you have these guys, you have procurement.
Well, and let me explain that like
It's
this.
value.
Supplier diversity is important for supply chain. And I mean that in a very traditional sense. What happens with departments is they want to do business who they've always done business with. And what happens if you do that over time, that builds an incumbent. It makes it harder and harder for people to get. What we want to do is we want to test the market often, level the playing field, and then award best value, so that we're constantly going through that cycle. So everybody gets a chance to compete, but they need to win the business, right? Because we have to be responsible for accounting. But we're not going to continue to just do business who we've always done business with just because that's who we're comfortable with, right? Our job is to be intermediary and make sure that we're testing that market, and that these vendors that haven't had a chance to come in, if they deem that they're in the service the category, get a chance to submit a bid. We go take it to the stakeholders and provide transparency around that process.
Yeah, I mean, that's the only thing that I'm asking. Nobody's looking for anybody to give them anything, but I just think there has to be some type of avenue for small businesses to even be able to get in, to introduce themselves. We know those relationships are the most important thing, you know, in any business of relationships. So however we get in, whether it's a small business or a big business, I just don't think the same company should begin to work all the time, the same company, because it's easy, because we know them, because we don't have to write an RFP, you know, because it's too much paperwork. You know, I think we ought to put more effort in. I think we got the FTEs to do that. Yeah, that's fine.
Are we the people who are supposed to, you know my business, we've talked, you know, oh, this is that I own all different sizes. We already give so much to the community. You know, we're fighting every day for every dollar. These guys, it sounds like they're doing the due diligence necessary, but our first responsibility is to the community when it comes to the hospital. Not to say, hey, I'm gonna give you a shot to help your business. No, we're here to help the people who need the care, not the businesses. I'm a small business like you are. I understand that this hospital's not the place. Go down to Cook's, go to somebody else, say, hey, I want to get in. But here, we've got to say what's the best for our community as a whole, as a hospital, not a business. I don't look at this as a business, I look at it as a hospital.
I look at that as, yes, we want the best, but we've already assumed that they can't do this. So that's my point, that's my thought. Because to give a small, the person that's trying to get business, have to communicate with them and let them know they are here. That's number one. Then if they can deliver it and they have the quality, then they're in the game. That's what I'm saying.
That's
So,
good. That's what you have to tell them.
Well, the next slide talks directly on that. Supply chain is your financial steward, right? It's driving value beyond cost. One of the most important roles of supply chain is financial stewardship. That is what we do. There's an old trinity that's purchasing is used for years, but it's not just cost, it's quality and outbound. You have to look at all of those things and have the right stakeholders making that decision. Supply chain doesn't make that decision. We're funneling the process and making it transparency and level the playing field. With the right clinicians, the right finance people, the right operations people are at the table determining where that best value is. We're documenting. It's public information. Our bid tabs are public information. So we're ranking these vendors, we're ranking these proposals as we come in, making those decisions, and doing what's best on a daily basis. Usually 3 years. We'll do 3 years with 2 optional 1-year extensions, typically in case we know. We try to do a 90-day out, no cost.
How do you want to deal with CPS historically and roles? There's historically things that are auto paid, and then you contract with them this, or you have to set up with them, a pretty strong
Yeah, so for most goods, the PO is linked to the contract, right? So if there's a price discrepancy, if you measure quantity, it flags, and AP has to work with purchasing to either we'll contact the bidder and get them to correct the price, which happens frequently. Or if there's something we miss, we'll update the PO, but we have to do that before AP can pay it. Service is a little more difficult, but typically for a service contract, especially if it goes to the board, we'll have a cap on the spend that is approved, and we'll link the PO to that cap. So we can't spend over that cap without it going back to us to approve that service. And that could cause an additional contract amendment or whatever, but we have to be involved in that.
So when we go to payable, do we issue? Because do we pay them directly, or do we hire a outside vendor to do that job?
Accounts payable?
The reason I ask is because I hate a lot of hospitals, you sign a contract with them, and then send to somebody else, and they take the fee out of it before you get paid. That will hurt a small business than anything else. I want to make sure that if we use outside vendor, we pay for that fee, not negotiate price and then force them to take that lower fee to another vendor to finance. That's kind of the process. All they do is delay the payable date and use that as a float.
And we have a obviously for separation of duties, accounts payable done in finance, but we work closely with them. I consider that part of the procure to pay process, right? If I do things right, it makes it easy for them to prove and actually pay. Any exceptions need to come back through us because we need to fix that and approve that. But
I didn't hear, do we use that? Because remember the old day when you fax stuff, when you send a draft, it's different than a check? I didn't hear that answer, that's why I'm asking.
Yeah. Lots of tools, everything goes through our ADI vendor electronically, and we get electronic invoices back. And what we're able to do with that electronic information is look at the match rates and what's causing that, whether it's the line, the quantity, the measure, the price. So we have lots of data and oversight of that whole process.
That's not my question. My question is, do we use a third-party vendor to pay and then they take the fee? No. Okay.
What about rebates? Is that part of our program? Yep. What does that look like on an annual basis?
I don't know on an annual basis. So let me answer it this way. We're developing a document savings plan. So part of that document savings, we're trying to document all cost reductions, cost variance, cost avoidance, and rebates and incentives. Historically, rebates have been sent kind of throughout the organization through different paths. We're trying to consolidate and track all of those.
What are the typical terms? Are they net 30 or are they
net 30?
Yeah.
Sure. All right. Let's go. So we talked about supply chain stewardship. One of the most important is ensuring those resources are utilized effectively as possible. This includes managing contracts, reducing waste, optimizing inventory levels, improving utilization practices, and ensuring compliance with negotiated agreements. Importantly, our objective is not just simply reducing costs, it's achieving best value while maintaining quality, safety, and operational effectiveness. Supply chain stewardship allows us to redirect resources toward patient care and other strategic organizational capabilities. This is just some of the key metrics. If you said, how do I measure supply chain? There's a lot of metrics, but as Kim talked about earlier, we look at supply expense per adjusted patient day. The 324 was our prior year threshold. Our actual to date is $312. We talked about that documented savings program. We have 2.5 million documented so far this year. Our goal this year is to document 10 million. Contract compliance is probably our biggest opportunity, and that's getting more and more spend on contract. 65% is our rate today. Best in class is 90%. I'd love to get to 80%. So we continue to look at that. And then price index is a essentially a comparison of our pricing compared to comparable organizations across Vizient. So we're at the 54 percentile. Best in class is the 38th percentile, right? Part of the challenge, we have a lot of local agreements that I'm not going to get the same pricing as the THR or Baylor Scott might, particularly on physician implants. So my price is around the 50th percentile in the market, where a THR or somebody, a large organization can get towards the 25th. And it's just something that smaller hospitals won't have as much opportunity to do. What's that?
If everybody buys from Vizient?
No, there's a lot of physician preference categories that are on GPO contract, and each health system is negotiating those locally. It's basically volume and the number of procedures. I can't get the same price on a total hip that a THR can, and they're doing quadruple the amount. So those are some of the categories that just being a smaller health system. There are opportunities to get around that, and that's to partner and collaborate with some other organizations. We're doing it with Vizient. It's called the Commit program, but it's a pre-commit program where lots of hospitals, similar to us, pre-commit to a category, and then Vizient can go to the market with all those pre-committed, and whatever they award to, we would go. So we're doing that with our med-surg product right now. It's about a $2.5 million savings opportunity that we couldn't get on our own. They do have that with physician preference as well. It's a lot harder to go after that. So we're going to see the success of the med-surg and then hopefully move that. And all of those things will help move our price index down.
Give us a couple of examples of what parts we included in med-surg.
All your medical surgeons, so basically your commodities, your needles, your masks, things that don't have it, gloves, not clinical preference.
No, the Vizient.
Those do go through Vizient, but again, I don't have the standalone volume. Most of the Vizient contracts are tier oriented based on volume. So I might be on a Vizient contract, but I don't have, my spin qualifies me for tier 1, where a THR can get tier 5. So their pricing is going to be, it's not all the same with Vizient.
But you're still getting a better deal than if we went direct.
I get a better deal than that.
I feel like third party group or anything group can possibly together with that as we ordering.
Yeah. We call those regional aggregation groups, and they do exist. And there are some of those we can do. Obviously, we're a county facility. We have certain RFP requirements, but they may not. So we need to align with similar governmental organizations. So we're finding all of those different opportunities and trying to drive.
Well, on the backside of that, if you want to fly,
Yes. Yeah. Part of all that is digitizing the supply chain. So we're going through what we call car optimization right now and re-engineering every location across the network. You can imagine how many there are. It's easier to build new, so we actually have one going into the health center for women's. It's about to open up this fall, so nurses can see what that looks like. But we're going to be standardizing that model and digitizing it across the entire organization. So when I know there's a back order, I know every location that glove's at. I know the volume and utilization of those gloves, so I can move those out and put the high volume things in. That makes sense.
So do you track like the expired supplies? I know that, we're always around and making sure that our supplies are not expired. Do you track that to make sure that we are more in real time with
Yeah, so we do track all that, but a lot of, like I said, a lot of departments are still decentralized, so they haven't been integrated. That's the restructure that we're working on as we speak. So we're going to be taking over those supply people in those various departments, so we own it, and now we own the supplies in one location, and we can aggregate and track that back better.
So you know about how much, so you would not know how much
I know
expires supply.
I know from our warehouse perspective, and it's actually very low because most
and financial sustainability for the organization. This is our agenda for today. I'm just going to go quick through who we are, where we're located, what services we provide, how we support our patients, why 340B matters, hint a lot, what the current challenges we are experiencing, how we manage our stewardship from a safety and resource perspective, preparing for the future, and building the budget. JPS Pharmacy is 400 pharmacy staff across 20 different locations throughout Tarrant County. Our team services care through inpatient and community settings, and our governance structure ensures strong oversight of our formulary management, safety, quality, and 340B program. In addition, our partnerships with Vital One strengthens operational execution in areas such as specialty growth, payer contracting, and regulatory compliance. This scale allows us to have meaningful impact on access, quality, and financial performance. In the ambulatory setting, pharmacy plays a major role in enabling access and continuity of care. We operate 10 retail pharmacies, along with correctional and clinic-based services, supporting over 1.3 million retail prescriptions and nearly 5 million dispenses annually. We also manage a high volume of patient interactions, including 250,000 calls and over 100,000 clinic administrations. Our clinical pharmacy specialists who operate in our clinics directly improve patient outcomes by lowering A1C levels, improving blood pressure control, and reducing heart failure complications. The work that they provide goes beyond volume and translates into better disease management, improved access, and high patient satisfaction. On the inpatient side, pharmacy is central to both safety and care delivery. We support more than 5 million inpatient medication doses and 132,000 infusions, while programs such as our Meds to Beds improve discharge transition and reduce readmission. Our patient assistance program generates $93 million in cost avoidance, directly supporting patients who would otherwise not be able to afford their medications.
Stephen, are you going to speak to this patient assistance program later on?
I can speak on it more in detail now. Sure. So the patient assistance program is a very manual process for these. These are free drugs that we're getting for our patients. So we are helping them complete all their paperwork and faxing it in to the manufacturers to then send free drug back to us to distribute to the patient. They can also send it to their clinics. They can also send it to their patient's home. And we have to track all of these drugs by the specific lot numbers and how they are delivered to our patients to account for the program and what's being used. And like I had up there, it's $93 million. It's very manual. A lot of time is taken to coordinate the medication, but also work with the patients directly in how to fill out the paperwork. So getting all their income information, getting their Social Security numbers, getting all the information that they need that are required as part of their programs is a significant overhead and significant amount of time that it takes. And so of that $93 million, we have roughly 12 PAP staff that work with those patients to obtain that $93 million. And that is true cost avoidance. And so sometimes you'll hear at some organizations other maybe more inflated numbers, which should just be the retail cost of medication. This is truly what we would have paid to obtain that. So a lot of times the 340B cost, which we'll go into a little bit later, but is substantially cheaper than what your retail perspective is. It's about 18,000 prescriptions a year that we do this for patients.
And these are for patients that would not have been able to pay for any of it.
Correct.
So we would have had no revenue off these prescriptions.
Correct, and we don't get revenue. This is cost avoidance. So this would have been costs that we would have otherwise had to pay. We would have to procure those medications at cost and provide them to patients. Oftentimes, JPS connection patients who would have otherwise not been able to afford them. That's annual cost avoidance.
Stephen, can I ask you differently from his question?
Sure.
I think we generate revenue, but we don't get any profit out of it. Or do we don't?
We don't generate any revenue for this.
Okay. I thought everything goes to Epic as a charge. Because otherwise you don't.
Yeah, these are straight through the manufacturer. We cannot charge the patients for this.
Maintenance drug or whatever that is, not going dispensing through our.
So this is different. So you're probably referring to like a copay assistance program that you have at your retail pharmacies, where you have like a copay assistance card. Is that kind of what you're thinking about?
No, I was thinking if it's dispensed like a Part B or something like that, it might appear on our system and then we write it off.
So we don't write it off. So if there's,
Outside of our dispensing, right?
if some of these come to our clinics and they'll be clinic administered drugs. So like our infusion center has a large percentage of these drugs. Those infusion drug costs, oncology drugs are expensive, right? So what happens is the PAP team works with the patient to fill out the paperwork. They mail it off to the manufacturer. The manufacturer then contacts us and says, hey, we're sending it, sends it in, and we actually have to store that drug patient-specific within our OIC pharmacy that's labeled, so-and-so so-and-so information that we will then actually pull and go in, prepare, and then dispense to the patient, and they'll receive that infusion. In the back round, what happens is it's changed to a penny, it's changed to no cost for that patient. It's there as a placeholder to document that it was administered on the patient and from a record standpoint. But there's no charge to the patient for it.
There's no charge up here.
Yeah.
You said there's 12 full-time employees here?
Roughly, yeah. So
Are they pharmacists?
they are pharmacy technicians.
And are they so busy that like that 93 million cost avoidance could be 120 million if they were able to somehow streamline what they're doing? Or is that 93 million pretty much it?
So we just recently got 2 positions approved to actually expand that cost avoidance, and it's growing proportionally. I think as our patient population continues to grow, I think there will be continued to be opportunities to expand.
Right, that's what I was gonna ask. I mean, because they're doing like a little form, they tearing the form out and filling it out, or
So
is there a faster way?
it depends on what from a systems perspective, the manufacturer allows. So a lot of times they keep it very rudimentary. There's not an online system, an aggregation system. We've looked at different vendors for that. Oftentimes what it'll be is you'll still have to print out the paperwork and send it in. So I think there's still efficiency opportunities that we can drive. There always is. I think that the biggest piece with this is really coordination with the patient. A lot of the time that they spend is getting the information from the patient, and that's where a lot of the delays and impact really is. It's not so much finding the application and quickly sending it in. It's waiting for the patient to submit their paperwork. And so that's really the inherent challenge with the program is it's very patient-specific. It's relied upon the patient, so.
93 million avoidance is not the hospitalizations. That's not even calculated.
No, that is.
Life-saving drugs that are taking stroke prevention.
Correct.
Heart attack preventing. It's got to be in the hundreds of millions.
Yeah, this would have been, that 93 million alone would have been just direct costs to the organization to provide the medications for the patients. So it's a great, wonderful program, and we're fortunate to have such a good team to manage it.
Yeah, to his point,
Mm-hmm.
you're avoiding hundreds of millions of hospital charges.
Correct.
This one does require a lot of paperwork to follow up because you still have to file claim and then deny before you can submit it to the patient assistant.
Yeah, it depends on each individual program. And one of the challenges that we also experience is the manufacturers can cancel these programs whenever they want. And so at times we will get patients started on these medications and then the manufacturer will actually pull the patient assistance program. And we'll have to work with the providers to find an alternative. And I will say that is some of our hardest challenges because you already have a patient established on the medication that you're now having to switch to because it's no longer being provided through the patient assistance program. But that's impacts real patients all the time. I will tell you, obviously that is one program that the manufacturers do to also try to get more people on their medication, right? And so that's just one avenue that they take. And so when they find it not financially feasible for them, that typically is why they'll cancel the program, right? So, but that happens regularly. I get emails from my team letting me know that we have X number of patients impacted and for these drugs that are being canceled, so. And then for just real quick too, we do have training programs that we work with high school students as well as the local colleges of pharmacy. And I will happy to report that actually just yesterday, one of our preceptors got Preceptor of the Year for Texas Tech. So they got to come on site and we got to celebrate that. So we're excited about that. Another one I'm sure we'll have a lot of discussion about, specialty pharmacy. So in FY25, we expanded our specialty pharmacy program, and that was focused on improving access and strengthening financial stewardship. And I wanted to come back to you guys to present today how that's going. Since FY 2024, we've increased our prescription capture by 56% and our revenue by 16%. So that's our volumes. Our volumes have increased 56% since FY 24, and then our revenues by 16%. We got full accreditation with URAC, and we got reaccreditation with our ACHC accreditation. We've been able to expand to additional payers, and we've also been able to open up a new specialty location that actually just moved this past Monday. So we have a brand new, much bigger location to help account for all this new volume that we're seeing. The team does a wonderful job with our patients. We're able to maintain a 90% patient adherence and 100% patient satisfaction that we have for these patients. And so specialty pharmacy, I think you guys have already kind of briefly heard pieces of it, but these are very high cost medications. This is a very small subset of the overall patients that we serve for the organization, but represents such a huge cost and revenue generating opportunity for the institution. And so the key piece for this is how we continue to grow the program and continue to expand into additional payer networks and even what are called limited distribution drugs. So manufacturers will actually have only specific pharmacies that can actually procure these drugs. And we want to be able to get access into that to be able to provide more opportunities for our patients to receive care.
You have 100% provider satisfaction. Dr. Fowler, can you say that? 101.
These are very high touch. I mean, this team is doing 20, 25 prescriptions a day. These are very high touch. They're calling the patient every single time they have to refill the medication. They're making sure that they're adherent to the medication. Any questions that they have, they're reassuring. Any side effects, they're following up with them. They're communicating with the providers to make sure there's communication. It's because of those high costs, you want to have that high touch. And that's also why there's the associated reimbursement for that. And so this will continue to grow. This is going to be another fun one. So 340B, the 340B program is massive for our organization, and I'm sure you've heard about various things in the news as well about the 340B program. It's vital to how we support our patients. It allows us to purchase medications at a discounted price and reinvest those savings into patient care. At JPS, the program generates over $170 million annually in savings, which this supports our patient assistance programs. It expands our access to medications that we talked about, and it helps to offset cost of uncompensated care. Without this program, many of the services we would not be financially viable that we could provide. With the 340B program, there's obviously a lot of interest in this at a national level. It is under a lot of scrutiny at the moment. There's a lot of concern from manufacturers, policymakers, and regulators that are going to create both operational and financial risks for safety net hospitals like JPS. One of the most immediate challenges that we're experiencing is manufacturer restrictions on our discounted drugs, particularly in the contract space. Several manufacturers have actually limited or conditioned access to 340B pricing recently, and they're requiring additional data submission or actually restricting distribution altogether. So they believe that there's not enough transparency in the program, and so they are threatening to restrict our access to this pricing unless we provide the information as to where it's being dispensed and how it's being dispensed. As of this recent update, as of today still, there's 8 manufacturers who actually have this restriction for in-house pharmacies. Originally, this started from the contract pharmacies, so you have a contract pharmacy relationship where it's not one of our in-house JPS pharmacies, but it's an outside pharmacy that we contract with that may provide care for our patients. And we extend that 340B savings to them, and we have their contract pharmacy relationship for that. We actually have over 100 pharmacies that we do that with. That is originally where these started from, and they've just been getting more and more focused, especially on the in-house pharmacies now as well. We have increased controls around the 340B program. We have a completely dedicated manager over 340B. We have HRSA audits, we have internal monitoring, we have split billing system, and we have many compliance controls over our program. New proposals at the federal and state level really want to expand what's going on with the program and what kind of information you have to provide. There's been discussions that you'll have claims level and encounter level data that you have to submit. So actually not only just sending, we dispense this drug and this medication to this patient at this date, but actually saying this is also the corresponding visit that this patient had with this provider that actually qualifies the patient as our patient. There's even discussions about more detailed reporting on how the savings are used, including community benefit and patient impact. There's also questions about eligibility for the patients and who qualifies, and that's particular in the contract pharmacy arrangements that I talked about further. There's requests for increased auditing, so we do get audited from HRSA every 3 years, and we also have our internal controls as well. But there's even talk that beyond HRSA, there'd be additional authority and additional site visits and audits outside of that. $170 million per year. What? $170 million. It's massive. And I will say that is off the retail cost of the drug. What is basically list price, published price. As you guys kind of heard already, there's layers to that. There's a lot of different pricing that goes around, right? But that is essentially the list price of the medication, and so that's massive. So there's a lot of different aspects of the program. A lot of it comes down to our internal controls and our auditing practices. So what we're doing, looking at individual patient claims and making sure that every individual patient claim, qualified, and reviewing each of those at that individual level. Not to try to get overly complex, but not necessarily all of our prescriptions qualify as 340B eligible because we service patients outside of just JPS providers, let's just say employees or other ones outside of the network. We actually can't use 340B drugs for those. And so we are constantly auditing and reviewing at a claim level each of these to make sure that we are compliant to the program, that the patient qualified appropriately, that any additional logic that we need to include in our algorithms that we use to manage which patients qualify and which ones don't are constantly being updated and reviewed. The program even gets a little bit deeper into that because when you actually go to buy the drug, you'll actually have pharmacies that are considered split-use pharmacies, and then you'll have pharmacies that are only 340B. We actually have a variation of the two. So we have some pharmacies that service both non-340B and 340B patients, and then we have some that service just 340B patients. There's different reasons for that. One of them is one of our mixed-use pharmacies is actually our central fill pharmacy. And so because that's one of our mixed-use pharmacies, what that allows us to do is actually we use our central fill pharmacy to send out a lot of our refill medications to our clinics to be picked up by our patients. And so we're able to still provide the level of service to all of our patients independent of whether the individual pharmacy was mixed use or not mixed use, which means, doing 340B only or allowing non-340B patients. And so by having that central fill pharmacy, we're still able to expand care and service patients both at home through mail order, which roughly 25% of our prescriptions that we send out through our central fill are mailed, but also support the patients to be able to receive their prescriptions however they want at any individual pharmacy they want. Central fill also allows us to save costs from an inventory perspective because we're able to centralize our inventory and not have to purchase the same drug at 5 or 6 or 7 different pharmacies. And so we're really able to control from a stewardship perspective how we manage the drugs.
So when you were saying some of the pharmacies they can do both, there's really only, based on your earlier chart, 2 pharmacies. There's central fill and then you have 1 clinic pharmacy.
We have 10 retail pharmacies. They fill and distribute.
Okay, so Central Phil's not supplying that?
It is supplying them. It can do both. So you can walk up to the pharmacy. They can fill it locally if you want it same day, let's just say, or immediate. They can fill it and service you right there. What for a lot of what we do is for maintenance medications, we have it filled from Central Fill. We know when you're going to need it. We know that you requested it. We send it over. You already tell us, hey, I want it at Maine. Let's just say here downstairs. I can come to Maine. That'll actually be filled at Central Fill, but it'll actually be picked up at our main pharmacy. So we do both.
And some of those retail pharmacies do 340B, some don't?
Yes, so some of them, the filling that they do on site is only 340B. That's because, one, the number of the patient population that they serve and where those prescriptions are coming from. And two, what that helps us do, one, it's cleaner from an inventory standpoint and an inventory management standpoint, but it also helps us reduce costs associated, let's just say, waste. So if you procure a 340B medication and you have to waste it, let's just say, at those closed sites, you're able to purchase that drug back at 340B because you know all the patients that you serve there are 340B eligible. If we waste anything at a mixed-use pharmacy that has both 340B and non-340B, any drugs that you waste that are 340B, you have to buy at the full retail price instead. And so that can be completely not of our own fault too. We could just dispense a medication. Let's say it comes in a 90-bottle tablet and we dispense 60 to this patient, and we're left over with 30. We could have no new patients come in who would be on that medication. We'd just be out those extra 30 tablets by servicing that patient because of the order that we received didn't have the full 90-count bottle. So you have natural cost loss from that, that when you have your closed site pharmacies, you're able to replace that at least at 340B cost versus having to buy at a higher cost instead. It's pretty complex. The mixed-use pharmacies, you actually have a system where you manage how many have been sold to the patient. So we actually have a count, a running count from an inventory perspective to make sure that we have appropriate accounting of how many patients received WAC and how many patients received 340B. So how it works is when you sell a patient who qualifies for 340B, you get that amount in our accumulator to be able to then go and buy more at that cost. So that's how we kind of manage the program. I'm going to move on from 340B and just talk about our overall challenges that we have, even outside of 340B. So in the pharmacy space, there's been some recent legislation that also has changed quite a bit for the pharmacy side of things. So reimbursement continues to decline across our government and commercial patients, while the Inflation Reduction Act introduced additional financial pressures. Drug costs remain high. Ongoing shortages and supply chain disruptions continue to impact availability. Workforce challenges, particularly technician turnover, add to operational strain, while administrative requirements continue to grow. I do want to spend just a quick moment. So the IRA, the Inflation Reduction Act, those 10 drugs, 3 of those drugs were some of our highest margin drugs that we have. And when this came into effect, how this worked is what basically happened is you have the retail cost of the drug. The retail cost of the drug on Jan 1 got dropped. We pay for 340B. When the retail price of the drug got dropped and we buy at 340B, all that changed. It didn't change any of our bottom line. And so the margin difference that we get has shrunk because of things like the Inflation Reduction Act on those drugs. So the savings that we get from the program decreased from the Inflation Reduction Act. And there's going to be another 15 drugs in 2027 that are coming that will further increase essentially that reimbursement that we get from that.
We're not just buying the 340B at a cheaper price. Somehow we're benefiting from the difference between the discounted price and the retail price?
So the savings that you get from the program when you buy the drug is based on the reimbursement that you're going to get from the payer. So our cost of doing business essentially didn't change, but our reimbursement dropped. And the reimbursement dropped because what's used as the average retail reimbursement rate across the country dropped because the actual cost to other non-340B eligible entities also dropped. And so we're not getting reimbursed at that higher rate, that the savings, essentially that reimbursement that we're getting from buying the drug at a cheaper for those commercial patients. And so we're seeing that decreased margin.
So Blake, basically the payers pay us on a formula related to the cost of the drug at the retail price. So when the retail price drops, our revenue drops, but our cost doesn't drop on the 340B. So cost drops for the retailer, revenue drops, our cost doesn't change, so it makes our margin small.
340B doesn't produce our purchase price.
No, not in this case against the Inflation Reduction Act. Basically, anytime you lower the retail price, we get paid by pharmacy benefit managers based on a formula related to the retail price. And that's just how PBM contracts work. And so when the retail price drops, so does the revenue.
So can we hedge pharmaceutical goods like you can with I'm asking.
So the 340B is the cheapest you can get the drug for. It's federally mandated from the federal government, right? Right. Now, we do creative things to try to still, you talk about stewardship, and I'm jumping a little bit ahead, but we do other creative things to try to help manage the program. So you also have times where, let's say a manufacturer has a compliance issue. They will voluntarily commit to providing the drug, not even just at 340B price, but let's say a penny price. So they will provide the drug at a penny price for a period of time. We will make sure to stock up so we can have that drug at a penny price to then use in the future, even if it comes off of penny pricing in the future. So we do take opportunities like that to save us and save the institution money when it comes to the program as well. But yeah. There's also the potential outpatient reimbursement on the pharmacy side as well, and this is the clinic side that's coming through the OPPS. We also have consistent PBM audits. We actually had over 2,000 audits this year by PBMs. They'll actually come in and review prescriptions that we've already dispensed to actually review our records to see if we should have dispensed them or not, even after we've already been paid. Yeah, so it can get pretty interesting sometimes about what they find as concerns. For example, if we don't have your signature when you pick up the medication, they could say that according to our procedure, not our procedures, but their procedures, we don't know if the patient got it, and so we're not going to pay you for that drug. We don't get paid. Even though we've already given out the drug, we can confirm. We do a really, really good job of fighting anytime they come up. The number of times I want to say that we haven't gotten paid on claims, 20 claims or less of the 2,000. Yeah. And this has been talked about. Keep going, sorry. Okay.
On those 10 drugs, 15 coming 2027, and 2029, 25 more coming in. How many of those drugs affecting us the most?
This first one hit us a lot harder than the next one will. So I was actually looking at that this morning. The first round of those 10, we had 4 drugs that are our top margin drugs that were impacted by this. The next 15, I think there's only 1 drug that are in the top 20 of our reimbursement, and that was Ozempic. So it'll be less, thankfully, but it's still obviously an impact. Overall, I did include some information just real quick about our top spend therapies. GLP-1s, as you guys have heard in the news, are expensive and have driven a lot of the costs. Our top spend therapies are also HIV related and Hep C related. Many of these drugs all of the drugs that are top spend are actually non-formulary drugs. We are providing them to patients who have funding, and we're working through PAP and other measures to make sure that patients who are JPS Connection patients are getting those drugs. So we're really trying to control the cost with those expensive medications.
Are we at the point that it's been released for a while that we can track to see what's the total cost of care? Because it can go up, but I spent on the patient for obesity and all that stuff coming down. So
when you say total cost of care, you mean across the life of the patient?
patient, right? That'd be downstream costs,
Not exact, I mean, not anything that I've found, that, yeah, I mean, I know like for Hep C, there's like, you know, Hep C is curative, and so you talk about quality of life and impact from that perspective. I know some of the qualities for those drugs are massive. We don't have that level of detail for all the drugs that we dispense. But that is one that obviously there is a lot of data out there to show what a community impact treating somebody Hep C is and what that means from a long-term perspective relative to their health and the cost of maintaining their care when you can treat them for a disease. Real quick, I referenced this earlier, but our specialty growth does represent over 35% of our overall drug spend for the organization, yet is less than 1% of our prescriptions. And then the future, kind of talking about really the future, what's coming. There's the new drug development, gene editing level drugs that some organizations are actually encountering that can be upwards of $2 to $3 million per administration. These are gene editing drugs. We haven't performed any here, but when you talk about what's coming, that's really what's coming down the pipeline from a future perspective. And so when you talk about if something has to be compounded, think about a technician in the clean room compounding a $2 to $3 million drug. Talk about the how you'll feel doing that. Yeah. So those are, you have a whole contract team, you meet with the PBMs and the manufacturers directly. There's a lot that goes with it, but it's exciting, but it continues to grow and put new considerations as we grow the program. From a stewardship perspective, we have various avenues that we use. We really focus heavily on evidence-based prescribing, strong formulary management, and our MUEs, medication use evaluations, to guide appropriate utilization of the drugs. So not only do we have them on formulary, but we review how they're being used to make sure that the restrictions are in place, that they're appropriate, and that they're being used for the appropriate indications. As we mentioned earlier, we maximize our patient assistance program, and we look to reduce any unnecessary waste that we can. We utilize central distribution. We talked about our central fill pharmacy, and we also use automation where we can to improve efficiency and lower cost. Patient safety, I just included some real quick images of various things that we utilize across the network. In the top left is actually a picture of our lighted bag system. So this system helps to make sure that on our retail side, we are dispensing the correct medication to the patient when they come pick it up. And so that will actually light up when you select the correct patient to actually deliver the drug to. In the top right, you can actually see a picture of one of our clean room IV hoods where we compound medications, and you can see a camera there where we actually do inline checks. The technician will actually take a picture of the camera and barcode scan the medication to send to the pharmacist to check to make sure that they're preparing it correctly. Bottom left is our new Parada equipment that we got for our correctional health facility. There's two of them you can't see on the other side, but these machines pump out around 13,000 doses per day through those machines. They just churn through. What they're doing is taking a bulk bottle and repackaging it into individual doses for the patients at the correctional health facility. And then we actually just recently got a drug waste testing machine to also expand our drug diversion program, and that's in the bottom right-hand corner as well. So that gives us another tool in order to help just improve our program and from an accountability perspective. Preparing for the future, we are investing in capabilities that position us. This is automation to improve efficiency, reduce errors, and control costs. We have advanced analytics and AI that we use to help predict drug shortages and optimize our inventory management. We are also expanding our specialty pharmacy services. I talked about that briefly already, and we're improving our patient access. This helps us prepare for the future in a more complex, high-cost, and data-driven environment.
Question for you.
Sure.
Oh, no, go ahead, finish it, and then I'll ask a question.
Keep going. You want me to go back?
No. I thought you had one more page before I asked a question.
Oh, okay. And just, I'll go quick. We obviously considered demand, cost drivers, and stewardship when we built the budget. Our hospital volumes, our clinic volumes, our specialty market growth, how correctional health is growing. Again, talked about already, cost drivers, the new drugs and inflation, the new high-cost specialty meds that are coming. Additional challenges always with workforce and labor shortages, especially on the technician side. We still have consistent supply shortages and drug shortages, mainly around our controlled substances. The DEA will actually cut the amount of controls that actually are in circulation. And so at times we'll have supply issues from that perspective. Any patent exclusivity, so any of the brands that have patent exclusivity obviously are cost drivers if it can't go to generic from a savings perspective, and then just continuing mail order and delivery as that continues to grow as well. And then I mentioned already, but the stewardship program, 340B, how we manage formulary, inventory controls, our automation, our patient assistance program, and then any other also grant partnerships that we have. So, in closing, pharmacy is no longer a dispensing function, but a critical component of patient access, quality outcomes, safety, and financial sustainability. Through programs like 340B, strong stewardship practices, and strategic investments in automation and emerging technologies, JPS has positioned itself to meet future challenges while continuing to serve patients effectively.
Question for you. I'm just curious because we don't touch on MTM. Is that because the program is mature enough to the point where we don't need to look into it? Or?
We do provide MTM services to our patients.
I didn't see it on here, that's why.
Yeah, it is a pretty small percentage. It has to be funded by the payer to actually be able to be a revenue driving opportunity for the patients that we serve. We do have a dedicated pharmacist from an MTM perspective who's actually based on the retail side who provides those services. We also have our clinical pharmacists that see patients that receive consults from providers to actually have focused care for, and that's specific to our diabetes patients, our hypertension patients, our high blood pressure patients, and our dyslipidemia patients as well. And so they see patients in the clinic like a provider would. They have a visit with them, and they make sure to maintain and increase a lot of their A1C goals, their blood pressure goals, and even like CHF they help to reduce. So we've
let you know why I asked that question, because as we move forward in the future, because of value-based care, star rating, and reduction in readmission, that's why I asked that question.
So we have a dedicated MedRec team of technicians for patients who come to our ED, and we have a scoring system for those technicians to actually review the medications for those patients, to identify and confirm what they're actually taking, and look for recommendations to try to streamline the care from a polypharmacy perspective. We also do the same when patients are discharged from the hospital. We actually have a pharmacist review some of those orders that come out to make sure that the orders that were prescribed were appropriate for the patient, and were actually, there wasn't confusion about how the patient should take them from that perspective. And so I think those contribute to helping reduce polypharmacy, programs like your MedRec techs and the ED, the discharge orders from that perspective, as well as just our pharmacists in the pharmacies. When you have a complete view of the patient's full profile, they can also intervene and reach out to providers and say, hey, did you know, I just wanted to confirm, you sure you want this patient taking it? Did you know they're taking these other medications that may interact? Or you have 2 medications for blood pressure, are you sure you want to be taking them? So having the pharmacies be able to have view of the whole patient medical record really helps to reduce some of that as well. And I know we're partnering as well with the correctional health team, looking at their polypharmacy as well in ways that we can help with them too. In terms of the chart reviews, or we have a prioritization system through Epic. Yeah.
Or like an intelligence signal.
There's drug alerts that fire when you prescribe or even verify medications that alert you to where there may be duplicate therapy or there may be contraindications. And they still get through, and we still catch them as well. But yes, there is, I'm trying to think of the right word, but there is logic that sits there to help the pharmacist and the providers make sure that they're prescribing and dispensing appropriately to make sure that it's safe for the patient.
It's also one of our inpatient hospital metrics, high-risk medications too. So
I'm glad to hear it, because for me, it's like a better word, it's part of the standard of care. So.
Correct. Yeah.
Thank you.
Thank you, guys.
Today. I hope your brains are not hurting too much. Spoke with Dustin, and we had scheduled the meeting till 3, so we want to be respectful of people's time. So we are going to jump to the end and then go into closed session. for the last topic, and we will complete the rest of the information at Finance Committee in 2 weeks. We should be able to do that. Most of it's just information for the rest of the time. Does that work for everybody? There's a long conversation about technology that I'm afraid we would be here till 8 o'clock based on the energy in the room, so. So the next steps for the budget process, we have the retreat today, and then we have Finance Committee 2 weeks from today. And in Finance Committee, we'll show you the actual financial statements. We will complete the review of the other expenses, the non-operating. We'll talk about Tarrant County, and we'll talk about the debt and the capital spend. Pretty straightforward information. And then after that, the second green box you see up here, we will take a couple weeks with the team here at JPS, and then we'll do some small Board of Manager groups on the 16th and 17th of July. That means we have a couple of you, I kind of have open office hours, give you some times, and you come in when you feel like you can come in. We can talk about the budget, the questions you have. And then at the end of July, we will have another finance meeting to really go over where we are with the budget. It's kind of a draft approval at the end of July, because the first week in August, we have to send over materials to the county for review, posting on the 7th of August. We will have the board meeting on the 13th of August to do the draft approval, not the final approval of the budget. We'll do the budget hearing at the county on the 14th, and then we'll look for the final Board of Managers review on August 27th. That'll be a joint meeting. That is a Finance Committee date, but we will do a joint meeting that day on the 27th of August to do the budget approval. The tax rate will be then set in September. If there's something unexpected with the tax rate and we have to come back at the end of September, we would have another Board of Managers at the end of September to do a second revised approval. And so we're working through how the approvals will work right now, as we move forward with the budget. I just want to let everybody know what the steps are as we move forward. So with that, I would complete basically the open session of the budget retreat, and ask you, Mr. Chair, if you have anything before you close the meeting. Okay.
Yeah, at this time, we're going to close our open session, and we'll go into close in 5 minutes. 2 minutes.
Or 1 minute, as soon as they shut us off.
We're going to go back to our open session, and with no further business, I'd like to thank everybody for spending enormous time with us. The staff in the whole day.
Is dinner in the other room?
I'm sorry?
Dinner is in another room?
No, we have extra cookies for you, so we'll close the meeting.
Yeah, when we could have had dinner.